Anji, a very good evening, or good afternoon rather. So a very good afternoon to everyone, and it's a pleasure to connect with all of you once again through this channel, and it's absolutely amazing that we can sit, chat with each other and make the discussion as high yielding as possible, right? So, okay. Now, when it comes to TND, and before I actually start with the session, a few things that I would just want to tell you, because although I already wrote it on the chat, but yes, I would tell you. So yes, there is an image book which is uploaded on your app, right, within your course in the notes section. It has all the images that I will be discussing in the class as well. Okay, and after the class, I'll try and put the annotated version of the image book, and remove the only image book thing. So I'll put the annotated version, but I'll put it after the class. Okay. Secondly, I know we call it as NEET TND, but be rest assured that we would cover all important topics, even for INI-CT exam, right? So whatever is required, we would cover that. The most important thing is that, the test paper is completely made by me, which means I've taken every care that, when we are doing the test paper, we will be able to cover almost all of obstetrics through it, especially the topics which are most high yielding for the upcoming exams, right? Which means, okay, which means that you have to revise your obs through this test paper itself. So after the class, do an analysis, do a retrograde revision whenever you want to do obstetrics through this paper. Also, the discussion is going to be the most important thing, right? So it's not just about the question and the answer. So there are going to be a lot of things that we will be discussing, and that's why I said the discussion becomes the most important part. All right. And every option by itself has been made in such a way that it covers some or important other aspect of the topic as well. Okay. So how to take notes? You have to write down Disha. Okay. So you use plain sheets of paper, or you use a separate diary, whatever you've made. Okay. You can use a sheet of paper or a separate diary, and you can jot down the points that we will be covering with every question. Please ensure that you're writing in a format which is easy, which means just bulleted points, just key things. Remember, you've already studied, right? So you are supposed to learn with me how to approach the topic in a concise, crisp manner, and to ensure that these are the things about the topic that are must-dos even close to the exam, right? So on that note, are we all ready for the... Absolutely, yes, Anuj, why not? Right? The test papers have been uploaded for you. The names of the teachers are written for you, right? Still, you should definitely attend the discussion. Okay. So now we are going to, absolutely yes, for repeated revisions, you are supposed to do it through the TND paper beta, because that ensures that you're doing a retrograde revision. You're focusing on topics that have high probability of coming in the exam. You are focusing on things that are probably your weak areas, right? So analysis after the test paper also becomes very important. So we'll talk more about the revision part towards the end, but I think let's start off, right? And as I said, we will upload the annotated version of the images as well as the test later after the class. Okay? Chalo. I think it was a moderate level paper. I haven't made a very difficult one, and anything, above 50 should be a good score. If you are at 60 or above, that is very good. You should try and reach around 55 to 60 correct questions in every TND, because aap padkar aa rahe ho and then you are giving the paper, right? So that is why it is essential that try and target 55 to 60 or 60 plus if possible. So beyond 55 or anywhere between 55 to 60 is very good. 50 plus is also okay, but you need to buck up, and I'm sure you will. Okay? Chalo. No, everything that is required will be put on the app. Okay? So whatever you need is going to be uploaded on the app, nowhere else. All right? Because then you lose the advantage of it. Chalo. So let's start off. Everything that I'm going to do will be uploaded on the app, nowhere else. Okay, just on the app. Chalo, let's start off everyone now, and okay, just a moment. So let's look at the first question. Yes. And then each one of you will tell me whether you were able to do it right or not, right? And the paper is a mix of everything. There are some important one-liners, there are some clinical vignettes, there are images, there are everything together what you need, okay? So let's learn the approach. Yes. So now this is a woman who has come to us with 6 weeks of amenorrhea and there is bleeding, right? Now, whenever you talk about early pregnancy and bleeding, the first difference that you need to know from late pregnancy bleeding is, should we be doing a PV examination? Yes or no? Yes. So please remember, whenever it is early pregnancy bleeding, you must do a PV exam, okay, as well as an ultrasound, right? So this woman has come to us with pain and bleeding at 6 weeks of amenorrhea. The uterus is 6 weeks in size, the internal os is open and products of conception can be seen, right? Now, genuinely tell me how many of you marked it as incomplete abortion because you thought that we are saying products of conception are seen. So I want to know how many of you marked the answer as incomplete abortion, genuinely, okay? So yes, the answer here is inevitable abortion. Who is going to tell me what are the keywords that you will look for when you talk about inevitable abortion? So whenever you get a question on early pregnancy bleeding, abortion is one of the important DDs. Ectopic is yet another important DD. Okay, good. I want you to accept your mistakes so that you don't do them again in the exam. See, class is the best place to do all possible mistakes. Jitni karni hai, you should do it in the class, right? So let's see. The keyword here is os is open. So whenever you talk about early pregnancy and bleeding and we say os is open, there are only two possibilities, okay? So there are only two possibilities. It could be an inevitable abortion. Yes. Or it could also be an incomplete abortion. Okay, so these are the two places where the os is open, right? Now, most importantly, what is the difference between the two? How will you differentiate between the two? So in incomplete abortion, please remember there will be history of passage of POCs, right? So products of conception have been expelled. Whereas here there will be no history of passage. Now sometimes we will not use that exact word. History of passage may not be written. Then how will we write the same thing with respect to incomplete abortion? You know, they will very importantly say POCs are seen in cervical canal. Do you understand this? Not in the uterus. They are seen in the cervical canal because they are in the process of expulsion. Do you understand that? Whereas, as I said, the process of expulsion hasn't started in inevitable abortion, right? So please remember, don't confuse with POCs are seen. The important thing is where they are seen, right? So in incomplete abortion, you will see them in the cervical canal. Also, yes, the other way of writing it would be size of uterus. Right? So in inevitable abortion, the size of uterus will usually correspond to the period of gestation because nothing has been expelled out, right? Whereas in incomplete abortion, what happens is that some products have already been expelled. So what will happen to the size of uterus? Tell me. It will be less than the period of gestation. Yes? Also, the other hints that we will give you with incomplete abortion. What is the kind of bleeding that you will see in incomplete abortion? Heavy bleeding or mild bleeding? So that could be yet another way of putting it. So please remember, here the patient may actually have heavy bleeding because the process of expulsion has started. So she may be bleeding a lot, which is why we should know that incomplete abortion is the kind of spontaneous abortion which can actually present as what? Shock. That is an MCQ by itself. So they might ask you which type of spontaneous abortion can present as shock. The answer will be incomplete abortion. Is that understandable? Yes. So I hope now you understand why the answer is not incomplete abortion here. Okay. So whenever you get early pregnancy and bleeding, os is a key word, size of uterus is a key word, right? And the general physical characteristics of the patient could also be keywords. Now suppose we say os is closed. Then what are the possible DDs that we should know? So please remember, for os closed, the possible DDs can be missed abortion, right? It could also be threatened abortion. And it could also be a complete abortion, right? So when they say os closed, these are the three possible DDs. Who is going to now quickly tell me? Who is going to tell me? When we talk about missed abortion and threatened abortion, what would be the key word for you? What would be the key word? The key word for you to differentiate between these two would be cardiac activity. So in missed abortion, the cardiac activity is very importantly absent, okay? While in threatened abortion, the cardiac activity is present, right? So ultrasound is the best way to differentiate a missed abortion from a threatened abortion. Is that understandable? Also, because nothing has been expelled, right? What will happen to the size of the uterus? So now in threatened abortion, the uterine size will correspond to POG, but the more important thing is cardiac activity, okay? Also, in missed abortion, although nothing has been expelled, but the baby stops growing, right? So would the uterus keep growing? No. So here again, please remember that the size of uterus would be less than the period of gestation. Is that understandable? Right? What about complete abortion? The most important thing here is there will be history of expulsion. So history of expulsion of POCs is present in complete abortion. Okay, whereas when it comes to this, there is no history of expulsion, right? So there is no history of expulsion. That is very, very important. Yes, complete abortion in the initial stages may present as open os as well, because it totally depends on when the patient will come to you. So if she comes to you early, the os may be slightly open, but eventually it has to close down. So the most important thing would be closed os. In early stages, it may be open, right? So please remember, the key thing to differentiate will be history of expulsion. This is only present in complete and incomplete abortion. It is not there in missed abortion, threatened abortion, or in inevitable abortion. Yes. Also, please remember, in complete abortion, the history may be very characteristic. The girl may say that the bleeding and pain, okay, bleeding and pain reduce after expulsion. Right, so the bleeding and pain will classically decrease after she has expelled the products. And should I do an ultrasound in complete abortion? Yes. So the important thing here is, if you do an ultrasound in complete abortion, it will show what? Empty uterus, right? Which means all the products have been expelled. Nothing is remaining. That is why it is a complete abortion. Is that clear to everyone? Is that understandable? Okay. Now also, when it comes to remember incomplete abortion, we could make a clinical question where we are telling you, as I said, that the patient comes in shock, right? So if it is incomplete abortion and the patient is in shock, can you tell me what would you do here as management for the patient? Because that could be a separate MCQ as well. So please remember, the management obviously will include resuscitation. But that's not a specific treatment, right? So what is the specific treatment that you would want to do here? So you have to remember, you have to complete the process of expulsion. Okay, so you have to complete the process of expulsion. And this has to be done preferably by suction and evacuation. Right? So, jab tak aap complete nahi karoge, the patient will keep bleeding. So, you have to complete the process by taking the patient to OT by doing a suction and evacuation. Okay? Now, if I ask you, what can I do while I am shifting the patient to OT to improve her outcome? Right? So let's say it takes me 5 minutes to shift the patient to OT to do suction evacuation. What else can I do to improve the outcome or reduce the morbidity of the patient? What else can I do? So while you are shifting, can you do a digital evacuation from the cervical canal? Yes. So please remember, while we are shifting the patient to OT, so meanwhile we can do a digital evacuation. Please understand, when I say digital evacuation, it is only from cervical canal. So whatever products you can see in the cervical canal, we will try and remove that and the bleeding will reduce. You are not going to put your hand into the uterus to remove the products. It is only a digital evacuation from the cervical canal. From the uterus, you have to do suction evacuation. Is that understandable? Is that understandable? Obviously, whenever you go to OT, you have to give anesthesia to the patient, maybe in the form of local anesthesia or an IV sedation, right? That will also work. So resuscitation and a specific treatment. So please remember, types of abortions are important. They would repeatedly come in the exam in some form or the other, and it's a good, usually it will come as a clinical vignette, right? Is that clear? Yes. Please remember, anti-D has to be given. So as per our national guidelines, so let me make it very clear to all of you. Please understand, you will follow WHO, ACOG or whatever nonsense you want to follow only for places where we don't have our national guidelines. Whenever we have a national guideline, you have to follow national guidelines. Only when we don't have national guidelines, we'll tell you some things about WHO, something about ACOG. ठीक है? अगर national guideline है, तो national ही follow करना है. Okay? Otherwise, the question will ask you as per WHO or as per ACOG, right? So most of the times they will ask you, if they want to really ask you something, they will really mention it, and that holds true for INI-CT exam. Okay? So please remember this. As I said, anti-D has to be given. Okay, so anti-D has to be given after abortion as per our national guidelines. What is the dose of anti-D? So if the patient is Rh negative, you have to give anti-D. What is the dose? So please remember, at less than 12 weeks, the dose is 50 micrograms. Okay, the dose is 50 micrograms. Is that clear? Okay. Now, please understand, when we say that no, 300 micrograms is the dose that you give after 12 weeks. Okay. So, after 12 weeks, the dose of anti-D is 300 micrograms. Up to 12 weeks, the dose of anti-D is only what is required is 50 micrograms. Is that clear? Okay. Inevitable का मतलब है nothing has been expelled, but क्योंकि रास्ता खुल चुका है, whatever is there will be eventually expelled. ठीक है? So whatever is there will have to be expelled because the os is now open. So you can't stop it. That is what inevitable means. Is that clear? Yes, in all types of abortion. Okay, so in all types of abortion, anti-D should be given as per our national guidelines. Okay, if the patient is less than 12 weeks, then you can give 50 micrograms. Also, please remember, beyond 12 weeks, 300. As I said, only and only place where we may avoid giving anti-D is threatened abortion, but not as per national guidelines. Even in our national guidelines, we are giving anti-D to every patient of abortion. It is there in the abortion care guidelines of India. All right? All right. Chalo. Now, let's move on to the next question. It is not dependent on threatened hai ki nahi hai bache. It is dependent on the period of gestation. If it is less than 12, you need only 50 micrograms. If it is more than 12, you would need 300 micrograms. Okay? बच्चे, because POCs आपको इसलिए दिख रहे हैं क्योंकि you are able to see it inside the uterus because the os is open. Okay? Nothing is expelled. That is what you have to understand. Only if something is expelled, then it is incomplete abortion. So आपने ध्यान से सुना नहीं है. So you have to all listen very carefully. Is that understandable? Listen carefully. Most of your doubts would be sorted by that itself. No, as I said, you have to be giving anti-D in all types of abortion. The only place, if you have to choose between other options, right, then yes, maybe we can say we can avoid it in threatened abortion because the bleeding is very less. Otherwise, you're supposed to give it for all types of induced abortions. Is that clear? Chalo. So which of the following is not recommended? So the key word here is not recommended. Okay? In the prevention of perineal tears, right? So now, yes, were you all able to mark A or somebody marked C? Did you mark C? And somebody, did you do a silly mistake in D? Did you do a silly mistake in D? So please remember, the option D says episiotomy routinely is not to be done. Okay? It is not to be done, which is absolutely correct. Routine episiotomy is not to be done. Please remember, episiotomy is only given in some conditions. What are good examples for conditions where you give episiotomy? What are the some examples we give in where we give episiotomy? So please remember, in episiotomy, you are going to give it in places where maybe you are doing an instrumental delivery, like forceps delivery. Then you may give it in conditions like shoulder dystocia, and you may also give it in conditions like breech vaginal delivery. Okay, so breech vaginal delivery. How would perineal compresses help? So yes, we would give perineal compresses. These are warm perineal compresses. How would they help? So when you say warm compresses, what are they going to do? They are going to do pelvic muscle relaxation, right? So they basically cause muscle relaxation, which helps in what? Which helps in stretching, right? So it helps in stretching in the perineal muscles. So it reduces the chances of perineal injury. Are we supposed to give a perineal support? Yes. So now listen to me very carefully. In the hands-on technique, with the right hand or the dominant hand of the examiner, we are going to give a good perineal support. What do you do with the left hand? With the left hand, you are supposed to control the delivery of head. Okay, so you're supposed to control the delivery of head. And do you all remember that delivery of head happens by extension? Yes, so delivery of head normally happens by extension. So what do? You have to control it by giving a counter pressure, right? So you have to control the delivery of head by giving counter pressure. Yes, so please remember this, extension nahi karna hai. Extension is rather going to cause perineal injuries, right? So you control the delivery of the head by giving a counter pressure and trying to maintain the head in flexion, all right? And this ensures that these smaller diameters are going to come out, all right? So no, we don't do deflection of the head, okay? So now please remember, apart from this, what else can you do? Can we also do perineal massage? Yes. Okay, so please remember, we can also do perineal massage. Again, how would perineal massage help? Perineal massage will also help to relax the muscles, right? So perineal massage will also help to relax the muscles. So there is more stretching and there will be less trauma. Is that clear to everyone? Yes. So please remember these important things in order to prevent perineal tears. Now when we talk about perineal tears, despite everything, tear may happen. Yes. Now a few things that we must know with respect to perineal tears. So as I said, this image book is uploaded in the app for you. But at the same time, after the class, I will upload the annotated version as well. Okay? So now, this is the classification of tears that you should know for your exams, right? So what is a first degree tear? So a first degree tear is one that involves tear of skin and or vaginal mucosa, right? So tier of skin and or the vaginal mucosa. Okay, so that is a first degree tear. In the second degree tear, as you can see, what is supposed to be torn to call it second degree? It has to be the perineal muscles. So if the muscles are torn, it is a second degree tear. If we ask you, episiotomy corresponds to what degree tear? So it corresponds to a second degree tear, right? So episiotomy would correspond to second degree. What would happen in the third degree tear? So in the third degree, what is torn is the anal sphincter, right? So what is torn here is the anal sphincter. So if you compare the images, in second degree, the anal sphincter is intact, right? While in third degree, the sphincter is also torn, right? And on the basis of how much sphincter is torn, third degrees are divided into A, B, and C. What is 3A? Less than 50% of external sphincter torn. What is 3B? It is more than 50% of external sphincter torn. And what is 3C? What is 3C? When both internal and external sphincter are torn. Okay. What is a fourth degree perineal tear? So when we talk about a fourth degree tear, now the tear will also extend to the anal or rectal mucosa, right? So if the anal or rectal mucosa is torn, okay, then you will say that it is a fourth degree perineal tear. Is that clear to everyone? So fourth degree is tear of rectal or anal mucosa. Okay? So this is the sub-classification and it is important for your exams, right? Before I go to some of the other things, let's quickly look at some of the other important images. This is a very simple IBQ often asked in the exams. You know that this is an episiotomy scissor, right? So it is an episiotomy scissor and we have already considered some points about the episiotomy. Now I want to ask you, if at all you give an episiotomy, right? Which episiotomy are you going to give? Is it mediolateral or is it median? Mediolateral or median? So it has to be mediolateral, right? So this is something that is already uploaded. Don't worry about that. The only thing that I want you to remember with respect to the advantage of mediolateral episiotomy. What is the only advantage? The only advantage is that it will not extend into the rectal mucosa or the anal sphincter. So can we extend the incision? Because some students don't get the words correct. You have to identify the key words. Can you extend the incision of the episiotomy? Yes. So even when you extend it, it will not enter the rectal mucosa or the anal sphincter. Is that clear? Apart from that, everything else is not so good about mediolateral. For example, blood loss is more, okay? The chances of post-operative pain are more. Dyspareunia is more. There is a higher chance of wound dehiscence, okay? And because of the location, the apposition or, as far as how cosmetically good it looks, it is inferior, right? So these are all disadvantages. But yes, you can extend the incision without causing injury to the sphincter or to the rectal mucosa. Is that clear? Now, a few things that I want you to know. Number one, when we say mediolateral, can you tell me what should be this angle that your scissor makes with the midline? What should be the angle that your scissor should make with the midline? Anybody? What should be the angle? So please remember the answer has to be 60 degrees when the perineum is stretched. Okay. So when the perineum is stretched, your scissor should make an angle of 60 degrees with the midline. Second important thing. When I say the perineum is stretched, the head is visible, what is this specific time called as? So you give episiotomy, if at all you want to give it, at the time of crowning. So crowning क्या होता है? When the head is visible, in between the contractions also, it is stretching the perineum. So you will give episiotomy at the time of crowning. Okay. Can you tell me what muscles are cut in the episiotomy? Muscles. So please remember, do we cut bulbospongiosis? Yes. So what you need to know is that bulbospongiosis is same as bulbocavernosis, right? Do we cut istiocavernosis? No. So what we cut is bulbospongiosis. We will also cut the superficial and deep transverse perineal muscles. And I want to ask you, would we also cut a part of levator ani? So yes, sometimes we may cut a part of levator ani. Can you tell me which part of levator ani? So which part of levator ani would be cut? So if we are specifically asking you, it has to be pubococcygeus, right? So it has to be pubococcygeus. Is that clear? So these are the muscles. Apart from this, yes, you are cutting the skin, you are cutting the subcutaneous tissue, you are also cutting the pudendal nerves and vessels, okay? And you are obviously cutting the vaginal mucosa. But usually the question would be asking you, which of the following muscles is not cut in episiotomy? So remember the ones which are cut. Is that clear? Okay. Now when it comes to repair, yes. So please remember, when it comes to repair of episiotomy, what is the first structure you repair? It has to be vaginal mucosa. Okay. So the first structure we will cut is, repair is vaginal mucosa. Followed by this, you're going to repair the muscles, and followed by this, you're going to repair the skin. Whenever we talk about mucosa, remember it is continuous. So the sutures we take are continuous sutures. For muscles, we will take the interrupted sutures, and for skin, we would take the mattress sutures. Okay, so for skin, we will take the mattress sutures. Which is the most common suture material? So please don't answer it as catgut. So when we ask you the suture material for perineal repair, whether it is episiotomy or perineal tears, you should answer it as vicryl. Okay, so the most common suture we use is vicryl. Okay. Also, when it comes to third and fourth degree perineal tears, the ones we were talking about previously, right? So when we talk about the third and the fourth degree tears, remember they are together also called as what? They are called as complete perineal tears. Okay, when should you repair them? Repair them within 24 hours. So ideally they should be repaired immediately. And what is the meaning of immediate? As early as possible within 24 hours, right? They are repaired in OT under anesthesia. Okay, and we will usually give a regional block. You don't need a GA for it. Is that clear? You don't need a GA. You will do it under a regional block. What is the first structure you repair? The first structure now you repair is rectal mucosa, then internal sphincter, then you will repair the external sphincter, then you will repair rest of the structures just like episiotomy. Okay, as I said, mucosa is always continuous. Okay, so mucosa is always repaired with continuous sutures. What about the sphincters? The sphincters are repaired in the form of end-to-end anastomosis. Okay, so they are repaired in the form of end-to-end anastomosis. The suture material remains as vicryl. Okay, now if you are not able to repair them in 24 hours, then when do you repair? So suppose the patient comes late right? And there are no signs of local infection. Then when do you repair? So if not done in 24 hours, okay, so if you couldn't repair it in 24 hours, then you will repair at around 2 to 3 weeks. But please remember, this is done provided there is no local infection. If there is a local infection, then we will do a delayed repair at 3 months, right? So if there is no local infection, then we now prefer to do early repair, which is done around 2 to 3 weeks. Is that clear? 3 months if there is evidence of local infection. Clear? Otherwise, the patient remains what? The patient remains fecal incontinent, right? And which is not good for the patient. Okay? So these are must know things about perineal tears as well as episiotomy. Okay? Chalo. Let's move on to the third question. Everyone ready for the third question? Okay, let's look at the third MCQ. The third MCQ says, no, Agastya, you are not making the MCQs. Let the faculty do that or let the examiners do that. See, the problem arises when you start framing MCQs, then you actually not only confuse yourself but others as well. So relax, let us mark, right? Give you the options and then you answer, right? So as I said, nowadays we prefer to do early repairs unless there is an infection. You can repair it as early as 2 weeks. You could repair it at 3 weeks as well, okay? So, which is a true statement? So, what is a true statement? Yes, so the only true statement here is that it can cause meconium aspiration syndrome, right? Now, first we will see why other options are wrong, then we will move on to other things about obstetric cholestasis. Yes, so what is wrong with option A? It does not present in the second trimester. It actually most commonly presents in the third trimester. Okay? What is wrong with option C? Raised alkaline phosphatase is never diagnostic. So please remember, raised alkaline phosphatase is a physiological change. It is released by the placenta. And therefore, the levels of ALP are actually 5 times the higher values or normal values. Okay, so the levels of ALP in pregnancy are 5 times the normal values, and therefore you cannot use it as a diagnostic test. It is a physiological change. So placenta releases placental alkaline phosphatase. Okay. And what is an important thing about placental alkaline phosphatase? This is actually the only heat stable form of alkaline phosphatase. Okay? Then, what is wrong with option D? So, delivery is not done at 40 weeks. What is the preferred time? 37 to 38 weeks. Right? So, we will usually deliver these patients between 37 to 38 weeks. Okay, now coming to what else are you supposed to know? So when I say alkaline phosphatase is not diagnostic, then what exactly is the diagnostic test? What is the diagnostic test? So remember, the diagnostic test for obstetric cholestasis is what? Yes, it is serum bile acids. Right? So it is actually serum bile acids. So although this is the diagnostic test, you should know what are the liver function abnormalities. Okay, quickly answer these questions because they're all important. Will you see a raised bilirubin? Yes, okay. But what you have to remember is not that you will see raised bilirubin. You have to remember that these are mild elevations. The levels are usually going to be less than 5. Also, I want to know from you, how is this bilirubin different from the bilirubin that you see in HELLP syndrome? So in HELLP syndrome, what you see is hyperbilirubinemia, which is again mild, but what kind of bilirubin is that? So that is unconjugated, right? Here, what kind of bilirubin is raised? Conjugated. Okay, so here it is going to be conjugated or direct. Is that clear? So here it is conjugated. In HELLP syndrome, it is unconjugated. Okay. What about liver enzymes? So if I ask about ALT, AST, what about the liver enzymes? So they are also mildly raised. Okay. So they are also mildly raised. Is that clear? So they're not severe elevations. There are mild elevations. Is that clear to everyone? Okay. Now, the important thing is how does it present? So please remember, if I ask you what is the most common presentation, what would be your answer? So most common presentation is pruritus in the third trimester. And you know, most of the times the NEET PG people are asking this. They will give you a very characteristic history. So if you identify the clinical history, things become easy. So NEET is usually giving these questions in a clinical format. So please remember that the pruritus initially is going to be only on palms and soles. Gradually, it will extend to the other parts of the body. So initially, it's only present on the palms and soles. That is the first thing. The second thing, at the time when the woman has pruritus, will she have liver function abnormalities? So no. Please remember, pruritus begins first. LFT's derangement will be seen 1 week later. Okay, so pruritus will actually appear first and liver function abnormalities will only be seen 1 week later. So you might have to repeat the test. Yes, the pruritus is classically more at night. Okay, it is more at night. It is initially only on palms and soles. Okay, gradually, yes, it will happen or spread to the other parts of body as well. Now I want to ask you, apart from this, can you tell me what are risk factors for obstetric cholestasis? Because these are also important questions. What is a risk factor? So, is previous history of obstetric cholestasis a risk factor? Yes or no? Yes. So, a previous history is a very important risk factor because the recurrence risk is 60 to 70%. Okay, so it's an important risk factor. Then conditions when the estrogen levels will be higher. Okay, so for example, multi-fetal pregnancy is also an important risk factor. Okay, is that clear to everyone? Then please remember, when we talk about obstetric cholestasis, it is classically linked to estrogen more. Now, if you have attended my classes, I always tell you that all the physiological changes of pregnancy are actually brought by both E and P, right? So, whenever we have to mark one, usually the best answer is progesterone. There are very few places where the better answer becomes estrogen. So, please remember that for obstetric cholestasis, it is actually estrogen. Now, you people are confusing what? Acute fatty liver with obstetric cholestasis. Acute fatty liver is what is seen with male baby bacha, not obstetric cholestasis. Obstetric cholestasis is more with actually female fetus. Okay, so you are confusing it with AFLP. Okay, so please remember this. Then can it have a genetic predisposition? Yes, it can have a genetic predisposition. The gene that I want you to remember is ABCB4, right? So ABCB4 is a better answer than ABCB11. Both are risk factors, but the single best would be ABCB4. So remember, these are other important things which you should know with respect to obstetric cholestasis. Also, obstetric cholestasis is more of a problem with the fetus as compared to the mother. The mother usually only has what? Has pruritus, okay, which can be intense. Who is going to quickly tell me what are the possible fetal complications? So can it cause a sudden stillbirth? Yes. Can it cause prematurity? Yes. Can it cause meconium aspiration syndrome? Yes, as well as respiratory distress at birth, right? So it can cause meconium aspiration syndrome or respiratory distress at birth. Now, agar koi in general aapse पूछे, what is the reason for all the fetal complications? Then please remember the single best reason is increased bile acids. So bile acids not only are high in the mother, they are high in the amniotic fluid, they are also high in the fetus, right? So please remember, stillbirth का कारण क्या होता है? Sudden cardiac arrhythmias, and they will cause a cardiac arrest. And the reason for arrhythmias is these bile acids, right? So the cause of stillbirth is fetal cardiac arrhythmias. What is the cause of prematurity? So again, bile acids high in the amniotic fluid, and these bile acids are uterine irritants. So what do? They make the uterus go into contractions. So they are basically irritants. That's why they're causing itching as well. Why, mass? Because high bile acids are also present in the amniotic fluid, and the baby is going to swallow, right? So when the baby swallows it, the bile acids reach the bowel, there is peristalsis, there is passage of meconium. Is that understandable? Yes. So sabka karan ek hi hai, which is raised bile acids. Lastly, I want you to tell me what is the drug. What is the drug of choice for obstetric cholestasis? So I think everyone knows. So ursodeoxycholic acid. But the question that I will rather ask you is, ursodeoxycholic acid definitely improves pruritus in the mother. I want to ask you, will it improve? Okay, will it improve the fetal outcome? Yes or no? So yes. So please remember, ursodeoxycholic acid improves fetal outcome as well. Why? Because it is going to reduce the serum bile acids, and all the complications were because of serum bile acids. So not only will it improve pruritus, but it will also improve the fetal complications. Is that clear to everyone? So the drug of choice is going to be ursodeoxycholic acid. Okay? So important for NEET PG. See, as far as difference between NEET PG and AIMS or INICT is concerned is, NEET PG needs more depth, more topics, more wider range of topics are asked in NEET PG exam. They may not go to a lot of depth, but the width is more. As far as INICT is concerned, you all have to remember, they have some key topics. Okay, so the width is less for INICT, but INICT will typically ask the same topics in more depth, right? They will go into tiny details of it and ask you about it, right? So this is the difference, but the key topics remain the same. So wherever I feel, that this is an important topic, I will necessarily cover the depth as well, and definitely through the paper we are covering the width as well. Okay, chalo, ready for the next one, everyone? Okay, so which of the following statements regarding anemia in pregnancy is not true, right? So the question is not true. So let's look at this. Is option 1 correct? Iron deficiency anemia is the most common one? Yes. Okay, this is a true statement. So among the pathological forms of anemia, the most common is IDA. Okay, then for prophylaxis, Government of India recommends 60 milligrams of elemental iron for 180 days during pregnancy and 180 days postpartum. True? Yes, this is also true, and they are all individual MCQs. We will cover more about it, but they are all individual MCQs. The total iron requirement in pregnancy is 1000 milligrams. True. So आप समझो कि सारे options मैंने एक देख के खुद बनाए हैं to ensure that the options themselves are covering MCQs. So when you revise the paper, okay, you have to revise every option of my test paper. That's how you will not do any MCQ of obstetrics wrong. Okay, is that clear? Yes. So severe anemia in pregnancy should be treated with blood transfusion irrespective of POG. This is the closest to correct answer. Okay. Now please remember, what is the wrong here? What is the wrong thing here? Irrespective of POG. Right? So it looks like a true statement unless you read the last line. Okay. So what is the last line? Irrespective of POG. So we'll start with option D itself. Okay. Can you tell me when we say severe anemia, how do you define it? Severe anemia in pregnancy is hemoglobin less than 7 gram%. Yes, so less than 7 gram% is severe anemia. But what is the management? The management is dependent on the degree and the POG. Okay, for example, we will divide it into two parts. Is it less than 5 gram% or is it between 5 to 6.9? Okay, that's what our National Anemia Mukt Bharat Abhiyan says. So this treatment is on the basis of Anemia Mukt Bharat Abhiyan. Okay, now if the level is less than 5 grams, only then you say that management is blood transfusion irrespective of POG. Okay, but if it is between 5 to 6.9, then it actually depends on the POG. How do we say? So we say if the POG is more than 34 weeks, then yes, give blood transfusion. Whereas if the POG is less than 34 weeks, then we will give parenteral iron. So anemia का treatment आप सबको आना चाहिए. It is important. So this is with respect to severe anemia, right? Who is going to tell me, apart from severe anemia at more than 34 weeks and severe anemia which is less than 5 grams at any POG, what else will be an indication for blood transfusion? Anything else that you can think is an indication for blood transfusion? So one indication is here. Second is here, hemoglobin less than 5. What is the third indication? The third indication of blood transfusion is any hemoglobin, but if patient has signs and symptoms of either impending heart failure or is already in heart failure. So if your patient has features of heart failure, maybe impending or obvious features of heart failure, then no matter what the hemoglobin level is, the answer will remain as blood transfusion. Is that clear? So please remember this. Okay. Then severe anemia which is caused by blood loss. So then we are not talking about IDA. I am actually talking about IDA. आप लोग जो answer कर रहे हो वो everything else other than IDA, right? So please remember this. Severe anemia, which is, because of blood loss, obviously has to be replaced by blood. But here I am talking about conditions or indications of BT in IDA. Is that understandable? Yes. So anytime your patient has signs and symptoms of heart failure. Now coming to important thing. The second aspect will be if my patient has mild to moderate anemia, right? So hemoglobin level is between 7 to, let's say, 10.9, right? So this is mild to moderate anemia. Then how do you decide the treatment? So please remember, okay, so please remember, number one, if your patient has mild to moderate anemia, the treatment plan usually depends on POG. Okay? So if the POG is beyond, so first, let's say less than 34 weeks. Okay? So if the POG is less than 34 weeks, then you have to begin treatment with oral iron. Okay, so you have to begin with oral iron. Doubt, can you give oral iron? Okay, can you give oral iron in first trimester? So what if your patient has first trimester anemia? So then can you give oral iron? Yes, so please remember this. First trimester anemia, treatment will be oral iron. Okay, but if they say there is severe anemia, the patient has heart failure, then obviously the answer will change to blood transfusion. But if it is severe anemia, then the treatment is going to be, anemia in first trimester, the answer will be oral iron. Okay, आप लोगों को बहुत सारे बेसिक्स नहीं आते हैं बच्चे, so please ध्यान से सुनो. There is no point trying to learn updates when we are doing the basics wrong. Okay, stop running after updates. वो actually आपको डुबाते हैं, right? So all the people who keep asking for updates is only, what others are trying to do is only and only play with you, right? So don't change your focus to updates. Stay focused to basics and application of basics. Otherwise, you will do wrong, very gross mistakes. So please remember, first trimester oral iron can be given. The only reason is that we are not giving it as prophylaxis is because it causes gastritis. And anyway, nausea and vomiting is more in the first trimester. Okay? So oral iron dena hai, theek, which is being given for treatment. Is that clear to everyone? Whenever we say oral iron for treatment, what is the dose? What is the dose? Now the tablet has to be 1 BD, not 1 OD. It has to be twice a day. Is that clear? It has to be twice a day. Okay? Then please remember, if the patient is beyond 34 weeks, okay? So if your patient is beyond 34 weeks or shows non-compliance to oral iron, or she has what? Or she has malabsorptive syndromes, or if she has intolerable side effects to oral iron. Okay? So now understand this. We are saying your patient has mild to moderate anemia, but if she has any of the things, what? She is beyond 34 weeks. She is showing non-compliance to oral iron, or she has malabsorptive syndromes, or she has intolerable side effects to oral iron. In all these conditions, what does your answer change to? Yes. Now your answer changes to treatment will be by parenteral iron. Okay, so the treatment will be by parenteral iron. Okay, the drug of choice here is iron sucrose. Okay, the drug of choice here is iron sucrose. Is that clear? So iron sucrose is given as an IV infusion. It's not IM. It is an IV infusion. Is that clear? So that is the drug of choice. Also, please remember, before starting parenteral iron, okay, before starting parenteral iron, we must stop oral iron. You cannot give both. It will cause toxicity. So you have to first stop oral iron and then you can plan to give parenteral iron. Also, please remember, parenteral iron is contraindicated in first trimester, right? So parenteral iron will not be given in the first trimester. It is only to be given beyond 12 weeks. Is that clear to everyone? Yes? So these are some of the very, very important things that you should know with respect to treatment based on the hemoglobin levels. Okay? Now, let's look at some of the other options. So we said total iron requirement in pregnancy is 1000. Isme se sometimes we will ask you, okay? Sometimes we will ask you, what is the iron required by the fetus? Okay? So what is iron required by the fetus? And maybe placenta. So if they ask about iron required by the fetus and placenta, then what is the answer? Then the answer is going to be 300 milligram. Okay. So out of the total, it is going to be 300 milligram. ठीक है बच्चा? Is that clear? Okay. Then sometimes they will ask you iron requirement in the third trimester of pregnancy? Okay, sometimes they'll specifically ask about third trimester of pregnancy, then it is almost about 6 to 7 milligrams per day. Okay, so it is almost around 6 to 7 milligrams per day for the third trimester. Okay, now please remember, what salt do Government of India use in the IFA tab? Anyone? So it is going to be ferrous sulfate, right? So the salt is ferrous sulfate. It's a 60 milligram tab. What else are we going to do as a part of prophylaxis? Okay. What else are we going to do as a part of prophylaxis apart from supplementing iron tabs? So please remember, in the prophylaxis, we are also going to give what? Albendazole tab. This has to be given in the second trimester. Okay. What is the dose? 400 milligram, and it's a single dose. Okay. So 400 milligram, and it should be a single dose, right? Also, please remember, when we talk about folic acid dose, okay, so that's what I said. We are asking very basic things as well. So please remember, in the IFA tab, it is 60 milligrams of elemental iron and 0.5 milligrams of folic acid. Okay, it is 0.5 because this is the RDA of folic acid in pregnancy. Okay, so this is the RDA in pregnancy. So the dose is 0.5 milligrams. Okay, what should be the time gap between iron and calcium tabs? So what should be the time gap between iron and calcium tabs? So there should be a gap of 2 hours. Okay, so there should be a gap of 2 hours between the iron and the calcium tablets. Okay, calcium tabs are also distributed by the Government of India. Kitne ki hoti hai wo tab? 500 milligrams. Yes, and we are giving it twice a day. Okay, so 500 milligram tab, which is given twice a day. Check. Is that clear to everybody? No, not 30 minutes. There has to be a 2-hour gap between the iron and the calcium tabs. Okay? Chalo. So these are things that are must do's or must knows. Okay? Now, let's go on to the next question. In the process of MTP done by suction and evacuation, it was realized that perforation of the uterus occurred with the cannula. Okay. So, Nidhi, we are supposed to give prophylaxis only in the second trimester. Treatment has to be done in the first trimester itself. Okay. So, when you talk about IFA tabs as prophylaxis, bache, this is to be done beyond 12 weeks. When you talk about treatment, then you can treat even in the first trimester. If the patient is anemic, you don't have to wait. You have to start the treatment in the first trimester itself. See? Yes. So the answer is going to be laparotomy with exploration of the bowel. Right? Which cannula are we talking about here? So we are talking about the Carmen's cannula. Right, and we will just see the images and we will talk about it in a moment, right? So we are talking about the Carmen's cannula. So please remember that if there is a perforation with a cannula while the suction machine is on, the management has to be laparotomy or laparoscopy, whatever is available. Okay, so whatever is available, laparotomy or laparoscopy has to be done. This is different from if perforation happens with Hagar's dilator. Then what is the management? Suppose in the MCQ they say perforation happens by Hagar's dilator. Then Hagar's dilator is a blunt instrument, right? So for this, the management is actually wait and watch and monitor the vitals. Okay, so wait and watch and monitor the vitals because it is a blunt instrument. Is that clear to everyone? Whereas with the cannula, it is going to be what? Yes, it has to be a laparotomy or a laparoscopy. See? Now also, can you tell me what is the pressure generated with the cannula? The pressure in suction evacuation is 600 millimeters of mercury. Okay, it is going to be 600 millimeters of mercury. And can you tell me What is the size of the cannula we use? Anybody, what is the size of the cannula? So size of cannula will correspond to the size of period of gestation or uterus, whatever they might give you, right? So it will correspond to the size of the uterus or period of gestation. But when they ask you Hagar's dilator, right, the dilatation is done usually up to 1 less than the POG. Right, so dilatation that we do is usually 1 less than the POG, but the size of the cannula has to correspond. The idea is that अगर हम बहुत ज़्यादा dilatation कर देंगे, then the cervix will not hold the cannula tightly. It has to tightly hold the cannula. Only then the pressure can be raised. Right? So please remember, as far as cannula is concerned, it has to correspond. Whereas when we talk about dilatation, it is usually 1 less than the period of gestation. Okay, is that clear to everyone? Also, when we talk about, using a Hagar's dilator, how can we prevent a perforation with this? So if we are talking about Hagar's dilator, how to prevent perforation? So please remember, for prevention of perforation with Hagar's, number 1, you have to hold it in a pen holding manner. Right, so you have to hold it in a pen holding manner. And the most important thing to prevent perforation is what? Assess the size or the direction of the uterus by a PV exam. So before you do suction evacuation, okay, so before starting the procedure, we must do a PV exam in order to confirm the direction of the uterus. So whether it is anteverted, whether it is retroverted. So we must do a PV exam to look for the direction. This will ensure that the chances of perforation are less. Also, in order to reduce the perforation, do you all know that these days, instead of Hagar's, what can we use with suction evacuation which can cause dilatation? So these days we are replacing tab misoprostol. Okay, so nowadays we are replacing tab misoprostol with Hagar's dilator. So what you do is you will put 400 micrograms per vaginally 4 hours prior to procedure. Okay, so 400 micrograms can be put per vaginally 4 hours prior to the procedure. So it actually opens up the os, and now there is no need to do a dilatation. So now you can proceed with the insertion of the cannula even without dilatation. Okay. So what is the other advantage? Will we need to give a paracervical block now? No. So once you put misoprostol, there is no need of paracervical block. There is no need of Hagar's dilator. So otherwise we were giving a paracervical block and then we were putting the Hagar's dilator. Is that understandable? So now we can use a combination, misoprostol with suction and evacuation. Is that clear to everyone? Okay. I want you to see some of the images here. For example, this is what is the image of Carmen's cannula. I'm sure this is an easy image, but it is a very important IBQ, right? So this is the image of the Carmen's cannula, and these are the openings that you can see in the cannula through which the products are sucked in. I want to ask you, suction and evacuation can be done up to what POG? Up to what POG can we do it? So the answer is 12 weeks. Because beyond that, the bones are formed, right? And they will obstruct the cannula. So as per our national guidelines, suction and evacuation can be done up to 12 weeks. Is that clear to everyone? Yes. So you should be able to identify the cannula. And remember that one of the important uses of cannula would also be for what? Can I also use it for incomplete abortion? Yes. Do you remember I just told you a little while ago the incomplete abortion is completed by suction and evacuation. Are we going to use it? No, color is not important, bhai. Okay. Are we going to also use it for molar pregnancy? Yes. We would also use it for molar pregnancy. So incomplete abortions, molar pregnancies, suction evacuation, as well as, do you all know that we can use it for endometrial biopsy in non-pregnant state? Yes. Okay, so we can also use the Carmen's cannula for endometrial biopsy. Is that clear? Okay. What is this an image of? Can you pick up? So this is the image of paracervical block, right? So this is an image of paracervical block. So now we want to let you see here that the block should not be given at 3 and 9 o'clock. So you are not going to give it at 3 o'clock position, not going to give it at 9 o'clock position. Why? The reason is because at 3 and 9 we have descending cervical branches of the uterine artery. Right? So you have descending cervical branches of uterine artery. So we'll not give it at 3 and 9. You can either give it one level below it, like 4 o'clock and 8 o'clock, or you can also give it one level above. So you can also give at 2 and 10. So one level below or one level above, but not at 3 and 9, right? And remember, the reason for paracervical block is because dilatation is painful. So if you will put Hagar's dilator, it causes pain. So pehle you have to give a paracervical block. Is that clear? Okay. Do we use paracervical block in labor? So no, generally not. Remember, paracervical block is notorious, and if given in labor, it can cause fetal distress. Okay, so it can cause fetal distress. So we are not usually using paracervical block in labor. So we are primarily using it for the process of abortions. Okay, is that clear? Okay. We will talk about different methods of abortion as we go forward. There are different MCQs where we'll cover different things, but these are some of the important things that you should know, that there is a perforation. Okay, in the same question, suppose they give you a clinical case scenario. What words would be written in the MCQ that will tell you that there is a perforation? What words will tell you that there is a perforation? Anybody? So if the MCQ says there is a sudden loss of resistance. Okay, so if the MCQ says there is sudden loss of resistance, if the MCQ says the vitals of the patient are deteriorating, if the MCQ says the bleeding increases, or if the MCQ says you can actually see omentum and fat, right, coming out of the vagina. So in rare cases, you may even see omentum hanging down from the vagina. So you have to begin resuscitation, you have to put the patient in Trendelenburg position, and you have to immediately start laparotomy or laparoscopy. Okay, is that clear? Yes. So if the patient is not sedated, then yes, she will complain of pain as well. But this is more of a condition where the patient is sedated, right, or is given some type of anesthesia. So she may not be able to complain. So you have to know. And very importantly, what sign? Your cannula can go to more deeper depth. Okay. So cannula can go to more deep depth. All right. So these are important things. So if they make a clinical question, they will use these words, but what they will ask will be very similar to what we've discussed. Okay. Chalo. So now, as I said, we will talk about different methods. So which of the following is not a method? Right. So now we are asking you, which of the following is not a method? Then so let's see if you did some mistake here. So please remember mifepristone and misoprostol. Yes, we all know our methods of first trimester abortion. right? So first we will talk about second trimester methods, and then I will talk about MIFI and MISO, what you need to know, right? So what is the most commonly used method for second trimester abortion? So please remember, most commonly used for second trimester abortion is what? It is going to be prostaglandins. Okay, it's prostaglandins. Among prostaglandins, the most common is misoprostol. Okay, what dose of misoprostol bache do we use for second trimester abortions? So remember, the dose is 400 micrograms. We are going to put it per vaginally every 3 to 4 hourly for a maximum of 5 doses. Okay, so most common is miso. But what are the other prostaglandins that can be used? We can also use PGE2. Remember, miso is PGE1. So we can use PGE2 also. We can use PGF2 alpha also. Okay, but most common is miso. Now, after prostaglandins, what is the other method for second trimester abortion? So yes, we can do an intraamniotic hyperosmolar saline, or we could use extraamniotic. This is also important for INI set exams. Okay, so please remember this. Or we can use what? Extraamniotic ethacridine. It is approved by Government of India. Okay. Fourth, we can also use drug like oxytocin. But please remember, oxytocin is least preferred. Who is going to tell me why is it least preferred? Because the uterus is not really sensitive this early. The receptors are really less, right? So receptors will increase at term. So oxytocin can be used, but it is least preferred. Okay. When it comes to second trimester abortions, what surgical method do we use? Again, students do a lot of mistake. The answer is D and E, not C. Okay, it is D and E, dilatation and evacuation. Now understand the concept. You get confused. Please remember, D and C, okay, is different from D and E. D and C was earlier used as a method of first trimester abortion. Not used now, but earlier it was used. It is never used for second trimester. Earlier we were using it for first trimester abortions. Now we are not. Now the only method which is surgical method in the first trimester now is suction and evacuation. So abhi we use suction evacuation, but pehle DNC bhi karte the. Is that clear to everybody? Yes? Okay. Now, when we talk about first trimester abortions, very, very important because there is an update now. So please remember, in first trimester abortions, when we talk about medical abortion, using MIFI and MISO, up till what POG can you use this? Because I don't want any confusions. Up to what POG? The answer is up to 9 weeks. Okay, so the answer is up to 9 weeks. Now earlier we used to say there are 2 different doses. Up to 7 weeks there is a different dose. Up to 9 there is a different dose. But now there is an update. Okay, and as per the update which has come in April or March this year itself, which is called as the Abortion Care Guide, please remember this. In our national guidelines, now there is a single dose that they are recommending. So the dose for mifepristone, which is given on day 1, is 200 milligram, single dose, and the route is oral. On day 3, now there is only one recommendation, which is 800 micrograms. Now there are no divisions into up to 7 and 7 to 9. So now when you get a question, there was earlier a confusion. Should we answer based on 7 weeks or should we answer based on 9 weeks? So now there is no confusion. You have to simply answer it as 800 micrograms. Okay. And this is usually put per vaginally. But please remember, we can also give it subcutaneous, oral, as well as sublingual. Those routes can also be given and the dose remains the same. It is 800 micrograms, right? More commonly, what is used is per vaginal. Is that clear to everyone? So no more confusions. What was the earlier dose route? Earlier, before the update, what was the dose? So earlier the dose was that up to 7 weeks, you should use 200 milligrams of Mifi and 400 micrograms of Mizo. And then we used to say from 7 to 9, this remains at 200 and this remains as 800. Please remember, the sole idea of medical abortion is that it can be done outpatient, right? So it can be done on an outpatient basis. That's the sole idea of medical abortion in early pregnancy. So now there is just one guideline, but the guidelines definitely say that after giving misoprostol, okay, we can keep, okay, can hai, mandatory nahi hai, we can keep the woman under observation for 4 hours. Why? Because this is the time when she is going to bleed and expel. So please remember, bleeding and expulsion happen after misoprostol, not after mifepristone. So you can keep the women under observation for 4 hours. Is that clear? It is not mandatory though. See? Also remember, what is the other name for mifepristone? RU486. Okay, so the dose for mifepristone is the other name is RU486. What category drug is mifepristone? Do you know? Anti-progesterone. Yes, so it's an anti-progesterone. Mizo, you all know, is PGE1, right? So Mizo is PGE1, while mifepristone is anti-progesterone. Please remember, okay, so please remember what I am saying very carefully. Is ultrasound mandatory before you do a medical abortion? The answer is no. So listen to these points carefully. Ultrasound before or after the procedure is not mandatory. You will only do it if there is a need. Okay, otherwise it is not mandatory. See? And as I mentioned, most of the times the bleeding and expulsion will happen after tab miso. Another one, what about methotrexate? So please remember this, methotrexate is definitely approved by WHO for first trimester abortion, but it is not in the Government of India guidelines. We are not to be using methotrexate. Okay, so we, as per our national guidelines, are not going to use methotrexate. So please don't say WHO says this. मैंने बहुत clearly पहले बोला है, wherever you have national guidelines, you have to follow national guidelines. Is that clear? Okay, perfect. So these are important things that you should know about methods used in first trimester and methods used in second trimester very, very clearly, so that you don't do anything wrong. What about hysterotomy? Hysterotomy is last resort for second trimester abortions. When the os doesn't open up by any method, not by drugs, not by surgical methods, if the os is very tightly closed, then yes, we can do a hysterotomy, cutting open of the uterus to remove the products. And it is to be done in the second trimester. Okay, is that clear? Yes, second trimester abortions are all inpatient. You have to keep the patient in the hospital. Okay, so please remember this. Second trimester abortions are inpatient abortions. The patient has to stay in the hospital. Okay? Chalo. Let's go on to the next one. So in which of the following vaginal delivery is not possible? Hanji. So what is the answer for this one? What is the answer? Is it possible in brow? No. So it is not possible in brow. Is it possible in left mento-posterior? It is not possible in left mento-posterior. Is it possible in occipito-posterior? Yes. Breech? Yes. So the answer will be D, right? So please remember, in brow presentation as well as in mento-posterior, there is no role of what? There is no role of vaginal delivery. Now please remember one thing very carefully. When we talk about mento-posterior, भाई कैसी बातें पूछते हो कुछ बच्चे, प्लीज डोंट आस्क सम थिंग्स ओनली फॉर द सेक ऑफ इट. Somebody is asking for suction evacuation, do we keep the patient in hospital? Obviously, will you go to her home and do suction evacuation? है ना, थोड़ा सा सोच कर पूछेंगे बच्चे. Suction evacuation is an OT procedure. Where will you do it if not in the hospital? हाँ, you won't go to her home to do it, right? So please remember, when the question is mento-posterior in labor and they are asking you management. Okay, thank you Nidhi, that's really sweet of you for reminding me. So when the question is very general, mento-posterior in labor, okay, then what is the management? It is a simple question. The management has to be cesarean. But if they be specific and they say mento-posterior in early labor. Early labor ka matlab hai, she is still in the latent phase. Now when we say she is in early labor, then the answer should be wait and watch. Because most of this mento-posterior will convert into mento-anterior. Okay, so this is important. Similarly, the MCQ stays for brow, right? So if it's a general question like brow in labor, then the answer will also simply be cesarean. But if they specify brow in early labor, which again means what? Latent phase, then again the answer is wait and watch. Because the brow can convert into vertex and it can also convert into face presentation. Okay? Now with respect to these positions or these things, remember certain other questions. For example, let's see if you can quickly give me answers. When you talk about brow presentation, can you tell me what is the engaging diameter? What is engaging diameter? No, Harishka, ultrasound is not mandatory beta. Okay? Ultrasound is only to be done if you are suspecting, let's say ectopic or molar, right? If you're suspecting something abnormal, then yes, do an ultrasound. Similarly, after the procedure, if you suspect that maybe the process is not complete, maybe something is retained, then yes, you do an ultrasound, but not as a routine procedure. Okay? Yes. So engaging diameter here will be mento-vertical. And yes, it is 14. What is the clinical importance? That it is the largest fetal head diameter. Right? So this is the largest fetal head diameter. So mento-vertical. Who is going to tell me what is the engaging diameter in face presentation? Anybody? What about face? So in face presentation, it is submento-bregmatic. Okay, it is submento-bregmatic. What is the answer? 9.5. Okay, 9.5 centimeters. So remember it, this one for face as well as for brow presentation. We will talk about OP and breech separately. So don't worry. We will talk about OP and breech separately as well. But you must know these engaging diameters. Okay? Okay. Who is going to tell me face presentation is a DD for which type of breech presentation? Anybody? So this is a DD for frank breech, right? So face presentation is a DD for frank breech. Is that clear to everybody? And what is common to face and brow? The head is in extension. So remember, in face, the head is in complete extension. Whereas when you speak about brow presentation, the head is in partial extension, है ना? So in brow, the head will be in partial extension. So these are the other things that they might want to ask. They want to know the head, whether it is flexed or extended. They want to know the engaging diameters, and they grossly want you to know whether a vaginal delivery can be done or not. Also, if I talk about one important one-liner with respect to face presentation, and we ask you, what is the most common? Okay, no Ritika, it is not deflexed bache. Deflexed is the answer for occipito-posterior. Okay? So what is the most common cause of, okay, what is the most common cause of face presentation? What is the answer here? So please remember, this is very specifically to be answered as anencephaly. Okay, so most common cause of face presentation is anencephaly. Okay? Chalo, let's go forward. Face, frank breech, because in both beta, in face and frank breech, we will see two bony, or feel rather, two bony prominences and one opening. So in face, the bony prominences are malar bones and the mouth, and in breech, it is going to be ischial tuberosities in the anal opening. So when you do a PV, you can get confused because you feel the similar things, two bony prominences and one opening. Okay? It is nothing to explain, bache. This is something that you have to remember, Anuradha. Okay? That face mein, it is going to be in complete extension, and in brow, it is in partial extension. Okay? ये आपको याद रखना पड़ेगा, बच्चा. Chalo. Let's go forward now. Your patient is coming at 34 weeks with complaints of edema in the feet. Her blood pressure is 170 by 110. There is protein urea. Which statement is not true? Were you all able to do it correctly? So let's see. Do we call it as severe preeclampsia? Yes. Now who is going to tell me why this is a case of severe preeclampsia? Why is it a case of severe? So anytime, please remember, if the blood pressure is more than or equal to 160 by 110. अच्छा, कुछ बच्चों को बिल्कुल मैं बता रही हूँ, बेसिक्स में कंफ्यूजन है. It has to be both systolic and diastolic, or it can be one of them. So please remember, दोनों की जरूरत नहीं है. Even if one of them crosses the cutoff, you will still call it as severe. Is that understandable? Yes? What is the other criteria to say severe preeclampsia? Either the BP is this and or any time there is end organ damage, right? So if the BP is not this high, but there is end organ damage, then also she is a case of severe preeclampsia, right? So either of the two. Now quickly, because this is very important for INI CT and they keep asking you what are criterias, you have to know. So what are the criterias for end organ damage? So if my patient has any of the following, right? So what are these things? Number one, the patient may have serum creat more than 1.1. The patient may have a platelet count of less than 1 lakh. The patient may have liver enzymes more than twice the normal value. The normal value in pregnancy is usually less than 30. Okay, so if the liver enzymes are more than twice the normal value, if there is evidence of pulmonary edema, okay, and if there is cerebral or visual symptoms. What could be the cerebral symptoms, beta? So anytime there is evidence of new onset headache or evidence of dizziness, right? So new onset headache or evidence of dizziness. So any 5 of these indicates end organ damage. So either the BP has to be very high or there has to be end organ damage to say it is severe preeclampsia. Okay? So option A is correct. है ना? Does my patient need termination of pregnancy? Why is this answer correct? This is also true, but tell me why. Because once you say your patient is a case of severe PE, you have to do a termination at and beyond 34 weeks. So patient has already reached 34 weeks. We have to do a termination of pregnancy. Yes. Should we give her injection labetalol? Yes. It is the drug of choice for hypertension in pregnancy. Right? So it is the drug of choice for hypertension in pregnancy. So please remember, whenever you get a patient of severe preeclampsia, right, you have to stabilize the patient and then do termination if POG is more than 34 weeks. Is that clear? Yes. So please remember, drug of choice is labetalol. Now, please remember, if your patient has acute hypertension, okay, so acute hypertension क्या होता है? Blood pressure is more than or equal to 160 by 110. Then we will give IV labetalol. This is the route, okay? The route is IV in this case. Can I give as an alternative? Can I give hydralazine? Yes, we can give hydralazine. Can I give calcium channel blockers as an alternative? Yes, we can give CCBs as well. And other drugs that we can use for acute hypertension are IV NTG, okay, IV NTG, and what else? What else? We can also give sodium nitroprusside as the last resort. Which means if I'm not able to control blood pressure with all other drugs, then yes, I can give sodium nitroprusside also. The important thing that I want to highlight here is, when it comes to acute hypertension, please do not say you will give methyl dopa. We will not give methyl dopa. No, it's a big no. That's the mistake you people do. Methyl dopa is not given for acute hypertension. It is a very mild drug. Okay. And it has a delay in the onset of action. So we don't give methyl dopa if it is acute hypertension. Okay, is that clear? Also, when we are talking about drugs, right, a very, very easy question has been asked in INI-CT, has been asked in NEET, is drugs which should not be given as routine antihypertensives, right? So can you tell me what drugs are simply contraindicated as antihypertensives in pregnancy? The best and the easiest answer you all know. It comes in the exams multiple times, right? So ACE inhibitors. But please also remember angiotensin receptor blockers. Okay. Also remember beta agonist. Also remember diuretics and diazoxide. Okay. So please remember, these are not to be given in pregnancy. Okay, is that clear? These are not to be given. So the answer to this question is steroids. Because your patient has acute hypertension, she has crossed 34 weeks, we are going to do a termination of pregnancy. We are not going to wait for steroid cover. Is that clear? Yes. So beyond 34 weeks, no waiting. If your patient has severe preeclampsia, no waiting beyond 34 weeks. Is that clear? Okay. So please remember this. Now please also remember, somebody is asking a very basic question. Are you supposed to repeat the blood pressure? Obviously yes. Have you not treated people with antihypertensives otherwise? So whenever there is acute hypertension, which is a BP of 160 by 110, you must take a repeat reading. But that repeat reading is not to be taken after 4 hours. It has to be repeated in next 15 minutes. Right? So if it is high, you have to start the antihypertensives. Okay, is that clear? Okay. So are we talking about heart failure, Pavleen? See, most of you, when you realize, what kind of mistakes you do, is your mistakes are mostly because of, overthinking. आप लोग अपनी thought process को इतना complicated क्यों करते हो? I don't understand. See, the biggest advice that I have to give to all of you for your exams is, keep your thinking simple. If you are going to think like this, the way you're thinking currently in the chat box, then it's a big blunder. Why heart failure? From where heart failure comes? We're not talking about heart failure. We're talking about preeclampsia. We are not talking about a woman who's dying, right? So if you keep putting ifs and buts, then every option will look confusing to you. Okay, is that clear? So the only thing is you have to understand jitna diya hai, utna hi diya hai. Okay? In the exam, whatever is given is given. You cannot presume things on your own. Alright? Of course not, Anisha. Why would it be contraindicated? But you will give it only when it is required, right? So please remember, Anisha, hydralazine is given only for acute hypertension when the blood pressure is this high and labetalol is not available. Okay? As an alternative, it can be given. Okay? Clear? No, it is not the same, but they are subsets. So please remember impending eclampsia or imminent eclampsia. Okay. So when we talk about the term like impending eclampsia, which can also be called as imminent. We don't use the word imminent, but they are the same things. Okay. So please remember, when we say impending eclampsia, it obviously is a patient with acute hypertension or severe preeclampsia, right? But this is a subset of it. It is a part of it. And the management protocols are also very similar, which means any time your patient has new onset headache, okay, new onset visual changes, or epigastric pain, nausea and vomiting. So any time a patient who is obviously a known case of what? PE. So we are talking about a patient who is a known case of preeclampsia and she has new onset headache or new onset visual changes or epigastric pain. She is to be taken as a case of IE. Okay, obviously she becomes severe preeclampsia, but a better, do you know why we label patients? I often teach that in my class. हम पेशेंट को लेबल क्यों करते हैं? इसको IE है, इसको सिवियर है, इसको एक्लैम्सिया है. The labeling is done for patient management and for triage, so that we as doctors know who is to be kept on priority and what is to be done for her, right? So if the patient has this, you should treat her like IE, which means the next step in the management of this patient should obviously be control or prevent seizures. So whenever we ask you, what do you do next in IE? The answer has to be Magself. But at the same time, what else should I do? I should also give antihypertensives, right? She'll have a high blood pressure. You have to give antihypertensives. And once you stabilize the patient, so these two things, Magself and hypertensives, we are giving to stabilize the patient. And after patient stabilization, we definitely have to do termination. So this is symptomatic treatment. This is specific treatment. Symptomatic shuru karte hain to stabilize the patient. Once the patient is stabilized, we will deliver her. Is that clear? So the absolute treatment is termination, but not the next step. I hope I've made myself very clear because this is very, very important for exams. Yes? Okay? Chalo. In severe preeclampsia, not based on Indian guidelines, American guidelines say that yes, when patients are a case of severe preeclampsia and they are in labor, you should give them Magself prophylaxis. You're giving it as prophylaxis. But India, we are not giving it routinely as prophylaxis. The American guidelines say that when a patient is, okay, when the patient is of severe PE and in labor, we should give Magself prophylaxis. But as I said, these are not followed in India. These are American guidelines. Okay? Arey bhai, why not Akanksha? It is a type of preeclampsia, bhai. Okay? Is that clear? Acute hypertension is just the description of the blood pressure, bache. Disha, it is a type, it is a finding in a patient of severe preeclampsia. Okay? Chalo. Let's move on to the next one. In a woman with previous history of 3 first trimester abortions all are required except. Yes, the dose for prophylaxis is absolutely similar to Pritchard. Okay, chalo. What is the answer for this one? So did you all do this right? What is the answer? The answer is D. Evaluation for cervical incompetence. Yes? Tell me, what is the reason for this? The reason is because the key word was first and except. These are the two keywords. So please remember, cervical incompetence will cause recurrent pregnancy loss, which has to be more than or equal to 3. It has to be only and only in the second trimester, right? And they have to be painless losses. Okay, so more than or equal to 3 in the second trimester, and painless losses is mandatory as a requirement to diagnose cervical incompetence, right? Which is then, so you know, if we meet all these criteria, more than or equal to 3 losses in second trimester and painless, this is criteria for history based. Okay, history based cervical incompetence diagnosis. Okay, is that clear? Okay. What are option 2, B and C done for? So APTT किसके लिए करते हैं? Anti-cardiolipin antibodies किसके लिए करते हैं? So APTT is actually a test of LAC, lupus anticoagulant. Okay, so it is a test of LAC, which is lupus anticoagulant. Right? Now please remember, lupus anticoagulant and anti-cardiolipin antibodies are antibodies for what? They are the two important antibodies for APLA. Okay, we have another question on APLA where we will definitely talk about this as well. So these are the two antibodies. Can you tell me what is the third antibody for APLA? The third antibody for APLA, so one is lupus anticoagulant, the other is anti-cardiolipin. What is the third one? Anti-beta-2 GP1, glycoprotein 1 antibodies. Okay, so anti-beta-2 GP1 antibodies. Now please remember, as far as APLA is concerned, APLA can cause both trimester losses, first and second, but even for APLA, more characteristic is second trimester losses, but it can also do first trimester losses, right? It can also do first trimester losses, but more characteristic is what? Second trimester losses. Is that clear to everyone? Yes? Okay. The same holds true for recurrent pregnancy loss with uterine anomalies. Even with uterine anomalies, more characteristic, whether the abnormalities are acquired or they are congenital, right? So if there are uterine abnormalities, okay, what is more characteristic? More characteristic is again second trimester losses, right? They can also do first trimester. But when you talk about specifically cervical incompetence, it does not cause second trimester losses, right? So cervical incompetence does not cause first trimester losses. Is that clear? It will cause only and only second trimester. Okay? Now, please remember the most common cause of RPL in the first trimester, right? So if we ask you, most common cause of RPL in the first trimester. If they are specifying, okay, if they are specifying the first trimester, then the answer should be written as chromosomal abnormalities. Okay, is that clear? Then the answer should be written as chromosomal abnormalities. Yes? If we ask you Most common cause of RPL in second trimester. Okay. Then अभी आप ध्यान से सुनोगे, नहीं तो आप सब गड़बड़ गड़बड़ करोगे. Okay. Then among groups, if you compare one group to another group, the biggest chunk is caused by endocrinopathies, followed by uterine abnormalities. But please remember, endocrinopathy here is not an individual entity. It is a group. Is that clear? So when you compare a group with a group, the answer becomes endocrinopathies. Yes? Now, listen to me very carefully. I'm going to convert these into MCQs for you and you have to answer to me. Okay? So the first question that I will ask you is, which of the following is most common cause of recurrent pregnancy loss in general? Okay? Let's say option 1 is hypothyroidism. Option 2 is uterine abnormalities. Option 3 is, let's say, APLA. And option 4 is chromosomal. Now what will you answer? Tell me. Question hai, most common cause of recurrent pregnancy loss. That's it. What is the answer? So please remember here, they have not specified anything with respect to trimesters. It's just a general MCQ. And then the answer will be uterine abnormalities. Why? Because uterine abnormality is a group. It has congenital abnormalities. It has acquired abnormalities. It is a group. And the number of cases because of a group will be more than any individual entity. Hypothyroidism is an individual entity. APLA is an individual entity. Chromosome is a group, but what is the problem? The problem is that you don't know the depth. Chromosomal abnormalities only cause 4% cases of RPL. So chromosomal is a smaller cause when it comes to RPL. When it comes to spontaneous abortions, not recurrent abortions, then chromosomal was the leading cause. So you all are really confused here. Okay? So chromosomal is the leading cause when we talk about spontaneous abortions in general. When we talk about RPL in general and nothing else is specified, the answer here will be uterine because it's a group. Is it clear to everyone? Okay? Now, if on the other hand I ask you to compare this, I'm changing the MCQ. Most common cause of RPL. And the options are 1 on 1. So let's say it's hypothyroidism. Let's say it's septate uterus. Let's say is APLA. And let's say it is trisomy. Okay. Now what is the answer? So now do you understand we are comparing 1 on 1? Right? And maybe in trisomy, they will specify also. Let's say trisomy 21 or they will specify trisomy 16. Now what is the answer? Now do you realize that you're comparing 1 on 1? And when you compare 1 on 1, the answer is APLA because APLA itself causes 16% cases of RPL up to. Uterine abnormalities cause 10 to 50% cases of RPL. Endocrinopathies as a group cause 15 to 60% cases of RPL. Is that understandable? I hope there is no confusion now. So endocrinopathy as a group is 15 to 60%. Uterine abnormality is 10 to 50%. APLA is around up to 16%. Is that clear? I hope there is no confusion now. And you will not do it wrong. Now, the other part which I also know you do wrong, maybe I don't know, you've read it somewhere or somebody is misguiding, don't know. But please remember, infections do not cause RPL, not even syphilis. Is that clear? Is that clear? So please remember, infections do not cause RPL. Is that clear to everyone? No infection is a cause of RPL, whether it is torch, whether it is syphilis. So never do this mistake in the exam. Tick? Okay. Also, please remember, So these are important things, especially with respect to RPL. It's an important topic. You keep doing it wrong and NEET PG people keep asking it. Absolutely right. Sakshi is right. Please remember, syphilis causes more of stillbirths, not recurrent early losses. Okay? It will cause usually stillbirths. ठीक? चलो. So now let's look at the next question. Your patient is pregnant. The first baby developed hydrops fetalis. Your patient is currently at 32 weeks. Her ICT is positive with a titer of 1:16. What is the next step in the management of this patient? Okay, I have to show you one visual also, I forgot. So, tell me what is the next step? Right, so please remember the answer here will be MCA Doppler. That's right, the answer is MCA Doppler. Why? Because the patient has caused what? Reached a critical titer. Okay. Critical titer is a titer which is more than 1:16. Okay? Equal to or more than. But my problem here I want to know is 1:8 less than this or more than this? So when the titer is more than 1:16, you have to answer it as MCA Doppler. But if the titer is less than 1:16, for example 1:4, 1:8, ठीक है, ये सब less होता है बच्चे, more नहीं होता. Then if they ask you what is the follow-up test, then the answer will be repeat ICT at 4 weeks. Okay, so repeat ICT at 4 weeks. Is that clear to everyone? So the answer will be different. What are you looking for in the MCA Doppler? You are looking for fetal anemia. So this can also be a separate MCQ by itself. MCA Doppler का best use क्या होता है? So best use of MCA Doppler is to pick up fetal anemia. Okay? And when you talk about fetal anemia, what are you going to study here? Yes, you will study Doppler में peak systolic velocity. Okay, so this stands for peak systolic velocity. And remember, if this turns out to be more than 1.5 MOM, MOM is the units hai, multiples of median. So if it turns out to be more than 1.5 MOM, it means the baby has significant anemia. Okay, the baby has significant anemia. Now I want to know this from you. Suppose MCA value is more than 1.5, what do you do next? So it will depend on POG, you know. If the POG is more than 34 weeks, you do deliver the baby. Okay, so then it will mean deliver the baby. Okay, but if the pregnancy is less than 34 weeks, then what do? Then you will have to do CODO. Okay, then you have to do chordosynthesis to look for exact amount of fetal hemoglobin, because that's how we are going to decide about what? We are going to decide about whether the baby needs blood transfusion or not. Okay, now very, very important, some basic concepts that you have to understand. Okay, ICT positive, anytime the MCQ says ICT is positive, then there is no role of anti-D. Is that clear? No role of anti-D. Only and only if ICT is negative. Okay? Only and only when ICT is negative, then you should give anti-D. Can you tell me, when ICT is negative and I am giving anti-D, what is the best time to give anti-D? So these are important with respect to INI-CT as well. The best time to give this anti-D is at 28 weeks. Okay, at 28 weeks. Because the pregnancy is beyond 12 weeks, the dose will be how much? 300 micrograms. When else will you give anti-D? Whenever you suspect, okay, whenever you suspect feto-maternal hemorrhage. For example, in conditions like abortion, in conditions like any invasive procedure being done, for conditions like external cephalic version, right? So whenever you suspect a feto-maternal hemorrhage, as I said, like abortions, like invasive procedures, like external cephalic version, or anytime your patient has antepartum hemorrhage, right? So in all these conditions, you suspect feto-maternal hemorrhage, then you should give anti-D. The third place where you should give anti-D, all this has to be given when ICT is negative. Okay? The third time is after delivery of RH positive baby. So please remember, once the baby is born, you have to send baby's blood group. So if the baby's blood group is positive, all patients will receive anti-D, right? At all these times, as long as pregnancy is beyond 12 weeks, I told you the dose is 300 micrograms. Okay, the dose is 300 micrograms. Okay, is that clear to everyone? Yes? Okay, so those are different things that you should know with respect to what will you do when they give you the ICT positive, negative. In case of positive, if they give you the titer, what would you do? Okay, is that clear? Yes, it has to be given ideally within 72 hours. That's the ideal situation, okay? So it has to be given within 72 hours of an RH positive baby. Take? All right. Chalo. Let's look at this one. So again, something that the NEET PG people are fond of asking, right? What type of placenta previa is shown? So how many of you get confused between type 3 and type 4? Because I've seen you get confused. So please remember, this is actually type 3 and we say partial. Okay? So we say it is partial. Now please remember, once it is partial, what does it mean? It means placenta is partially lying over internal os. When you say type 4, it means placenta is completely lying over internal os. ठीक है, ये older classification है, now not the newer classification, but NEET PG is very fond of asking this. So I want you to all see this image so that you don't get confused because you don't know the words. People have not told you the concepts. This is where you get confused. Okay? Type 3 is shown like this, which means not that the os is partial. It means a part of placenta is coming over the os. So that is why it is called as partial. In type 4, the entire placenta covers the os. And that is why type 4 is also called as central. Okay? So type 4 is also called as central. Type 3 is also called as partial. So it's a partial part of the placenta is covering the os. Okay, what is the other name for type 2? Type 2 is marginal. Yes, reaching the margin of internal os. And type 1 is low-lying. So please remember that this is the older classification, but you get IBQs from it, so you should never get confused. Okay. Also, please remember, we might want to ask you, when do you say it is low-lying? When do you say it is low-lying? So when it is within how much? Within 2 centimeters of internal os, right? So if the placenta lies within 2 centimeters of internal os, then you say it is low-lying. Okay? Also, please remember, now as per the newer classification, we have only 2 terminologies. Either we say it is low-lying, which remains the same within 2 centimeters, or we say it is placenta previa. So the previous terminologies, which were type 2, type 3 and type 4 are now simply put under placenta previa. So now we have only one word for it. What is the word? Placenta previa. Okay, is that clear? Also, what is the investigation of choice for abnormally located placenta? So investigation of choice for abnormally located placenta has to be answered as TVS, transvaginal ultrasound. TVS is safe. It is also more sensitive. It is the investigation of choice. Okay, bacha, is that clear to everyone? Yes, so I hope you will not do the IBQs wrong. Okay, so the classification is important. Don't do it wrong. Take. And then also please remember, I am sure that you know these basics. Whose blood is it when you say it is antepartum hemorrhage? So when we talk about maternal placenta previa, it is going to be maternal blood. And typically, please remember, when you say APH, it is bleeding at and beyond 28 weeks based on our guidelines. So period of viability in India is still 28 weeks. Is that clear? Okay, so period of viability in India is still 28 weeks. Okay, bacha? Good for everyone? Okay. There is one more image that I had brought for the previous question, which I didn't show you, but I'll show it to you now. Okay. It is there in your image book, and it is a few things that you should know with respect to the image of cervical cerclage. Yes, if I show you this picture and I ask you which type of cerclage is this, what will you say? What would you say? Okay, so nothing. I said as far as the new classification goes, there is only two terms now. Okay, the two terms are low-lying placenta and placenta previa. अभी सिर्फ दो ही terms हैं. And then I said कि पुराने terms में जो 2, 3, 4 थे, now they are all put under what? Placenta previa. So there is nothing like 2, 3, 4 now. It's just all of them are together called as placenta previa. Okay? Then I said in placenta previa, it's maternal blood. And remember that as far as our guidelines are concerned, antepartum hemorrhage is bleeding beyond 28 weeks. Okay, so it is bleeding beyond 28 weeks. See? Also, so these were the things that I was trying to say when, I don't know, it might have hanged for some of you. Okay, so now as I said there was one more image that I have got for you, and that is important, which is this one. Okay, and I was asking you what type of cerclage is this, right? So what do you see here is a purse string suture. Okay, so this is a purse string suture. See? And when it is purse string, the answer is what? McDonald's. Okay, is McDonald's a vaginal surgery or an abdominal surgery? So this is the most common cerclage which we do, and it is a vaginal procedure. Okay, it is a vaginal procedure. And please remember that there are certain surgeries that we do in the while the woman is pregnant, and certain others that you should know while the woman is non-pregnant. Okay, so McDonald's, then Shirorkars, as well as emergency cerclage, which is called as worm stitch or worm cerclage, right? All these three surgeries are vaginal surgeries. Okay, they are the first preference when the woman is pregnant. So all these surgeries are the surgeries that we do while the woman is pregnant. And out of the three, as I said, the most common is McDonald's, right? When do you say it is an emergency cerclage? So you say it's an emergency cerclage when cervix is fully dilated. But please remember, membranes have to be intact. Okay, so when the cervix is fully dilated, the membranes are intact, and then if you are putting it a cerclage, that is what you call as an emergency cerclage or a worm stitch. So ये सारे vaginal हैं and they are done in the pregnant woman, right? What about non-pregnant? So in non-pregnant, we would usually want to go nowadays with abdominal surgeries. So now the treatment of choice in non-pregnant state is abdominal surgery. Okay. Abdominal, maybe the one we prefer is laparoscopic. Okay. So abdominal, maybe the one that we prefer now is laparoscopic surgeries. Please remember the surgeries are done when vaginal surgery has failed, right? So they are not the initial surgery. Laparoscopic surgeries or other surgeries which are abdominally done are done when vaginal surgeries have not been effective. So basically you will treat in the non-pregnant state when vaginal surgery is or has not been effective. So nowadays, as I said, the treatment of choice is laparoscopic cerclage. But then you should know an older abdominal surgery, which is coming by the name of Benson and Durfee. Okay, Benson and Durfee. Yes, usually we are not doing laparoscopic surgeries when the woman is pregnant, right? So if she is pregnant and she has cervical incompetence, we will actually be doing the vaginal surgeries. Is that clear to everyone? In the non-pregnant, we would preferably want to do lap, and especially when the vaginal have failed. Okay. Yet another one which is vaginal is lash and lash. So these are all the names of the surgeries for the non-pregnant state. Okay. So in the non-pregnant, the options we have are laparoscopic, Benson and Durfee, lash and lash. ठीक है, जिसमें से now what is the treatment of choice? What is the treatment of choice? Laparoscopic. Okay, so now the treatment of choice is laparoscopic. Is that clear? No, vaginal is not preferable. In pregnancy, vaginal is preferable because operating when the uterus is big becomes difficult. Okay, so in pregnancy we are doing vaginal, but otherwise the success rate is higher with these abdominal surgeries. The problem is abdominal surgeries are more difficult to do, and please remember that these abdominal surgeries, whether it is lap or open abdominal, these are permanent surgeries. Okay, they are not temporary unlike vaginal. Okay, the thing is that these vaginal surgeries tend to be temporary, which means we have to remove the stitch. But the abdominal surgeries are permanent, right? They're more difficult to do as well. Okay, but they give a better outcome. So especially if patient has been undergoing a vaginal procedure and she has failed, then yes, we would want to do this. Okay, is that clear? Now please remember some very, very important, just smaller points that you should know with respect to cervical incompetence. I'm sure you might want to know, right? It's just a small sperm. The sperm can pass through. Don't worry about it. ठीक है? So please remember, permanent का मतलब ये होता है कि आपको remove नहीं करना है, and then these patients have to undergo a cesarean section. ठीक है? While temporary का मतलब है the suture has to be removed. ठीक है? Now some common one-liners that are important for you. What is the ideal time to put the cerclage? The ideal time for cerclage in pregnancy is 12 to 14 weeks. Okay, 12 to 14 weeks. And when do you remove the cerclage? We generally will remove the cerclage at 37 weeks. Okay, we will remove the cerclage at 37 weeks. See? Also, please remember, in pregnancy, they are very fond of asking you contraindications of cerclage. So, if the membrane is ruptured, this is one of the most important contraindications. Okay, if the membranes are ruptured, you will never put a cerclage. If there is a current pelvic infection, then again you will not put a cerclage. It has to be current, not a past infection. And lastly, if the baby has a known case of gross congenital anomaly. which we mean is incompatible with life, like anencephaly, then yes, don't do a cerclage. It's better that she expels. Okay, so these are some of the other common important things that are often asked in the exams with respect to cerclage. Okay, is that clear? Okay, right. So I will talk about ultrasound diagnosis in a little, maybe a little later when we have another question. But this is with respect to some basic things that you should know about cerclage. Right? Right. Let's go on to the next question now. Okay. Were you all able to identify the placental abnormality? So this is a case of battledore placenta. Why do you say it's battledore? Because the cord is attached to periphery. Okay. So if the cord is attached to the periphery, we say it is a battledore placenta. See, what is an important complication that you should know? What is an important complication? So an important complication is cord avulsion. Okay, it is called, the complication is cord avulsion. मतलब cord break हो जाता है. What will happen then? The cord comes in your hand and the placenta is left inside, which means we will deal with retained placenta. Yes, marginal attachment and battledore are same, bache. Okay. So marginal attachment and battledore are same. Yes. So if it is a retained placenta, what is going to happen? Postpartum hemorrhage. Right? So if there is a cord avulsion, there is a retained placenta, the patient is bleeding a lot. What do you think is the management? MRP, right? Manual removal of placenta, right? So the management then will be MRP. Is that clear? Now with this question, I want you to see the other abnormalities which may come as IBQs or maybe something application. For example, this. Right? What is the abnormality that you see here? So this is a placenta succinturiata. Right? Why? Because you see a small, the key is this is a small accessory lobe. Okay, so we have a small accessory lobe. So this is a succinturiata. What complication do you expect here? Postpartum hemorrhage, right? So the complication is going to be postpartum hemorrhage. What happens is that the smaller lobe is left inside. So again, what is the management here? The smaller lobe is retained. And again, we will have to do MRP, right? So again, you will have to do a manual removal of placenta, right? Now, so these are the two places where we typically might have to do manual removal because the patient may bleed a lot. Now, my doubt to you is, when we say there is a succinturiata and there is a PPH, will this cause primary hemorrhage or secondary hemorrhage? What would it cause? Because I see you people have some weird concepts on this. So primary or secondary? So please remember, if this entire lobe is left inside, it is going to cause primary PPH, not secondary. So primary is when she has bleeding within 24 hours. See, I knew where you would do wrong. Secondary is when the bleeding happens beyond 24 hours up to 12 weeks. Okay, please understand, if this entire lobe is left inside, do you think she's going to bleed after 24 hours? No, that retained placenta is placental tissues, smaller bits and pieces of placenta that are left inside, not an entire lobe. Is that understandable? So this will actually cause a primary hemorrhage more commonly, right? So more commonly, please remember, succinturiata will cause primary hemorrhage, not secondary. ठीक है? Secondary तब होता है जब छोटे से बहुत bits pieces are left inside. All right? Okay. Which is this abnormality that you see here? So this is a velamentous cord insertion, where the umbilical cord is inserted on the membranes. And then what is happening? The blood vessels are traveling outside the cord. Yes, they are traveling outside the cord to reach the placenta. Right? Now, one of the important things that you should know is an association with velamentous is what? What is an important association? This one. Right? So, please remember, there are two images that we have brought for you. First, let's look at image number A. Only A. So, if you look at A, this is where the cord has ended. Okay, and that is why we are saying it's a velamentous attachment. And then the blood vessels are traveling outside and they are crossing over internal os. So when it crosses over internal os, it is called as vasa previa. Okay, it is called as vasa previa. Now please remember, the important thing here is that vasa previa, although more commonly is seen with velamentous. Okay, so it is more commonly seen with velamentous. If I ask you, can it be seen with succenturiata as well? Yes. Okay, so uncommon, but yes, it can happen. It can be seen with placenta succenturiata, where the smaller lobe is connected to the bigger lobe, right? And again through the blood vessels. So smaller lobe and the bigger lobe are connected. So please remember, when you have to mark one with vasa previa, which one will you mark? Velamentous or succenturiate? Velamentous. Ek mark karna hai to velamentous. Similarly, with succenturiata, if you have to mark APH or PPH, what is more common with succenturiata? Please answer PPH. APH with succenturiata is rare, only when it is associated with vasa previa. Okay? So vasa previa causes antepartum hemorrhage, actually a lot of times intrapartum. So antepartum or intrapartum hemorrhage, right, at the rupture of membranes. Yes, there is going to be bleeding from here. What else is very characteristic to vasa previa? Fetal blood loss. So as compared to abruption, as compared to placenta previa, here you would see a fetal blood loss. So a clinical presentation would be a patient who is in labor, has had ruptured membranes, is now bleeding. So not only there is APH or intrapartum bleeding, there will also be, yes, severe fetal distress. Okay, there will be severe fetal distress, and therefore we say that the management of vasa previa is what? Emergency cesarean. Okay, the management is emergency cesarean. Okay, who's going to tell me how can we diagnose vasa previa? How can we make a diagnosis of vasa previa? So it has to be done with ultrasound Doppler, right? You will see blood vessels traveling over the internal os. So ultrasound Doppler is what we would use for diagnosis. Yes? Okay. The last thing I want you to know here is, when we talk about fetal blood loss, sometimes, has been a PYQ in INI-CET. So what test can you differentiate fetal blood from maternal blood? What test will you use to differentiate? So when we have to answer like this, the answer has to be apt. It is a bedside test. It is a qualitative test. Okay. And alkali or acid? It is an alkali test. Hai na? It is an alkali test. And what do you use here? Absolutely. 1% NaOH. So qualitative test. It's a bedside test. Okay. KB is quantitative beta. So KB is something when you want to see individual RBC. So when you want to see an individual RBC, then we will use KB, which is an acid test, right? So apt is alkali. Okay, KB is when you want to see individual cells. Okay, then you do KB, like in RH negative. Okay, clear to everybody? Chalo. So those were important things about placental abnormalities and how we would clinically connect them. Chalo. Let's go forward. Okay, again, a topic which is important for both the exams, INICT exam as well as NEET PG. So very easy one, right? What is the finding here in the image? What is the finding? So this is a umbilical artery Doppler. A lot of you get confused between umbilical and uterine. So I will just talk about it, but this is umbilical artery Doppler. And the patient is 35 weeks. What is the management? Is the question, right? So absolutely yes. This is a patient of AEDF. है ना? Absent end diastolic flow. Now, if it is absent end diastolic flow and the POG is beyond 34, the answer is termination, where cesarean will be preferred over vaginal. Vaginal can be done, it's not contraindicated, but what we prefer is cesarean. ठीक है? Do we wait for steroid cover now? No, वो तो हम पहले ही दे चुके होंगे. Once she has crossed 34 weeks, you just deliver her. ठीक है? Is that clear to everyone? Okay. And I'll come back to this. What will you do if the POG is less than 34 weeks? So if it is AEDF and the POG is less than 34 weeks, तब क्या करना है? Then your answer should be daily NST plus daily biophysical profile plus steroid cover, right? So plus steroid cover, and when will you add MagSulf? कौन बताएगा मुझे? जल्दी से बताओ. When will you add MagSulf, Betu? You are a super interactive batch. I am loving it as well. You're going to keep me on my toes, and I love that. Okay, so when bachas keep me on my toes, that's the fun part, है ना? So please remember, only and only if the pregnancy is less than 32 weeks. Very good, excellent. Yes, well done. Then you will add MagSulf, है ना? MagSulf क्यों दे रहे हैं? For neuroprotection. Do not give MagSulf beyond 32. ठीक है? 32 के beyond नहीं देना है. Only if she is less than 32 weeks. Also, since we are talking about steroid cover, which steroid is the drug of choice? Which steroid is the drug of choice? So now please remember, we have to answer based on our guidelines. We do have our guidelines here. So for us the answer is dexamethasone. Right? Jaldi se dose batao. Kaun sa bacha batayega? Perfect. You know everything. Do you need me? I don't think you guys need me. Huh? Chalo. So dexamethasone is 6 milligrams, 4 doses, 12 hourly intramuscular, right? So 6 milligram, 4 doses, 12 hourly intramuscular. ठीक है? What is the dose of betamethasone बच्चे? 12 milligrams, 2 doses, 24 hours apart. Yes? Again intramuscular. ठीक है? So 2 doses, 12 milligrams, 24 hours apart, intramuscular. ठीक है? So you should know about MagSulf and you should know about dexamethasone as well. ठीक है? Perfect. Very good. Na beta. This is not a particular regime. The Pritchard, वो सब regime सिर्फ eclampsia के लिए बोले जाते हैं. Here, the international recommendations are actually IV MagSulf. So we start an IV drip for this, right? So forget about the dose, but we don't use them as a Pritchard regime. Those are only specific to eclampsia, pre-eclampsia. ठीक है? Okay. Now, please remember, with respect to this, I also want you to see this image. Who is going to diagnose this image? So the answer is already written there. What is the image? So this is an image of REDF in umbilical artery. Okay. We will talk about endomethacin also. Don't worry. In a relevant topic. ठीक है? हाँ जी. So this is REDF in the umbilical artery. And once you identify, please remember, once the pregnancy is at and beyond 32 weeks, the answer will be termination. Again, the preferred mode is CS. Okay. If the pregnancy is less than 32, then you will give steroids plus Magsalve plus daily monitoring. Okay, so steroids plus Magsalve plus daily monitoring. Okay, is that clear to everyone? Okay, perfect. Now, as I said, some bachas get confused between umbilical artery and uterine artery Doppler. तो जो अभी मैंने डिस्कस किया है वो umbilical artery Doppler है. So please remember, umbilical artery Doppler बच्चे is used for monitoring the fetus. Okay, in patients of uteroplacental insufficiency. So umbilical artery Doppler is actually a marker of UPI. Okay, is that clear? Also, when we talk about uteroplacental insufficiency, what do we measure? We measure SD ratio, right? That's what we primarily measure, SD ratio. So please remember, in a normal pregnancy, okay, this is important with respect to NEET PG as well as INICT. So in a normal pregnancy, as POG increases, what will happen to SD ratio? SD ratio should decrease. But if my patient has uteroplacental insufficiency, then we will see SD ratio will increase. Okay, then SD ratio increases. And once the pregnancy is beyond 28 weeks, if SD ratio is more than or equal to 3, then this is a marker of UPI. Okay, then this is a marker of uteroplacental insufficiency. So this is how we pick up UPI. Okay? Now, don't confuse this with uterine artery Doppler. Bacha, uterine artery Doppler, okay, is what you use for prediction of preeclampsia. Okay, so please confuse nahi hona hai. And uterine artery Doppler can be done early, which is around 11 to 13 weeks, or it can be done in the second trimester between 22 to 24 weeks. Okay, so ध्यान से सुनोगे, this is important for INI set. So early is 11 to 13 weeks, and in the second trimester we can do it between 22 to 24. When you do it early, you are doing it for prediction of early onset preeclampsia. Okay, early onset preeclampsia. Okay, which means preeclampsia which is happening before 34 weeks. In second trimester, we are doing it for prediction of late onset preeclampsia, which is beyond 34 weeks. So if the preeclampsia happens beyond 34 weeks, it is considered as late onset. Is that clear to everyone? Yes. And at the same time, we can also measure pulsatility index and resistive index, right? So along with, what all are you going to see in the uterine artery Doppler? Okay, is PI, RI, and diastolic notch. So what are the findings in these patients? RI and PI will be raised and diastolic notch will be present. Okay? So PI stands for what? Pulsatility index. RI stands for what? Resistive index. So ये दोनों high होंगे. High pulsatility index, high resistive index, while diastolic notch will be present. Okay? So these are the findings if the uterine artery Doppler is abnormal. Is that clear to everybody? Yes? Alright. Chalo. Let's go on to the next question. Yes. Rakshan, we will do cesarean only but beyond 32, at and beyond 32 weeks in REDF beta. Okay? Alright. So let's look at this one now. Not correct about Spiegelberg criteria. Right? Spiegelberg criteria are used for what? They are used for diagnosis of ovarian ectopic. Okay, so they are used for diagnosis of primary ovarian ectopic. Lunch break at 3, abhi nahi, 3 o'clock. Okay, everybody 3 o'clock. All right, thank you. You people are so sweet. Thank you so much. That's very, very kind of you. Some of you are actually reminding me to drink water. That's extremely, extremely kind. Thank you so much. Okay, I'll do that. So is option A correct? Yes. Gestational sac should be located in the region of the ovary. This is a true statement. You should know these, okay? This is especially for NEET PG bacha, right? Now, ectopic pregnancy is attached to the uterus by round ligament. This is what is the wrong one. What should be the answer here? It should be connected by ovarian ligament, not round ligament. Okay? Then ovarian tissue should be in the wall of the sac. Yes. So on histopath, we will be able to see the tissue in the wall of the gestational sac. And the tube on the involved side has to be normal, right? Okay. Can you tell me what are the named criteria for cervical ectopic? I don't know. I don't have much option when it comes to lunch in between a class. I tend to eat less when I have a class. Okay, so maybe you can give me ideas. All right, so criteria for cervical ectopic. They are called as Palman. These are the new ones, बच्चे. ठीक है, पुराने वाले थे Rubin. They are not used now, but you should know Rubin were the older criteria for cervical ectopic. Palman are the new criteria. ठीक है? Now, when it comes to Palman criteria, remember this. First, you have to say that the external os is partially open and internal os is closed. ठीक है? So external os partially open है, internal os is closed. Third, there is bleeding without uterine cramping. Okay? So bleeding without uterine cramping, मतलब no pain. ना बेटा important है, please समझो. NEET PG has asked us twice. पहली बार जब NEET PG ने पूछा था, that time they had only asked about the name. Then again they have asked where they have asked the details. So abhi tak they have asked only for Spiegelberg. It's a good idea to know about the other ones as well. At least you should have heard them once so that you're able to pick up the wrong answer. ठीक है? And the fourth is gestational sac is attached to endocervix. Okay, so it is tightly attached to the endocervix. So these are the Palman's criteria. What are the named criteria for abdominal ectopic? So for abdominal we have Studiford, right? So there are Studiford criteria. Now abdominal के लिए चाहिए मुझे that there should be no uteroperitoneal fistula, which means no fistula between uterus and peritoneum. So no uteroperitoneal fistula. Second, tubes have to be normal. All right. Third, pregnancy is detected early enough to rule out secondary implantation. Okay. So you have to diagnose it early enough to rule out secondary implantation, and the sac is exclusively attached to peritoneum. Okay, so it is exclusively or early enough attached exclusively to the peritoneum, right? Now there's another little question which I feel that sometimes students tend to do wrong, which is, if I ask you which ectopic, okay, which ectopic will go to the longest gestational age, what is the answer? So many of you answer this question as, okay, interstitial or intramural, and that's where you go wrong. The answer to this question, yes, is abdominal. Right, so abdominal ectopics actually can keep growing They can go even up till the 3rd trimester. Only when you're comparing within the fallopian tube, then the answer changes to interstitial. So, longest gestational age within tubal pregnancy. So, if we ask you within tubal pregnancy, then the answer becomes interstitial. Okay, then the answer becomes interstitial. What is the other name for interstitial? Intramural. Okay, so please don't do this mistake. No, we need all the criteria, bache. We don't need one of them. We need all the criteria, right? Okay, quickly 2 other MCQs that I want you to answer. Which is the narrowest part of the fallopian tube? So I don't want you to do these mistakes. So please remember, interstitial is narrowest. Narrow is isthmus. Okay, so interstitial is narrowest. Okay, and it goes to the longest gestational age, which is, yes, around up to 12 weeks. Okay, so it can go up to 12 weeks. No, so isthmus is narrow, but narrowest is interstitial. Okay? Okay, I want you to look at, okay, let me just see what is the next question, and then I'll try and show the image as well. Okay, so maybe we can see it here itself. So I've brought 2 more images for you, but I want you to understand something. What is this image that you see here? So image number 1 is double decidual sac sign. And what is image number 2? It is double bleb sign. है ना? Are they markers of ectopic pregnancy or intrauterine pregnancy? So please remember, they are early markers of intrauterine pregnancy, not ectopic. The second problem is the order. Which of these 2 comes first? Double decidual sac or double bleb? So double decidual comes first, then comes double bleb. और double decidual से भी पहले क्या आता है? उससे पहले क्या आता है? Intradecidual. Okay? उससे पहले आता है intradecidual. So intradecidual sign comes first, then double decidual sac sign, then double bleb sign. Right? Intradecidual sign, so they're all signs of early intrauterine pregnancy. So remember, intradecidual sign is nothing but seeing the gestational sac. So you see the sac, all around it you see the decidua, right? So that is the intradecidual sign. The second doubt I want you to understand is, when you talk about double decidual sac sign, what are the 2 sacs here and here? So again, a common mistake. So please remember, here it is going to be decidua capsularis and decidua parietalis. What are the 2 sacs here? So here one is the yolk sac and the other is the amniotic sac. Is that clear? So do not confuse the 2, right? So often you get confused. So दोनों में क्या चीजें दिख रही हैं वो अलग अलग हैं. So please don't do it wrong. ठीक है? On the other hand, so these are signs of intrauterine pregnancy, right? When you talk about ectopic pregnancy, what is the diagnostic finding? Diagnostic of ectopic pregnancy is if you see a extrauterine G-sac with embryo or yolk sac. So if you see the same things but you see them outside, then it is considered as ectopic, right? And when you see the sac, outside, so findings which are suggestive of ectopic. Okay, ये ऊपर वाला तो diagnostic था. Suggestive of ectopic में you see empty uterus. Okay, so you will see an empty uterus. What else will you see? We're talking about ultrasound findings, bache. Right? So you will see empty uterus. You will see a sac outside, which may be called as tubal ring sign. Okay, so tubal ring sign, and you may be able to see a complex mass with ring of fire sign. So ye sare signs, please remember, are suggestive of ectopic. If you see an extrauterine sac, you are with embryo or with yolk sac, then you say it is diagnostic. Is it understandable? Yes. So please remember this. They are understandable. That ye sari cheeze, there should be difference between diagnostic and suggestive. Beta, timelines are almost similar. So when you talk about gestational sac, so I'll talk about it, but in general, you see a gestational sac as early as 4.5 to 5 weeks. And these two signs can be seen anywhere between 5 to 5.5 weeks. Right? So these two signs can be seen anywhere between 5 to 5.5 weeks. So they're almost seen, you know, at the roundabout the same time. So this is important. Right? Is that clear to everyone? Okay. So please know intrauterine signs, please know ectopic signs. We'll talk about management of ectopic separately, right? वो अलग से करेंगे. Chalo. Quickly, let's go on to the next question. Okay. Were you able to do this one right? Which is not seen in ruptured uterus? The answer question is not seen. So, the answer is fetal tachycardia. Okay. Now, rupture uterus is a very, very potential question, especially with respect to NEET PG. And you have to understand that rupture uterus is a very close DD for abruption. That is how they give it in the exam, especially NEET PG. So, I'm just going to tell you the differences here in the MCQ itself. Okay. So, please remember, when you talk about rupture, yes, you will never see fetal trachy. In fact, you will see severe fetal distress in the form of fetal bradycardia, right? So you will see severe fetal distress in the form of bradycardia. You could even have an absent fetal heart rate. Okay. Now, what is the difference with rupture with respect to tender abdomen? So in rupture uterus, the entire abdomen is tender. What about abruption? What about abruption? In abruption, okay, in abruption, it is not the abdomen which is tender. It is a tender uterus. Okay, it's a tender uterus, right? Both of them will present with bleeding. But what is the difference between bleeding in rupture and abruption? In rupture, it is fresh vaginal bleeding, right? Whereas in abruption, it is altered blood. Fetal distress is common to both. You cannot differentiate. You will see distress in both. What about fetal parts? So they are definitely superficial in rupture. What about abruption? They are difficult to palpate. Okay, fetal parts are difficult to palpate. Then what is the difference with respect to uterus or the uterine contour, right? So when you talk about uterine contour, in rupture uterus, it is difficult to palpate because it has ruptured. So uterus you cannot feel very nicely. Whereas in abruption, the uterine contour is well made out. Can you tell me why is it well made out? Because it is a tense uterus. So it is standing out, right? So it's a tense uterus. So the contour is actually very well made out. Is that understandable? Yes. Then the keywords what they give you. So in a case of rupture, the keyword for you will be the patient will be a case of previous cesarean. What will be the keyword for you in terms of abruption? The patient will be a case of preeclampsia, or there may be history of trauma, right? So history of preeclampsia, history of trauma are keywords for abruption. Do you understand? So these are some of the very, very important findings. Yes. And what is the most, now if we talk about some one-liners, right? And if I talk about rupture uterus, can you tell me what is the most common finding? So when we say most common, it is fetal distress, right? Which they might write in the exams as non-reassuring FHR. Whereas if we ask you about most specific finding, then the answer is going to be loss of station. Okay, so then the answer is loss of station. And if we ask you most common cause of rupture uterus in a non-scarred uterus. So when we ask you about non-scarred uterus, then you can't answer previous cesarean, right? Then the answer has to be obstructed labor. If we ask you which drug is notorious to cause rupture uterus or has highest risk of rupture uterus, then it has to be answered as misoprostol. That is why we say misoprostol or PGE1 is absolutely contraindicated in previous cesarean, right? So that is why we say it is absolutely contraindicated in previous cesarean. Is that clear to everyone? Yes. So these are, either they will give you the question as one-liners or they'll give you clinical. If they give you clinical, they'll ask you to differentiate it from abruption, right? So I've covered both types of questions for you so that you're able to, answer it, because these are typical things that NEET PG is asking these days. Good to go, everyone? Perfect. So now I think we can take a lunch break and then we will start from the next question. Question number 16. Okay. And is the lunch break good as 35 minutes for everyone? Is it good? Or maybe we can make it 40 minutes. So we will restart the class at 3:30. Okay? And then we need to go a little fast. We are going a little slow. Okay? So 3:30 we will restart. Everybody go and have your lunch and then you can come back. Okay? Fetal tachy can be seen in dehiscence or impending rupture, beta, not in rupture. Okay? So tachycardia will usually be seen when there is impending rupture, not with rupture. ठीक? Class कब तक? रात तक. हाँ जी, is everyone back? Okay. So I hope everyone joins in quickly so that we can restart. And now that we've covered a few topics, I think the speed should get better, right? As we keep moving forward, as we keep covering more topics, the coverage improves and we can go a little faster as well. Okay. So I'll wait for another minute because I did mention that I'll start at 3:30 after the break. So I'll just wait for a couple of minutes and then we will restart. All right. So now I'll start. So let's look at question number 16. So let's look at this. So in this question, the woman is 6 weeks amenorrhea and she is coming to us with bleeding and ultrasound shows an empty sac of diameter 20 mm. Right? What is the advice that we want to give her? Tell me. So now, so do you remember the criteria for non-viable pregnancy? Yes. Now please understand, here we are seeing an empty sac. It's not an empty uterus. Do you understand this? Which means you are seeing a gestational sac in the uterus. So a lot of you might have confused it with ectopic. This is not ectopic. It's an empty sac. We are seeing a sac in the uterus. But as of now, there is nothing inside the sac. Right? So one of the definitions is that when you see a sac, we start measuring what? MSD. Do you remember what is MSD? Mean sac diameter. And then we say on transvaginal ultrasound, if the mean sac diameter is more than or equal to 25 mm and there is no yolk sac or embryo inside, then this is one of the definitions of non-viable pregnancy. Can you tell me what name do you give to this non-viable pregnancy? So this is what is called as blighted ovum. And This is one of the criteria to say it is non-viable. And do you know why blighted ovum becomes blighted? Because it has avascular, right? So it is avascular, so nothing develops inside. Now in this particular case, my patient is not meeting the criteria to say that it is non-viable. So I have to wait, and what we do is repeat ultrasound. Okay, please remember the minimum gap to wait is 1 week. It could be a range of 1 to 2 weeks as well. Okay, do you know what is the second definition of non-viable? So typically we call it as missed abortion. So who is going to tell me the ultrasound criteria for missed abortion? So ultrasound criteria are on TVS. If I am able to see an embryo, so once the sac develops an embryo, then I am going to measure what? Crown rump length. And then we say if the CRL is more than or equal to 7 mm and there is no cardiac activity, then you say it is a missed abortion, right? And what do you think is the reason for missed abortion? So majority of times this is going to be chromosomal abnormalities, right? So majority of times it is chromosomal abnormalities. Okay? Okay. So please remember, we did talk about most common cause of abortion. Here I'm not talking about RPL. We've already covered RPL. In general, when we talk about spontaneous sporadic abortions, not recurrent abortions, then the answer is chromosomal. But can you tell me what type of chromosomal abnormalities cause abortions? So most commonly these are aneuploidy. Whereas when you talk about chromosomal abnormalities, okay, so when you talk about chromosomal abnormalities in RPL, then what type of abnormalities are they, bacha? So then it is not aneuploidy, then it is balanced Robertsonian translocations. Yes, so then it is balanced Robertsonian translocations. Okay, we have already seen the ultrasound intrauterine signs. I already showed it to you before lunch break. So those are the important things to know here as well, right? And I am sure that you all understand that the findings on transvaginal ultrasound are seen 1 week earlier. Okay, so TVS shows findings 1 week earlier than abdominal ultrasound. Is that clear to everyone? So now can you tell me, when you talk about TVS and HCG value, at what value? Okay, so please listen to the question carefully. What is the minimum value of HCG? Okay, at which gestational sac can be seen? Can you tell me? We already talked about the POG, 4.5 to 5 weeks on ultrasound, but at what HCG value? So when we ask you minimum value at which it can be seen, then it is 1000 international units. Very good, excellent, Anisha. But if I ask you with respect to HCG, what is the critical value for, which we also called as discriminatory score? So what is the critical value of HCG or discriminatory score of HCG for TVS? Then what is the answer? Then please remember the answer is 2000 international units, right? So it is 2000 international units. So these are different MCQs. The minimum value at which it can be seen is 1000. The discriminatory score is 2000. Where do we use the discriminatory score? Ectopic pregnancy. Yes. So applied kya hai iska? So remember this. The applied is if HCG is more than or equal to 2000 international units and ultrasound shows signs suggestive of ectopic. I have already told you the difference between suggestive of and diagnostic of, right? So now I am saying the value is more than or equal to 2000 and ultrasound shows signs which are suggestive of ectopic. Then can you tell me what will be the next step in the management? बेटा 1500 पुरानी वैल्यू थी, इट इज नो लॉन्गर 1500. 1500 पे you will actually misdiagnose a lot of intrauterine pregnancies as ectopic. ठीक है, so the cutoff has to be kept higher, which is 2000. Hanji, who is going to tell me what will be the next step in this clinical question? So if the value has crossed the critical value and ultrasound is showing signs of ectopic, then the next step has to be treat as ectopic, not repeat beta. Okay, then the answer has to be treat as ectopic. No. So please understand, NEET PG is asking these questions. So you have to be very clear. We are already seeing signs. All right. So if you are seeing signs suggestive of ectopic and it has crossed, you have to treat as ectopic. When would you repeat? You will repeat when the value is less than 2000 beta. Okay. If HCG is less than 2000 or critical value, then the answer is repeat after 48 hours. Is that clear to everyone? Do you understand the difference? Okay. So पहले वाले का आंसर repeat नहीं है, उसका आंसर treat as ectopic है. ठीक है? I am again saying that this is very important. Please don't do it wrong. The value is more than 2000 and ultrasound is showing you signs suggestive of ectopic. Okay? If you are seeing a complex mass, a ring of fire sign, a tubal ring sign, and now if you see HCG has crossed, then you have to treat. ठीक है बच्चों? Chalo. I am not talking about only empty uterus. Okay? Only empty uterus, yes, then you can repeat because then you are not seeing anything anywhere, not inside, not outside. ठीक है? Chalo. Which of the following gives the best assessment of gestational age? Now, what is the answer? So again, something that the NEET PG people are very fond of asking, bacha. The answer is CRL at 7 to 10 weeks. Okay. So please remember the ideal time of CRL is usually between 7 to 9, sometimes taken up to 10 weeks also. Okay, this is what is ideal or best time. But if we ask you CRL is used up to, so CRL is used as best parameter for gestational age up to actually 14 weeks. Okay, so it is used up to 14 weeks, but the ideal time to measure it is around 7 to 9 weeks. Can you tell me which parameter will you use beyond 14 weeks? So beyond 14 weeks, best individual parameter की बात हो रही है, which is again going to be biparietal diameter, right? So biparietal diameter. Okay, so beyond 14, if we have to answer one, it is BPD. Up to 14, if we have to mark, it will remain as CRL. Acha, I want to quickly know, is mean sac diameter better in the first trimester or CRL better in the first trimester? So we all know that first trimester ultrasound is best for gestational age. Now I am trying to ask you, in the first trimester, what is better? Is it CRL or is it mean sac diameter? So please remember, out of the two, always it is going to be CRL. Once you start seeing the embryo, you will always measure CRL. Okay, is that clear? Okay. Somebody was asking about the Bagel sign. Beta, Bagel sign is just the other name of tubal ring sign. Okay, it just appears like a Bagel. So it is same as tubal ring sign. All right. Perfect. Can you tell me which is the best ultrasound parameter for fetal growth? So which is the best ultrasound parameter for fetal growth? So whenever we ask you single best parameter for growth, then it is abdominal circumference. It is best for gestational age as well as best for IUGR as well as macrosomia. Right? So दोनों के लिए ये अच्छा रहता है. Perfect. Very good. Okay. And what is the best method to assess fetal weight or estimated birth weight? What is the best for estimated birth weight? Then when we talk about estimated birth weight, the best is actually the Hadlock's formula. Okay, Hadlock's formula includes all the fetal biometry. So it will include biparietal diameter, it will include head circumference, femur length as well as abdominal circumference. ठीक है? So अगर combo है, तो please understand the combo is better than abdominal circumference alone. ठीक है? So Hadlock's, because it uses all the parameters, it is more reliable than AC alone. But when you have to mark single best, then it will be AC. ठीक है? Good to go everybody? Chalo, very good. Okay, again, very, very important. Next question for NEET PG again. Which of the following is not true about cell-free fetal DNA test? Could you do it right? Not true. The answer is B. Okay. Currently, please remember, cell-free fetal DNA test is able to not give us the complete karyotype. It is available currently only for trisomy 13, trisomy 18, trisomy 21 and monosomy X. ठीक है? So monosomy X. अभी वो हमें full karyotype नहीं देता. Okay, so please remember, full karyotype cannot be obtained by cell-free fetal DNA test. Can it also tell us about the RH status of the baby? Yes, it can. Okay, it can also tell us about the RH status. Is that clear? Now, let's look at some of the options. Very, very important. They're individual MCQs as well. For example, is it done beyond 10 weeks? Yes. The test can be done any time at and beyond 10 weeks. What do you understand by option A? It is done after a positive biochemical test. This means it is a secondary screening test, where we are using biochemical test as the primary screening. If it turns out to be positive, then we are using it as a secondary screening. So please remember, it is a screening test. And therefore, whenever it turns out to be positive, it has to be followed up with a diagnostic test. Okay, is that clear to everyone? Also, please remember, cell-free fetal DNA, when would the results be obtained? The results are obtained in around 7 to 10 days. Okay, what is the other name for cell-free fetal DNA? It is called as NIPT, non-invasive prenatal test. Okay, so it is also called as non-invasive prenatal test. Can you tell me what sample do we take for this test? What is the sample? It is maternal blood sample. So the concept is that the maternal blood sample will have fetal DNA freely circulating in the blood. Free means it is outside the cells, right? So maternal blood has fetal DNA freely circulating. तो freely का मतलब समझ में आ गया? Outside the cells बेटू. ठीक है? Everybody clear on it? Now, please remember, we might want to ask you, where is this fetal DNA coming from? है ना? So what is the source of this fetal DNA? So when we ask you the source, bacha, the answer has to be, yes, it has to be apoptosis of placental cells. Okay? It has to be apoptosis of the placental cells. Take bacha. So these are some of the must knows about NIPT. Now my question to you is this. So suppose a patient has undergone a dual test. Can you tell me what is a dual test? सारे बच्चे बताएंगे, बहुत important है. These are very basic and very, very high yielding MCQs. So dual test में आता है HCG plus PAP-A, right? Now please remember, if I say that the dual test turns out to be abnormal, which means high risk, and now I ask you, what should you do next? What should be your answer? Let's see. Jaldi se, because I have to ensure कि खाली one-liners नहीं, you are able to apply the logic also, apply the concepts, है ना? So if the question is, your patient has undergone a dual test and it turns out to be high risk, what should you do next? So your answer should be ultrasound for NT. Okay, very good. Yes, excellent. Your answer should be ultrasound for NT. Okay, this together, most commonly used test for screening of Downs is actually a combined test. Okay, so now who is going to tell me what is a combined test? This is what is combined test. So combined is dual test plus ultrasound for nuchal translucency, which means all these are tests of which trimester, bacha? All these, ये कौन से trimester के test हो गए? शाबाश. Yes. So dual test is also a test of first trimester. Ultrasound of NT is also first trimester. Combined test is also first trimester. ठीक है? अभी I'm going to change the MCQ बच्चा. ठीक है? Suppose I ask you, ultrasound for NT shows that my patient is high risk. Which means I am asking you, let's say the value is more than or equal to 3 mm. है ना? अगर अब मैं आपसे पूछूं what is the next test, तो क्या आंसर करोगे? So suppose an MCQ says your patient has ultrasound for NT which is more than 3 mm. What do you do next? So should you answer it as dual test now? The answer is no. Okay, ultrasound for NT has a very high sensitivity for Downs. So now the answer cannot be, exactly, it cannot be dual, right? So now the best answer would be what? CVS for karyotyping. This is the preferred, but yes, can the alternative be NIPT? Yes, the alternative can be NIPT. So both are answers, but the best answer would be CVS for karyotyping. Do you all understand now where we use NIPT? Yes. So when the combined test is abnormal, then again the same things apply. So if the examiner says combined test is abnormal or high risk, the preferred should be CVS for karyotyping. It is a preferred test because it is diagnostic. This is preferred over NIPT. ठीक? So this was just to explain where exactly NIPT will come if you get a clinical MCQ, because I want you to be clear on the clinical aspect as well. ठीक है? चलो आगे बढ़े. We will talk about second trimester screening in a moment. We have another question and then we will talk about it. ठीक? चलो. Question number 19. Again, NEET PG and an important one. So not true about anaphylactoid syndrome of pregnancy. Do you know what is anaphylactoid syndrome of pregnancy? So this is another name for amniotic fluid embolism. Okay, this is just another name for amniotic fluid embolism. Now, please remember, amniotic fluid embolism has to be a clinical diagnosis. Okay, option number B is not a diagnostic test. It is a simply additional testing which helps, but it is not by itself a diagnostic test. Diagnostic test कैसे है, diagnosis कैसे बनाना है? Only clinical. ठीक है? So this is a supportive finding beta. It is not diagnostic. So this is a supportive finding in a woman who has clinical presentation of amniotic fluid embolism. So if my patient has, as I said, if she has clinical features of amniotic fluid, I can use this test as a supportive test, but the diagnosis is clinical. ठीक है? I'll tell you what is the characteristic clinical finding in my patient. So who can tell me the classic presentation of the patient? The classic presentation is the patient will have SOB. What is SOB? Sudden onset of breathlessness, right? So she will have sudden onset of breathlessness. Very quickly, she will develop hypotension. Then very quickly, she will develop a cardiac arrest and she will go into coma, right? So this is the clinical presentation. Most of the times, amniotic fluid embolism happens during labor, right? So now listen to another important thing. amniotic fluid embolism most commonly will be seen during labor as compared to postpartum stage. So postpartum is less common, during labor is more common. During labor mein, we would say, give you a hint, these symptoms usually develop after rupture of membranes, right? So after rupture of membranes, suddenly the patient develops breathlessness, goes into hypotension, cardiac arrest and coma. ठीक है, postpartum भी हो सकता है बच्चे, but most common नहीं है, most common during labor होता है. Now this what we have written right now, so as, yes, so that's exactly point number C, more common during labor. ठीक है. Then as I have written, it presents as cardiorespiratory failure, right? Now please remember, this thing that we have written as clinical presentation is generally called as the first phase of amniotic fluid embolism. Most patients will not survive this because we know that it has a high mortality rate. Okay, so the most patients will actually die. Okay, but some women may survive and then they will enter the second phase. आपके exam में they might even ask you, what is second phase characterized by? What is the answer? So yes, then you have to say DIC or bleeding, right? So the second phase, very good, excellent everybody, is characterized by DIC and bleeding, right? So this is the typical presentation. Is it a rare thing to happen, amniotic fluid embolism, or a common thing to happen? Remember, it is a rare phenomena. That is why, you know, I have given you the incidence. NEET PG वाले ये वाले incidence किसी किसी चीज में डालते हैं. Usually वो correct डाल रहे हैं. ठीक है? So remember, it is a rare thing and therefore we say it is a diagnosis of exclusion. Right? A typical one-liner would be, a lady goes into shock which is unexplained after delivery. So if we say unexplained shock after delivery, yes, Yashika, it is unfortunate, but these things do happen. Even I had one of my co-residents suffer from amniotic fluid embolism, but it happened for her during MTP. She was undergoing an MTP. So these are rare, but we do come across instances in real life as well, right? So shock unexplained after delivery is to be answered as AFE. Okay, whereas if we say immediate shock after delivery, then you are right, it is to be answered as uterine inversion. So keywords को identify करना है बेटा. पहला keyword है unexpected shock, दूसरा keyword है immediate shock. और अगर question हो simply most common cause of shock after delivery, so if it is most common shock after delivery, then you will always answer it as PPH. तो आप मेरी बात ध्यान से सुनेंगे. Shock and death after delivery are because of PPH until proved otherwise. ठीक है? So until proved otherwise, shock and death after delivery is to be answered as postpartum hemorrhage. ठीक है बच्चों? Good to go everyone? I am very happy with how you are answering and how active you are in the class. Makes me give even my 101% for it. So very good. I'm really proud of you. और अच्छे से पढ़ के भी आए हो, मुझे बहुत अच्छा लग रहा है. Keep it up. चलो आगे बढ़े. Okay. The following sign is best seen at what gestational age? What sign is this, Betu? Right. So this is the lambda sign. What else do we call it? We call it as twin peak sign. Okay. So lambda sign as well as twin peak sign, they are the same things. And they are markers of what? Yes, so they are actually markers of dichorionicity. Okay, they're markers of dichorionicity, which means we could show you the same sign and ask you what is the type of pregnancy? तो आंसर क्या करोगे? DCDA, right? So then you will answer it as DCDA. And the best time is 10 to 14 weeks. If you have to mark one beta G, then the single best answer will be 10 weeks. Okay. So SBA means single best answer would be 10 weeks. Similarly, can you tell me what sign would you see in monochorionic twins? So in monochorionic, it is going to be T sign, which is sometimes also called as inverted T. So it's one and the same thing. So T sign or inverted T sign, bacha, are the same things. Okay? Now I have brought some images for you which are important. So the same questions but asked in different formats. So let's understand and let's try and answer. So let's look at the first image. Whenever you get an image like this, the first thing you should see is there a dividing membrane present in between the babies or no? Right? So in this particular picture, okay, would you see a dividing membrane? No. Right? So whenever we see an image and there is no dividing membrane, okay. So if there is no dividing membrane, then they are monoamniotic. And if they are monoamniotic, they have to be monochorionic. Now, who is going to recall and tell me at what time the cell division might have happened? Jaldi batao. What time the cell division might have happened? So this must have happened somewhere between 8 to 12 days. What kind of twins are formed if division happens beyond 12 days? So beyond 12 days, it is going to be conjoined. I want to ask you, is conjoined a type of MA twin? Yes or no? Yes. So conjoined is a type of MA twin. Yahi baat, if INICT people have to ask, they will ask you this. If the division is happening in the or after the formation of embryonic disc. So if cell division happens after formation of embryonic disc, then they will ask you what is formed. So if it is embryonic disc, then it is conjoined. है ना? Exam में question ऐसे ही आता है. This is how they ask in INICT. So topic same है लेकिन चीज बदल जाती है. Whereas if the cell division happens at the time of implantation, then it will be MCMA. ठीक है? At the time of implantation पूछेंगे तो आंसर आएगा MCMA. Also, before I go to the other images, which is the most common type of conjoined twin, beta? So please remember, most common type of conjoined twin is parapagus. Okay, parapagus. Only and only if parapagus is not in the options will you go with thoracopagus. Okay, parapagus hote kya hai, do you know? Joined by lower abdomen and pelvis. Okay, so this is lower abdomen and pelvis. So babies are joined by this part. In thoracopagus, they are joined by thorax and upper abdomen. Right? So thoracopagus is thorax and upper abdomen up to umbilicus. Okay? Which is the rare ones, least common? So least common ka answer hai rachypagus followed by craniopagus. Okay? Now please remember, exam में INICT में पूछा था craniopagus are joined by what? So craniopagus are only and only joined by cranium or skull. So joined by only cranium. If it is head and neck, then it is cephalopagus. ठीक है? Then it is head and neck. Right? But when you say cranio, it means only joined by skull or cranium. ठीक है? Is that clear? All right. So these are some of the common terminologies that have been asked in the exams. Now let us look at this question. So if we look at this image now, do we have a dividing membrane? Yes. Dividing membrane is present. Okay, dividing membrane is present, which means this will be what type of twins? This has to be diamniotic. Now, how will you comment on, can you tell me, how will you comment on chorionicity? So count the number of membranes. Do you see they have only 2 layers? One amnion of this baby and one amnion of the other baby. Which means dividing membrane has only 2 layers. If it has 2 layers, it has to be monochorionic. Okay, it has to be monochorionic. Also, when you see, more than or equal to 3 layers, actually there should be 4. Okay, so actually there should be 4 layers, but any image showing you more than or equal to 3 layers will be dichorionic. Okay, actually there are 4, but sometimes kya hota hai? The chorion of the 2 babies can meet. Okay, chorion of the 2 babies can fuse. So then it will look like amnion here and chorion in between. So then it looks like 3. इसीलिए बहुत जरूरी है कि आप याद रखो, anything more than or equal to 3 should be answered as DCDA. But if the examiner asks you, okay, how many layers in the dividing membrane in dichorionic twins, then what is the single best answer? The single best answer is 4. One amnion and one chorion of one baby, and other amnion and other chorion of the other baby. Okay, is that clear? Yes? Okay. Now, coming to this, very, very important. How will you identify? So, is a dividing membrane present? Yes. And now, what can you see very characteristically? So, you are able to see the dividing membrane. And how many layers? Yes. Can you now see 4 layers? Yes. Can you all appreciate? So that is why this has to be dichorionic and diamniotic. But this image actually shows the best sign of dichorionicity. Who is going to tell me what is the best sign of dichorionicity? The best sign is what? Yes, 2 separate placentas. Can you see here? Right? So if an image clearly shows you 2 separate placentas, you have to answer it as DCDA. That's the best sign. Please remember, is vice versa true? So no, please remember, single placenta can be dichorionic, it can be monochorionic as well. So when I see single placenta, I cannot say mono or di. But when I see 2 separate placentas, then it is definitely dichorionic. What is the other sign? Other good sign. 2 separate placentas or opposite sex twins. Okay. So opposite sex twins are always dichorionic. Okay. Magar, if it is same sex, it can be dichorionic, it can be monochorionic. Okay. Okay. Now coming to some very important one-liners. I'll tell you, bacha, don't worry. So in general, if I, first of all, I want to ask you, at what cell division will DCDA twins form? So DCDA is first 3 days. So if division happens in the first 3 days, it is DCDA. If division happens from 4th to 8th day, then it is MCDA. Okay, then it is MCDA. So please remember, MCDA is the most common type of monozygotic twin. Okay, so among the monozygotic twins, the most common is MCDA. Okay? Yes, now coming to the stages. MCDA is formed. So agar INI-CT mein aayega to kaise aayega? MCDA is formed when the cell division happens in the blastocyst stage. Whereas DCDA will form when cell division happens in the morula stage. Is that clear? Now comes the confuser. if I ask you which is the most common type of twin in general, matlab, I have not asked monozygotic or dizygotic, then what is the answer? So most common type of twins are dizygotic, and therefore you have to answer it as dichorionic and diamniotic. Okay? Is that clear? So please remember, iska incidence or rather prevalence keeps changing. So prevalence varies throughout the world, right? But monozygotic twins ka prevalence is constant, right? Monozygotic twins ka prevalence is constant. Doubt. Suppose I say that a lady has undergone IVF. Can you tell me which type of twins are more common after IVF? So please remember, IVF increases incidence of both. Okay? Dizygotic as well as monozygotic. So it increases incidence of both. But which are most common? The answer will remain as dizygotic. So the only thing which has shown to affect incidence of monozygotic twins is IVF. Okay? Is that clear to everybody? Good to go, everyone. So these are some of the very important topics with respect to twin pregnancy. Remember that the best time for chorionicity is first trimester. Okay. So in general, the best time for chorionicity is first trimester beyond 7 weeks, not before 7 weeks. You cannot talk about chorionicity before 7 weeks. Is that clear to everyone? Chalo. Ready for the next one now? Okay. NEET PG, again, they're fond of asking something or the other about amniotic fluid. So which of these statements about amniotic fluid is false, right? So the answer is A, right? Why? What is wrong here? Because the most common source in the first trimester is ultrafiltrate of maternal plasma. Fetal urine becomes the main source beyond 20 weeks. Okay. But if examiner asks you, when does fetus start producing urine? So when we ask you, when does it start producing urine, then the answer is beyond 12 weeks. So they're all separate MCQs. Don't get confused. Okay. Osmolality is, yes, 260 milliosmoles. It is 98 to 99% water. Williams quotes it as 98. Some of the other textbooks say 99. Right? What is the normal value of AFI? The normal value of AFI is 5 to 24. Right? So anything beyond 24 will be considered as poly. Some textbooks include 24 also in poly. So it is absolutely okay. There is no controversy and don't waste your time on it. So beyond 24 or beyond or equal to 24 is poly. Less than or equal to is oligo. Can you tell me the definitions of poly and oligo in terms of SDP or DVP? So single deep pocket or deep vertical pocket. So what is the criteria for poly? More than or equal to 8. And what is the criteria for oligo? Less than 2, which means 2 to 8 is normal. Right? Which means 2 to 8 is normal. What is the pH of amniotic fluid? So some of the other things, pH of amniotic fluid is usually between 7.1 to 7.3. Maximum value of amniotic fluid is seen at around 32 to 34 weeks. If we ask you post-term, what is the amount? It is around 200 ml. So in a post-term pregnancy, it is around 200 ml. Okay? Can you tell me which out of the two parameters, SDP or AFI, is used in twin pregnancy? Which one do we use in twin pregnancy? So remember, SDP or DVP is the one which can be used in twin pregnancy. We cannot use amniotic fluid index in twin pregnancy. Okay? So it has to be SDP or DVP in twins. Is that clear? Okay, perfect. Can you tell me, if you are seeing a golden colored amniotic fluid, what is the cause? I'm sure jaldi answer karoge aur sabko aata hoga. RH incompatibility. Yes? If you see amniotic fluid which we say is tobacco juice, then what is the answer? Intrauterine death. Okay? And greenish yellow or saffron is what you see in postterm. Yes, these type of questions are not just asked in NEET PG, they are also asked in INI-CT. INI-CT is actually nowadays asking more basics than even NEET PG, right? So for example, what about a term amniotic fluid? It is turbid in color. Okay, it may be slightly yellow, it may be turbid, right? So at term, the amniotic fluid can be turbid, it can also be pale yellow. Is that clear? So these are some important features. We will talk about other things with respective questions, but this is important. Okay? So yes, pale yellow or straw colored, whatever you want to say, it is the same thing. Right? Straw colored, pale yellow, turbid, that is what you see at term. So ye important hai. They seem like one-liners, but even INI-CT is asking. So please be clear of these things. Good to go, everyone? Perfect. Let's go forward. So we talked about APLA antibodies. Now this is a question on APLA, right? A patient is second gravida. She is APLA positive and she has history of preterm delivery in the previous pregnancy, which was secondary to uteroplacental insufficiency, right? What is the treatment that you want to give her? So how many of you marked it as aspirin and heparin? So please remember, heparin is added, okay? Heparin is added only if there is history of, okay, thrombosis or abortions. Okay? So only if there is history of thrombosis or abortions, then you will add heparin. Otherwise, you will not add heparin. देखो अब मेरी बात समझो. It depends on how we are framing the MCQ. If the MCQ is general मतलब कैसे? Suppose you go for the exams and they ask you, drug of choice for APLA in pregnancy. Suppose this is the question. Then what will you mark, bache? Then you all are right. It's a general question. So when they don't give you any details and it's a general question, you will answer it aspirin plus heparin. But look at this question. This is the kind of question that AIMS people will give. They'll give you the same topic but more depth. Now instead of making it general, they are telling you the exact history patient has. So she has history of preterm labor and she is a known case of APLA. So now since there is nothing written about thrombosis or abortions, we will give only aspirin. Is that understandable? Yes. Also, please remember, I told you there are 3 antibodies. How many antibodies do we need to be positive? Any one. So any one antibody plus any one clinical criteria is used for diagnosis of APLA. I need only one clinical criteria and I need one lab criteria. Can you tell me what is the name for this classification or these criteria? Again has been asked as a NAMES MCQ. So this is what is called as Sydney criteria, also called as Sapporo criteria, right? So Sydney criteria or Sapporo criteria is the name of this. Is that clear? ठीक है, so ये याद रखना. मैंने बोला एम्स क्या करता है, स्पेसिफिक चीज मगर और डेप्थ. ठीक, अब अगर हमें डेप्थ समझना है तो प्लीज ऑल्सो रिमेंबर दिस. व्हेन यू टॉक अबाउट क्लिनिकल क्राइटेरिया, how many abortions do you need if they are in the first trimester? So please remember, if the pregnancy is less than 10 weeks, then we need more than or equal to 3 RPL to think of APLA. But if the pregnancy is beyond 10 weeks, then we need 1 abortion or 1 or more, okay, fetal loss. That is why I said more characteristic is second trimester loss. Do you understand why I said that? So beyond 10 weeks, only 1 fetal loss, and this baby has to morphologically normal. Okay, so this baby is morphologically normal. Is that clear? The third clinical criteria you all know is history of preterm labor, which should be less than 34 weeks, which should be secondary to severe preeclampsia or uteroplacental insufficiency. What is the fourth clinical criteria? What is the fourth clinical criteria? The fourth clinical criteria is history of thrombosis. So we need any one of these. Is that clear to everyone? In fact, NEET PG ने भी इस पे clinical question दिया था. They said a lady has undergone recurrent abortions. They were at around 12 weeks. Then she had a pregnancy with preeclampsia. What are you suspecting? So what is the answer? The answer is APLA. ठीक है? So these you should know. You should know the name of the antibodies and you should know the treatment. अच्छा, अगर मैं पूछूं simply drug of choice for APLA, तब? So now we are not asking you in pregnancy. So drug of choice for APLA is actually warfarin. Drug of choice in pregnancy is heparin and aspirin. ठीक है? So drug of choice for APLA in general it is warfarin. These are the clinical criteria. बेटा मैंने लिखा more than or equal to 3 recurrent abortions at less than 10 weeks. More than or equal to 1 fetal loss beyond 10 weeks where the baby is normal. Then history of at least 1 preterm delivery before 34 weeks. The cause has to be either severe preeclampsia or uteroplacental insufficiency. The cause of preterm delivery. Okay. And the fourth is if your patient has history of thrombosis. Is that clear? Okay, chalo. Let's go on to the next question. Again, very, very important for both exams, NEET PG as well as INICT. The following are correctly paired except, right? So could you do it right? What is the answer? So the answer is D, and a very, very important drug which actually your NEET PG exams are very fond of asking. What drug is carboprost? So carboprost is methyl analog of PGF2 alpha. ठीक है? It is also given what? PGF2 alpha, also called as dinoprost, also called as hemabate. Okay, dinoprost also called as hemabate. Please understand this is not dinoprostone. Okay, dinoprostone is actually PGE2. It's a separate drug. You get confused between the two. Okay, so prostone is different, prost is different. What is the dose for carboprost? Yes, 250 micrograms or 0.25 milligrams given intramuscular. NEET PG depth में पूछता है तो what is the maximum dose that you can give? We can give it 8 times, which makes it 2 milligram. Okay, so the maximum dose I can give in one day is 2 milligrams. Okay. Dinoprostone, I already told you what it is. It is used for cervical ripening. The dose is 0.5. How many doses can we give? We can give a maximum of 3 doses. That makes it 1.5 milligrams. Okay, that makes it 1.5 milligrams. Misoprostol, you all know, is PGE1. Please remember, this is the only prostaglandin used in obstetrics which is available as a tablet. So whenever in the MCQ you see PG tablet, then this means they are talking about misoprostol. So if it is a question on OBS or gynae, OBS particularly, and they're saying PG tablet, then it is misoprostol. Okay? So yes, very, very important. The dose of misoprostol for induction of labor is 25 micrograms. How do you give it? Per vaginally. You can put every 4 hourly for a maximum of 6 doses, right? So you can put it every 4 hourly for a maximum of 6 doses, right? The dose for PPH prophylaxis is 600 micrograms and the recommendation by WHO is per oral. Yes, so it's an oral route. Can you tell me what is the dose used for treatment of PPH? Misoprostol? So when we talk about treatment of PPH, then the dose recommended is 800 micrograms sublingual by WHO. An alternative is 1000 micrograms per rectal. Okay, so alternative kya hai? 1000 micrograms per rectal. Is that clear? So these doses are really important. Your exams have been asking these. Especially again, kaun pooch raha hai? Need PG. ठीक है? Okay, perfect. Now when you talk about induction of labor, I have already told you in the previous MCQ, PGE1, which is misoprostol, should not be used in previous cesarean for induction, right? This is again something that they repeatedly ask. With respect to carboprost, okay, I also want you to know this, that carboprost is not used for prophylaxis of PPH. It is used for treatment of PPH. Okay. So it is not used for prophylaxis, used for treatment. On the other hand, dinoprostone, not used for PPH and not used for induction of labor as well. Oh, sorry, not used for PPH, both treatment and prophylaxis. So please, again, इसमें कुछ घबराने वाली बात नहीं है. You know the drugs that are consistently being asked. So be sure that you know at least what these drugs are. You can quickly recall and then answer. So dinoprostone, okay, is only and only used for induction of labor and for abortions. It is not used for PPH. Carboprost, no, that's what I've written. It is not used for prophylaxis of PPH. Prophylaxis is AMT-SL. बहुत सारे बच्चे कार्बोप्रोस्ट और कार्बेटोसिन में कंफ्यूज होते हैं. What is कार्बेटोसिन? What is कार्बेटोसिन? Carbetocin is synthetic oxytocin analog. Okay, this is used in PPH prophylaxis, right? So this is used for prophylaxis of PPH. Dose is something which INI-CT is repeatedly asking for carbetocin. Okay, so for carbetocin, please remember the dose is 100 micrograms slow IV over 1 minute. I am saying INI-CT people are repeatedly asking this. So please know these drugs. I am not trying to cover unique things. It's just the ones that have been consistently asked. So I want to put them at one place for you. Okay? So that you can revise through this itself. Okay? So yes, 100 micrograms slow IV over 1 minute. ठीक, good to go everybody? Okay. चलो आगे बढ़े. So now your patient is G3P2L2. She is 35 weeks pregnant. She has come to us with bleeding and pain. Now the baby is in cephalic presentation. Fetal heart rate is given. Placenta is spundle. There is no RPC. What is the next step? Could you all do it correctly? What is the answer for this one? Tell me. So please remember, this could be a case of what? This is definitely not a case of placenta previa, because the placenta is spundle. I want to ask you, can this case be still a case of abruption? Yes. Which type of abruption? Revealed. Why am I saying revealed? Because the question already says there is no RPC. So this can still be a case of revealed abruption. Can you tell me what can be the other differential? So yes, one is abruption. Can she also be a case of labor? Yes. The other DD is labor. Why would labor have bleeding? Show. So now you have to differentiate whether she is a case of abruption or labor. What will help you differentiate? PV exam, right? So when you do a PV exam, you will be able to know whether the woman is in labor or not. And what can you do during your PV exam to know about abruption? ARM. If you do an artificial rupture of membranes and you see what? And you see what? You see altered or dark colored amniotic fluid. Then you know you are dealing with abruption. Okay? Why not tocolytics? Jaldi batao, why not tocolytics? So please remember, even in preterm labor, okay? So even in preterm labor, beyond 34 weeks, tocolytics are not given. Okay, so even in preterm labor, we don't give tocolytics beyond 34 weeks. Tocolytics are only given up to 34 weeks. Very good, excellent. So proud of you. Aap log, you're making me super happy. I really feel that even if I don't do the discussion, you will do really well. Okay. Okay, someone, I have already taught Vasa Previa Vanshika. Can the fetal heart rate be normal in Vasa Previa? No. So you remember what I said? It is not a case of Vasa Previa. Vasa Previa will be associated with severe fetal distress. Whereas here we are saying that fetal heart rate is absolutely normal. Exactly, this is why you don't even need to do an NST. The FHR is normal. Okay, is that clear? Okay. So this is therefore probably a case of revealed abruption. So we need to do a PV, see whether she is in labor or not, and then do ARM. Who is going to tell me what features on PA exam, okay, will help you know that this is a case of abruption? So if you go for MCQs and you get a clinical vignette, what are the keywords on PA exam to tell you it is abruption? So number one, the MCQ may say tense uterus, tender uterus. Okay. Second, fundal height more than period of gestation. Okay. Third, fetal distress. There may be evidence of fetal distress. So tense uterus, tender uterus, fundal height more than POG, evidence of fetal distress. Fetal parts are difficult to feel. Not, ऐसा नहीं है कि not felt है, but fetal parts are difficult to feel. So these are important PA findings that will help you know that this is probably a case of abruption. Yes, मगर इस case में हमें ऐसे कुछ भी नहीं है. तो most likely she is a case of what? Preterm labor. Is that clear to everyone? Now quickly, when we say preterm labor, and I have already told you tocolytics are to be given only if the pregnancy is less than 34. Can you tell me what is in general the tocolytic of choice? So in general, the tocolytic of choice is nifedipine, okay, which is a calcium channel blocker. Is indomethacin also a tocolytic? Yes. Indomethacin is also a tocolytic, but please remember, indomethacin is given only if pregnancy is less than 32 weeks. Yes? Can you tell me why? So, इंडोमेथेसिन के लिए दो चीजें याद रखेंगे. Number one, when you give beyond 32, it will cause premature closure of ductus arteriosus. Okay, if you give it beyond 32, it will cause premature closure of ductus arteriosus. दूसरा बात, indomethacin should not be given beyond 48 hours. Yes. Why not for beyond 48 hours? Because then it will cause oligohydramnios. So these are the two things which you have to remember with indomethacin. क्या दो बातें याद रखोगे? Premature closure of ductus arteriosus when given beyond 32. And when it is given for more than 48 hours, it will cause oligohydramnios. ठीक है? Perfect. Very good. Super proud. Should I go ahead now? Chalo. Acute fatty liver of pregnancy, very important for both exams, INI-CT as well as NEET PG. ठीक है? So let's see. Which of the following statement is true? Chalo. Is the incidence 1 in 1000? No. It is actually a rare thing to happen. 1 in 1000 is very common. The incidence is actually 1 in 20,000 pregnancies. Okay. Commonly presents in the third trimester. Is that true? Yes. This is the true statement. Most commonly it presents in the third trimester. More common in multipara. Is that true? No. It is again more common in primigravidas and more common with male fetus. है ना? तभी आप confuse हो रहे थे between obstetric cholestasis and AFLP. ठीक? Now, can you tell me what else is risk factor? Other risk factors are multifetal pregnancy. Okay? So, multifetal pregnancy. Okay. Hanji. So, coming back again, multifetal pregnancy is an important risk factor. Please remember, 50% of patients, okay, 50% of patients with acute fatty liver of pregnancy also have preeclampsia. Okay, so 50% of patients will also have underlying preeclampsia. Is that clear to everyone? Now, can you tell me which enzyme deficiency has been linked to it? Which enzyme deficiency? So, LCHAD. Okay, LCHAD. And who is homozygous for this enzyme deficiency? The baby or the mother? So, please remember, the fetus is homozygous for this enzyme deficiency, while the mother is heterozygous. So, yet another risk factor is LCHAD deficiency. Okay, is that clear? Now, please remember, when it comes to AFLP, if they are going to make a clinical question, they basically want you to differentiate AFLP from HELP. Okay? So what you have to remember is that HELP is mild liver injury. While what about AFLP? AFLP is acute liver failure. It is a severe liver injury. So you know when you read an MCQ which looks like help initially, ठीक है, आपने शुरू में पढ़ा and the question looks like help syndrome, but if the MCQ or the patient has any of the following, then you will change the answer to AFLP. What are these? Any of the following? So if patient has signs of encephalopathy, if patient has raised ammonia levels or low glucose, that is hypoglycemia, okay, then if my patient has rising creatinine values, if my patient develops coagulation failure, and if my patient develops secondary complications like pancreatitis, okay, so if which they might write in the form of raised amylase levels, right? Then, so if your patient has any of the following, then you should answer it as acute fatty liver and not really as HELP syndrome. Is this clear? Yeah. Okay, so if my patient develops secondary complications, yes, so AFLP is important. You should know when to mark AFLP and when to mark HELP syndrome. Is that clear to everyone? Please remember it has a high mortality rate, AFLP. Okay, so AFLP में patient has a high mortality rate, इसीलिए irrespective, okay, so irrespective of age, management is termination of pregnancy. Okay, management is termination of pregnancy. Is that clear, everyone? Yes. So those are important things that you should know about acute fatty liver. And please remember, we say it is a closed DD for HELP because it presents in a very similar way. So both present in the third trimester. And what is the most common presentation for both? Acute fatty liver as well as AFLP. They will most commonly present as pain. Okay, dono. Pain which is more in the epigastrium or right upper quadrant. Right, so epigastrium or right upper quadrant. ठीक है बच्चा, good to go everyone, आगे बढ़े. चलो, okay, जल्दी जल्दी आंसर करना है. मैं I am seeing that the interaction has reduced, so post meal सोना नहीं है. Okay, keep having water and that keeps you awake. So keep having water, sona nahi hai, you have to answer in the class as much as you can because that is like a super revision for you. Okay, chalo. So all the following are true about the measurement shown here except what is the measurement that we are showing you? So this is an image of nuchal translucency. Yes, now let's look at this. What is wrong? So it doesn't have to be a coronal view. What view is this? It has to be a sagittal view. Okay, so it has to be a sagittal view. Neutral position of the head का क्या मतलब होता है? No flexion and extension. ठीक? Fetus must be kept away from amnion. So here, you can see the amnion separately and the fluid collection separately. And where do we take the measurements? We take the measurement in the widest area. Okay, so it has to be taken in the widest area and it has to be taken from inner to inner border. So these are the kind of details that INI-CT people tend to ask. As I said, INI-CT will go to more depth. Okay, what are the other things that NEET PG people would also ask? So now, what is the ideal time to measure this? The ideal time to measure is 11 to 13 plus 6. Okay. Anything more than or equal to 3 mm is considered as increased NT. Okay. Now we've done some clinical application before, we'll do some clinical application now. So if I have to tell you that your patient has increased NT, what is the most important association? So remember, the most important association is aneuploidy. So it's actually a marker of aneuploidy, right? Now, if it is a marker of aneuploidy, which aneuploidy is it going to be? So most commonly it is going to be trisomy 21 followed by monosomy X, है ना? Followed by monosomy X. What is the clinical application? We have already done. Because of the strongest association with aneuploidy, when we say there is increased NT, the application is the bachcha must undergo karyotyping. Okay? Now, what is the second application? Suppose the karyotype is normal. Okay? So if karyotype turns out to be normal, then what should you suspect with increased NT? Suspect cardiac anomalies. So second leading cause is cardiac anomalies, which means now if I ask you the application, what should this bachcha undergo? The answer should be fetal echo as well as level 2 scan, right? So fetal echo as well as level 2 scan. Can you tell me when do you do both these things? Again, these are the kind of things that INI-CT people will go to the depth of. So now tell me, what is the time to do fetal echo as well as level 2 scan? 18 to 22 weeks, right? So 18 to 22 weeks. Okay. Can you tell me if my patient has increased NT and if pregnancy is twin pregnancy, then what should you suspect? So what is the application now? Now application is twin-twin transfusion syndrome. So the third important cause is twin-twin transfusion syndrome. ठीक है? So please remember this. इसके अलावा certain genetic syndromes may be linked to increased NT. Okay, but they are uncommon causes. So the first three are the ones that you have to remember as causes of increased NT. ठीक है बच्चा? Is that clear to everybody? Very good. Now, we have already talked about first trimester marker. I want to know from you about the second trimester marker. So let's see who can tell me. Quad test as well as triple test. Both are done at what trimesters? Anywhere from 15 to 22 weeks. है ना? So anywhere I can do it from 15 to 22 weeks. Quad में क्या क्या होता है? HCG, alpha fetoprotein, okay, UE3 and inhibin A. Okay, inhibin A, not B. This is what the NEET PG tends to confuse you with. Triple में क्या होता है? It has HCG, AFP, UE3, but does not include inhibin A. The same thing INI-CT people ask. They will ask you about triple, but instead of triple, they'll ask you which is not a component of BART test. So please remember, BART and Kettering are other names for triple test. Okay, they are just other names for triple test. BART test, B-A-R-T, and Kettering test. See? All right. Now I want you to see two images with respect to this, or maybe I think. Okay. Okay, just give me a moment, it's opening up. Yeah. Okay, who's going to tell me what is this an image of? It's a very simple image and we must not do it wrong. So this is what an image of amniocentesis looks like. है ना? So कब करते हैं amniocentesis? Any time beyond 15 weeks, most commonly between 16 to 18. Who is going to tell me what is early amnio? Early amnio has been twice asked in AIMS exam. So what is early amnio? When you do it between 11 to 14. Do we do it in modern obstetrics? No, we don't. Okay. So we don't really do early amnio because this has high fetal loss rate. Okay, so it has high fetal loss rate, so इसलिए नहीं करते. Is that clear? Okay. Please remember, in amniocentesis, results are obtained in 10 to 14 days. What is the blood or what is the sample that you get here? So it has to be either amniocytes or dermal fibroblasts. Okay. So amniocytes or dermal fibroblast. What about CVS? So please remember, CVS can be done anytime beyond 10 weeks. Okay. Should not be done at less than 9 weeks because it will cause limb defects. Most commonly, CVS is done between 11 to 13 weeks. Most commonly between 11 to 13 weeks. Results are obtained much faster with CVS in 48 hours. Right? So much faster results. But as compared of the two, I want to ask you about within amnio and CVS, which is more safe and more reliable. So please remember, amnio is in general considered more safe and reliable. Yes, the tissue that we use in CVS is going to be trophoblasts. Okay, it's going to be the trophoblast. So those are important points, bachas, that you should know about CVS, amnio, NT, dual marker, combined test, quad test, and so on. Right? These are easy questions and scoring ones. Let's go on to the next one. So which of the following is not true for complete mole? So is option number 1 true? Yes. 80% of times, the range is 80 to 90. The karyotype is 46XX. Only in 10 to 20% the karyotype can be 46XY. They are dispermic? No, this is a false statement. They are actually monospermic. Cheek? Are they more common than partial moles? Yes, definitely yes. They are the most common type of molar. And they are the ones which are associated with theca lutein cyst. Please remember, these tend to be large, they tend to be bilateral, and they tend to be multilocular. So large, bilateral, and multilocular, theca lutein cyst. Okay. Also, please remember the characteristic features with respect to complete mole. And I think some of them we might see it with the image also. So I've brought 2 images for you. Let's look at those images. So, you know, the new pattern is they may show you this. So they will show you this pathology and they will ask you, this is pathogenesis of which type of pregnancy? So do you see here that this ovum, can you all see the ovum? Do you see that it is an empty ovum? Yes. So this is maternal chromosome inactivation. So this is an empty ovum. So when you see an empty ovum being fertilized and then there is a duplication, this is complete mole. Okay. On the other hand, when you see the ovum has chromosomes and it is being fertilized by 2 sperms, so dispermic. Okay. Then resulting in triploidy. This is what is a partial mole. So they may show you the image and then ask you, right? So you should know that this is the image of complete mole, this is the image of partial mole. Also, when you talk about complete moles, okay, when we talk about complete moles, this is a classic ultrasound image very often asked in the exams. So what is this image called as? So you all know that this is called as snowstorm, right? Do you know what is the other name? The other name is honeycomb appearance. Very characteristic to complete moles. This is because of hydropic degeneration of the placenta. And you have to know that there is a complete hydropic degeneration. So there is a complete hydropic degeneration of the placenta. Do you see a baby here? No. So no fetus, right? So these are all characteristic features of complete moles. Please remember, complete moles are P57 stain negative. Okay, they do not stain with P57 immunostaining, they are stain negative. Okay, remember they do have villi. So villi are present, but what is the classic feature? These villi are avascular. Okay, also when I say it is a trophoblastic disease, okay, this is one of the components of GTD. So remember, नीट पीजी वाले कई बार बेसिक्स में कंफ्यूज करते हैं. So when we say GTD, it includes both molar pregnancy as well as gestational trophoblastic neoplasia. है ना? So it includes both बच्चे. So now remember that when we talk about trophoblastic disease, especially complete mole, is it a disease of amnion, chorion, or is it a disease of decidua? What is it a disease of? Batao. So please remember, molar pregnancy is actually a disease of chorion. Okay. There is extensive trophoblastic proliferation. है ना? So what we see is extensive trophoblastic proliferation. Remember, I have already shown you the karyotype. So please remember, this is the most common karyotype, 46XX. Okay, these are the kind of questions that you get repeatedly in INICT, in NEET PG. So ये बहुत जरूरी है. ठीक? What is the treatment of theca lutein cyst? Anybody can tell me? So theca lutein cyst is what you will see in the ovary. But what is the treatment? So यहाँ पे लिख लेते हैं. Please remember, treatment of choice for molar pregnancy is suction and evacuation. So once you do suction evacuation, theca lutein cyst will disappear within 2 to 4 months. Right? So these cysts will usually disappear within 2 to 4 months after you do the suction evacuation. ठीक है? All right. Perfect. Good, good, good. Well done. चलो आगे बढ़ते हैं. Okay. Now this is a typical NEET PG question where they give you a little longish history और पूरा time तुम history पढ़ के सोच रहे होते हो what is the diagnosis, जबकि end में वो diagnosis भी बता देते हैं. For example, look at this patient. They are already telling you she is diagnosed as a case of septic pelvic thrombophlebitis, right? So we have to say what statement is true. Now, what is the classical presentation of septic pelvic thrombophlebitis? That patient after delivery has fever. So these patients develop postpartum fever. ठीक है? Majority of times when they develop fever in the post-operative, this is usually within first few weeks. Okay. Contraception of choice for molar is OCP बच्चे. अभी एक और जगह हम करेंगे GTN जहां बात करेंगे, but yes, we can write here that contraception of choice for molar pregnancies is OCP. And which contraceptive method should be avoided? Which contraceptive method? So remember, avoided में क्या है? Intrauterine device. Okay, so IUDs are to be avoided. ठीक? हाँ, चलो, coming to this. So patient presents with postpartum fever, and the important thing with septic pelvic thrombophlebitis is that when they have fever, you give antibiotics, and the patients do not respond very well to antibiotics. So look at option number B. This is what happens. You know that when you talk about antibiotics, initially antibiotics have to be given because this is septic septic pelvic thrombophlebitis. So septic का मतलब होता है it is a local infection of the pelvic veins or vessels, right? So septic thrombophlebitis. Now please remember, no doubt these patients need to be given antibiotics because it is septic, but the other word is thrombophlebitis. The patients with antibiotic alone may not respond, but when you add heparin, they show a dramatic response. So the treatment of choice actually for this condition is antibiotics plus heparin. मैंने बोला सस्पेक्ट कैसे करना है जब ओनली एंटीबायोटिक्स देके फीवर मे नॉट बी सबसाइडिंग, द फीवर कंटिन्यूज. ओके, नाउ लेट्स लुक एट द पॉइंट्स हियर. Involves both iliofemoral and ovarian veins? No. So more commonly it will involve ovarian vein. Okay, and in the ovarian vein they will involve usually the right vein more than the left. Who can tell me why? Also remember, आप मुझे why सोच के बताओ, मैं आगे बता रही हूँ, ठीक है. Also remember, the patients with involvement of ovarian pain will usually present with abdominal or pelvic pain, right, and with fever. As I said initially, you will give antibiotics thinking इनको infection है, but alone antibiotics are not useful. Now that is why, although we are saying the option number B is not absolutely correct. The B says antimicrobial therapy is ineffective. So that's not true. Antimicrobial is effective, but it has to be given with heparin therapy. Okay. Fever spikes are rare? No. That is the most common presentation. The presentation itself is with fever. And the answer therefore is heparin. Now the question is, or other questions that we could ask is, yes, so the reason is because right ovarian vein has a longer course. It is also valveless. Okay, that is why it is more commonly involved. Investigation क्या कर सकते हैं? We can do a CT scan, we can do an MRI, we can also do a pelvic exam. Can you tell me what can be a possible finding on the pelvic examination? We may be able to feel a cord-like structure. This cord-like structure is actually the thrombosed vein. Even in CT MRI, you may be able to see the thrombosed vein. Okay. What should we do with the heparin therapy? So you continue heparin, and as I said, the fever will subside. So now the heparin is given for at least 48 hours after fever subsides. Okay, so give it for at least 48 hours after the fever subsides. And if you could also feel a thrombosed vein or there is evidence of thrombosed vein on CT or MRI, then you should continue for 6 weeks. So if evidence of thrombosed vein present, this may be present on palpation, it may be present on CT, on MRI, but if the evidence is present, then continue heparin for 6 weeks. Okay. Please remember that the iliofemoral and ovarian veins are usually not involved together. It's usually one of these venous systems. So more commonly ovarian, less commonly iliofemoral. Okay, so this is a slightly off topic, and this is what I said when, when I mentioned that NEET PG go into more of width. So these are typically more width-based questions for NEET PG. INI-CT, some specific things, but actually to the depth. Okay, chalo. Okay, this is an easy one, and again a NEET PG favorite one. You should all have be able to tell me this. Tell me. So a patient after birth, okay, bleeds massively. She goes into shock, almost near shock, and 9 units of blood are transfused. So what is the late sequelae? Yes, so the sequelae that we are looking for is Sheehan syndrome, a typical description of a woman with severe PPH The complication she develops is Sheehan's. Quickly tell me these, although I'm sure you might have done it in medicine. What is the most common presentation? So the most common presentation is, yes, failure to lactate. Second most common, persistent amenorrhea. Who is going to tell me what will happen to LH-FSH levels? बताओ LH-FSH levels क्या होगा? They will be highly suppressed. Why? Because all anterior pituitary hormones are suppressed or decreased. Because there is infarction of the anterior pituitary. Okay? Perfect. Can you tell me which is the first hormone to be affected? So when we ask you first hormone, the answer should be growth hormone, right? Growth hormone. Can you also tell me what would be if I have to integrate? I might show you a radiological image. Let's say MRI brain. Can you tell me what would be the findings in the MRI brain? So MRI brain will typically show an empty sella sign. Yes, so you will see an empty sella sign. Please remember, posterior pituitary is usually spared. Right? So posterior pituitary is usually spared. It's usually the anterior pituitary. Okay? And if I ask you, can Sheehan syndrome present as adrenal insufficiency? Yes or no? Yes. So please remember, can also later present as adrenal insufficiency. Treatment में क्या करना पड़ेगा? We'll have to replace all the anterior pituitary hormones. Okay. Now, very important. Will it cause primary amenorrhea or secondary amenorrhea? I know it's not gynae test, but still, primary or secondary. So you have to know that Sheehan's presents as secondary amenorrhea. Okay. So it will typically present as secondary amenorrhea. Okay. So those are the other places or things that you should know. Please remember, when it comes to Sheehan's, the karyotype of the patient will be absolutely normal, right? So she is going to have a normal karyotype. She has normal ovaries and a normal uterus. Okay? So, normal ovary, normal uterus, normal karyotype, but the hormones are going to be suppressed. Is that clear to everybody? Chalo, perfect. Treatment, whatever medicine people have taught you, follow that. Okay, it is primarily a medicine topic. They just integrate it with obstetrics and ask. Chalo, let's do this now. So again, a simple one. I'm sure you were all able to pick it up. So patient has undergone shoulder dystocia. Okay, the baby delivers and shows this image, or this is the newborn baby. So this is a typical MCQ, again, NEET PG format. Okay, NEET PG वाले आपको newborn babies की photo देते रहते हैं and keep asking you what was the problem in the mother or during the pregnancy. So this is a classic image of Erb's palsy. मुझे बताओ Erb's palsy में ये कौन सा tip hand होता है? Let's correlate with anatomy. They may integrate with anatomy. So policeman tip hand. Do you see the position of the hand? It is adducted. Yes, internally rotated and the wrist is flexed. Which nerve segments? C5 and C6. So हो सकता है ऐसे दिखा के लेकिन पूछे core anatomy. ठीक है? So C5, C6. Also please remember, this is the most common fetal complication of shoulder dystocia. What is the most common maternal complication? Anybody? So when we ask you most common maternal complication of shoulder dystocia, then it should be answered as postpartum hemorrhage. Okay? Then answered as PPH. Now quickly, coming to shoulder dystocia, in which kind of pregnancies will you come across this? Diabetic pregnancy and pregnancy where there is macrosomia. So those could be other hints for shoulder dystocia. Then what is the keyword in terms of clinical presentation? The keyword will be turtle sign. Do you all know what is turtle sign? What is turtle sign? So turtle sign is sudden retraction of fetal head towards perineum. Okay, so the fetal head retracts and there is a delay in the delivery of the shoulders, right? So they may write this. Then if I typically look for NEET PG, they are not just interested in the name of the sign. So I'm sure by now all of you know the mnemonic helper. So ये जरूरी है बच्चे, लेकिन इसमें ना बहुत डेप्थ में नहीं जाना है. Don't waste your time on stupid things. Remember the sequence. That's where the NEET PG people confuse you. So they will specially ask you, are you going to first give or do macrobursts, or are you going to first give suprapubic pressure? What is done first? Batao? What is done first? So please remember, macrobursts is done first. Okay, so first we do macrobursts alone. If macrobursts alone doesn't help, then we go to suprapubic pressure. So ये जरूरी है, ये एग्जाम में नीट पीजी वाले आपको कंफ्यूज करते हैं, ठीक है. Second thing, never ever give fundal pressure. Okay, so fundal pressure is contraindicated. I have already told you, can we give episiotomy? Yes, so E is actually episiotomy, and very importantly, you have to empty the bladder. I'm trying to highlight points which NEET PG people are fond of asking. What is H actually? Call for help. Okay, call for help. Here, can you also tell me which maternal nerve injury can you do while you're doing macrobursts? So which nerve injury? So we can injure the lateral cutaneous nerve of thigh. Okay? Okay. Remember, E is enter maneuvers or rotational maneuvers. You just should know the names and no more details are required. So, Wood's corkscrew. What is the other name? Rubin's maneuver. Okay. The R, first R is removal of posterior arm. And last R is roll over maneuver. Okay. The rollover maneuver is actually called as Gaskin maneuver or Gaskin all fours. The other format in which the NEET PG will ask you is, what is the first maneuver? What is the last maneuver? So remember, the first maneuver for shoulder dystocia is macrobursts. What is the last maneuver? The last maneuver is Zavanelli. Doubt. Can I do cleidotomy and can I do symphysiotomy? So please remember, as far as cleidotomy is concerned, it can be done. But as far as symphysiotomy is concerned, it is not done. Okay? So please remember this. Okay? Cleidotomy can be done. Symphysiotomy is not to be done. So maternal destructive procedures are not to be done. But cleidotomy, in order to prevent injury to the brachial plexus, I can actually do a cleidotomy. What is cleidotomy? You will cut the anterior clavicle or fracture the anterior clavicle of the baby. So that reduces the bisacromial diameter. Okay? So cleidotomy can be done, not symphysiotomy. Okay? No. You can even do it on a live baby. The idea is we are trying to do a smaller injury to protect a bigger one. What is the bigger one? Permanent brachial plexus injury. See, then I preferably can do a fracture of the clavicle. वो तो heal हो जाएगा. But brachial plexus injury अगर हो गई तो वो heal नहीं हो सकती. Is that clear? ठीक है? So these are important points that you should know with respect to shoulder dystocia. ठीक है बच्चा? चलो आगे बढ़े. Okay, let's look at this one. So your patient is a primigravida. Okay, She's been in labor for 16 hours and she is fully dilated for 3 hours. Okay. Now, the fetal vertex is ROP. The station is +1. It is a molded head. There has been mild late decelerations. Okay. And the pH has gone from 7.27 to 7.20. Okay. Now what is the case? What is this a case of? Can you tell me? Can I say this is a case of arrest of second stage? Yes or no? Yes. Why do I say arrest of second stage? Because in primigravidas, the criteria is 3 hours. And in multigravidas, the criteria is 2 hours. So if there is no descent / rotation for 3 hours in primi and 2 hours in multi. So definitely I am dealing with arrest of second stage. My doubt. Is this arrest of second stage also associated with fetal distress? Yes or no? Yes. So there is evidence of fetal distress. Yes. What is the evidence? Cord pH. Look at what has happened to the cord pH. What is the normal pH of the umbilical cord? Normally, it should be between 7.25 to 7.35. If it is between 7.20 and 7.25, this is borderline. And once it goes below 7.20, there is acidosis. So we see that the pH is going in the range of acidosis now. Okay. So you are seeing second stage arrest with fetal distress. Now whenever there is fetal distress and there is an arrest, there are only two options. Yes. Can I do instrumental delivery? The answer is yes, I can do instrumental delivery in the second stage. तो मेरी बात बहुत ध्यान से सुनोगे, ये typical NEET PG MCQs हैं, ठीक है? So what I am saying is, once there is a second stage arrest with fetal distress, I can either do instrumental delivery or I can do a cesarean. Why is the answer here not forceps? Why is the answer here cesarean? Because look at the station, right? What is the station? The station is +1. Do you apply forceps at +1? No, right? So the instrumental delivery is not an option here for various reasons. The first reason is head is high up. Okay. So head is high up. Second, do you see what we have written? There is molding. Molding का मतलब है evidence of cephalopelvic disproportion. Do you do instrumental delivery if there is CPD? Absolutely no. If there is CPD, you cannot do instrumental delivery. Third, this is a case of occipito posterior. In OP position, we prefer to deliver by cesarean section. Why? Because the head is usually deflexed and bigger diameters come out. So because bigger diameter is coming out, I don't want to do instrumental delivery. So even if the option had vacuum, can that be an answer? A big no. So again, as I said, आजकल NEET PG ये सब बहुत पूछ रहा है, आप ध्यान दोगे. So instrumental delivery will not be done if the head is high up. It will not be done if there is molding, if there is caput. ठीक है? It will not be done, especially if the head is deflexed. So even if vacuum had been in the options, the answer would remain as cesarean section. Is that clear? Yes? Okay, perfect. On the other hand, when you talk about active phase arrest, what are the criteria? So active phase arrest is when it is what? When it is no change in cervical dilatation for A, 4 hours, and criteria of 4 hours is used with adequate contraction. What is the criteria used? Okay, what is the criteria used if it is with inadequate contractions? With inadequate contraction, it is going to be what? 6 hours, right? So then it will be 6 hours. What is the basic difference between second stage arrest and active phase arrest? So active phase arrest में, once you say there is fetal distress, the answer is cesarean, even without waiting for 4 hours or 6 hours. Do you understand that? So we are not going to wait for 4 hours or 6 hours if there is fetal distress. Also, please remember, there is no role of instrumental delivery if there is fetal distress in the active phase. Only and only instrumental delivery is done in the second stage fetal distress. Is that clear? These criteria by themselves are asked in INI-CT exactly like this. So INI-CT is asking you the values. NEET PG is making clinical questions and asking you. For last 2 sessions, NEET PG has been constantly asking this kind of a question. That is why I deliberately put this question. Yes, people, if you have given the exam prior, you will actually recall that these or this particular MCQ has been repeatedly coming in NEET PG. Okay, so your concepts have to be very clear. Okay, please remember, for active phase arrest, membranes must be ruptured. And what should be the dilatation? So to call it as an active phase arrest, the dilatation should be more than or equal to 6 centimeters. Is that clear? Now please remember, there are 3 things that you need to know with respect to active phase. So when I talk about active phase, unfortunately we have to remember 3 different things. If it is saying when does active phase start with respect to modified partograph, which has been a question multiple times, it is also a PYQ, then the answer is at and beyond 4 centimeters. Okay. If the question is only and only specifying based on labor care guide, then the answer is beyond or equal to 5 centimeters. Please understand, labor care guide कोई नई नहीं है, आपको बेवकूफ बनाया जाता है by people who want to keep selling their app repeatedly. Labor care guide 2020 में आ चुकी है. It is 3 years old. It is not an update. Okay. And since that time, not even a single question has come. So stop wasting your time on unusual things, because people have to keep selling you new videos. They'll keep making unnecessary things and bombarding at you. Okay? So please understand, unless they really talk about it, specifying labor care guide, only then mention 5. And based on ACOG criteria, which is what we follow in clinics as well as in these guidelines for arrest, it is considered as more than or equal to 6 centimeters. Labor care guide और partograph में सिर्फ 2-3 ही फर्क हैं. There are only few differences. The first difference is this, that in modified partograph, it is starting at 4 centimeters. Okay. Whereas in labor care guide, it is starting at 5 centimeters. What is the second difference? The second difference is that in modified partograph, जो अभी तक use हो रहा था, okay, in this there is a action line and there is a alert line. ठीक है? Labor care guide में there is no alert and action line. Okay, so there is no concept of alert line, no concept of action line. Is that clear? So the first difference is the timing at which we start plotting. That's what the exam asks. So especially INI-CT. INI-CT specify करता है. So if they ask you when do you start plotting based on modified WHO partograph, it is 4 centimeters. If they ask you when do you start plotting based on labor care guide, then it is 5 centimeters. There is an alert line and action line. Okay. Please understand this in only and only partograph. The labor care guide partograph does not have alert and action line. The modified partograph has it. Okay? That is the second difference. The third difference is we don't have any specific time to say that this is slow labor, this is prolonged labor as far as labor care guide partograph is concerned. Please remember this. When we talk about labor care guide, for every centimeter of dilatation, a separate upper limit of time is given. And if the woman crosses that time in that centimeter, then you say it is slow labor or abnormal labor. For example, in the labor care guide, they will say she should be at 5 centimeters for 5 hours. If she is at 5 centimeters for 7 hours, 6 hours, which means beyond that cutoff, then the labor becomes slow. Do you get me? Do you all understand? Similarly, they will give you at 6 centimeters, she can stay at 6 for X number, let's say 4 hours. So if she stays at 6 centimeters for 5 hours, it becomes abnormal. On the other hand, when we talked about modified WHO partograph, here we had a standard cutoff. What was the cutoff? That minimum requirement for normal progress. Okay, minimal requirement for normal progress was 1 centimeter per hour. Anything less than 1 centimeter per hour was considered as slow labor. So this is no longer followed. For every centimeter, they have a different time cutoff limit. Okay, is that clear? So these are some of the differences in plotting the labor care guide partograph and the modified WHO partograph. Okay, is that clear? So just know the differences. There is no need to bother yourself with anything more than that. All right. Also, as I said, INI-CT people tend to ask some, even NEET PG for that matter. Can you tell me what is the average rate of progress in primi gravidas? So average rate of cervical dilatation in primi gravidas. So remember, in primi it is 1.2 centimeters per hour. And in multi it is 1.5 centimeters per hour. But is the criteria of slow labor different for primi and multi? No, that's where they confuse you. So concepts अच्छे से clear रखो. Please remember, based on this, yes, the average rate is different. But when we talk about slow labor, it is irrespective of primi and multi. As I said, then there is only one cutoff. Anything which is less than 1 centimeter per hour. Okay, have I made myself clear? Okay. Quickly, I want you to see these two partographs that I got for you. Okay. Please remember, as soon as the graph reaches the action line, okay, it means you have to take an action. Okay, which means you have to do some intervention. Once it crosses alert line, what are you supposed to do if it crosses the alert line? So if it crosses alert line on right, then you are supposed to either refer her to a higher center or do more intensive monitoring. If she is already at the higher center, you do the monitoring. Okay? Please remember, in the time axis, okay, in the time axis, 1 square corresponds to 1 hour. These are the MCQs which have been asked by INI-CT. So 1 square corresponds to 1 hour. At what frequency do you monitor FHR? 30 minutes. Which means 1 square in FHR corresponds to 30 minutes. How frequently are you going to monitor uterine contractions? So uterine contractions also every 30 minutes. And here 1 square corresponds to 1 contraction. And what will you count? You will count number of contractions in 10 minutes. Okay, is that clear? How frequently do you do a PV exam? PV is done every 4 hourly, right? So these are the points that are important for you as far as PYQs are concerned. They are all PYQs. ठीक है? So ये देख लो, इसके बाद मैं एक और ग्राफ दिखाऊंगी जो नीट पीजी में पूछा गया है. So these are basics of the modified WHO partograph that AIMS people have asked. ठीक है? Now, after this, look at this graph. Any graph which is showing you a straight line. So look at this. So we are plotting the cervical dilatation with an X. And look at this. This is a straight line. When you see a straight line, this is what is representing arrest. Okay. This represents arrest of what? Active phase. I want you to see in this MCQ, for how long are we waiting before we did a cesarean? Batao? So do you see that I am waiting only for 3 hours in this patient? So look at this. 1, 2, 3. Right? Abhi मैंने आपको बताया with adequate contractions. So this patient has adequate contractions. We were supposed to wait for 4 hours. Why are we waiting only for 3 hours? Batao? Why are we waiting only for 3 hours? So then you should always look at heart rate. Do you see that the heart rate has begun to dip? Yes. So because there is fetal distress, I am not waiting for 1 more hour. I am straight away taking her for cesarean. Also, what do you think is the cause here? Look at the partograph. ये नीट पीजी का क्वेश्चन है. उन्होंने हाथ से बनाकर दिया था. Look at this area now. What is M and 3 plus? M means the baby has passed meconium. What is 3 plus? Molding. So what do you think is the cause of this arrest? This is again something that the NEET PG people are asking you. So please remember, the most common cause of arrest of active phase is cephalopelvic disproportion. So straight line represents arrest. Okay. These boxes which we have colored solidly are contractions. Yes. So this is what you are supposed to see. Okay. And this, as I said, this is what NEET PG people have been asking. और इसके पहले वाला graph is what are PYQs for INI-CT exam. Is it clear to anyone? Everyone? Okay. I'll move forward now. Anybody who wants to go through again, the video would be available. You can go through this part again as well. Okay? Okay. Let's go on to the next question now. So let's look at this. Your patient is coming for her routine visit at 32 weeks. The fundal height is measuring 40 centimeters. Okay. There is evidence of polyhydramnios, but along with that, the fetus has ascites and scalp edema, right? Can you tell me what is this a case of? So this is actually a case of hydrops fetalis, right? This is a case of hydrops fetalis. Who is going to tell me, is this immune hydrops or non-immune? Non-immune, because nowhere did we mention that the patient is Rh negative. So please remember, nowadays the most common type of hydrops fetalis is actually non-immune. Okay, so non-immune is more common than immune. The second thing, which infections are important causes of hydrops fetalis? So there are two infections. One is syphilis and the other is parvovirus. Okay. So parvovirus, please remember, causes aplastic anemia in the baby, which in turn causes heart failure. Why is the answer parvovirus here? Because see what hint we have given. We are giving you, she is a kindergarten teacher. And parvovirus छोटे बच्चों में होता है. Can you tell me what is it called as? What disease do you call it as? You call it as the fifth disease. Am I right? Yes, so it is called as the fifth disease. What is the appearance of the bachas? Slapped cheek appearance. Right? So the babies will have a slapped cheek appearance. Okay. Now please remember, although infections are one of the causes of non-immune eye drops, can you tell me what is the most common cause of non-immune eye drops? The most common cause of non-immune eye drops is cardiovascular diseases. Okay. So cardiovascular abnormality in fetus. The second leading cause is anemia, especially thalassemia, alpha thalassemia. Okay. So second leading cause is anemia. Infections are one of the causes, not the most common causes. Okay. Is that clear to everybody? Okay. Now please remember, when we talk about hydrops fetalis, when will this develop? So remember, if the hemoglobin of the baby goes below 5 gram% or hematocrit goes below 15%, then yes, the baby will develop hydrops. Okay. Also, when we talk about hydrops, remember it is a ultrasound diagnosis. So on the ultrasound, if we see any two of the following, then you say she has hydrops. What are any two? So any two can be, number one, my patient can have ascites, pericardial effusion, pleural effusion. Okay. So pericardial effusion, pleural effusion and subcutaneous edema. So when you see the subcutaneous edema on the scalp, you give it a special name. What is it? Buddha sign. So please remember, these are diagnostic criteria. Can you tell me two findings on ultrasound in hydrops, which are just findings, not diagnostic criteria? So ultrasound findings, which are just findings but not criteria, are placentomegaly. Okay. So placentomegaly and polyhydramnios. Right. So remember, placentomegaly and polyhydramnios are findings. They are not diagnostic criteria. Is that clear? But okay. Now, once we have understood this, let's move forward. So please remember, when we talk about hydrops fetalis, okay, suppose it is immune mediated. Okay, so if it is immune mediated, okay, CMV is not the common cause, beta. See, all infections can cause, all torch infections can cause. But when we have to mark the most important ones. So among infections, the two most important are syphilis and parvovirus. Okay, so we cannot say everything causes. So all torch group can cause, but they are not the most important ones. Okay, so please remember, in immune mediated, if the pregnancy is beyond 34 weeks, you will do a termination. But if the pregnancy is less than 34, you have to do cordo and intrauterine transfusions. So please remember, when it is immune mediated, intrauterine transfusions can actually reverse hydrops fetalis. Do you understand this? They can reverse hydrops fetalis. Okay, is that clear to everybody? Chalo. Let's move forward now. All are true about insulin requirement in pregnancy except. So who's going to tell me the answers? So is option A true? Yes. Remember this, requirement increases as POG increases. Why? Because insulin resistance increases. Okay? what is the indication to start insulin? So there are two indications that you have to remember. Number one, if I do a Deepti test or OGTT test and the value turns out to be more than 200, then I have to directly start her on 8 units of insulin. The second criteria for starting insulin is 2-hour PP value after 2 weeks of diabetic diet. So once my patient has been put on diabetic diet, after 2 weeks I will check her blood levels. If 2-hour PP value is more than or equal to 120, then again we will start her on insulin. So between 120 to 160, the dose is usually around 4 units. Okay, is that clear? Right, so then again you will start her on insulin. So isliye this is wrong. This cutoff has to be 120, not 140. See? Requirement reduces in labor. Is it true? Yes. So please remember that insulin requirement reduces in labor. What is the application? So on the day of induction of labor or cesarean section, what should you do? What should you do? So on the day of induction of labor or cesarean section, morning dose of insulin is not given. Okay? Do we give the night dose? Yes. The night prior, the night dose is given. Okay? So night before, give the dose. Okay? But on the morning, you will not give insulin. Okay? So answer D is also correct. Now quickly tell me, please tell me what is in general when we talk about diabetes, when would you do termination of pregnancy? Tell me. So please remember, termination of pregnancy as long as diabetes is well controlled. It doesn't matter whether it is controlled on insulin or diet or OHA. As long as it is well controlled, the answer is 39 weeks. That is the single best answer. But we can go up to 40 weeks. Okay. So 39 is the best answer, but we can go up to 40. Also, INI-CT, as I said, is more fond of asking depth. So they will ask you the target values. Okay. So please remember, when we talk about target values, the fasting should be kept at less than 95, 1 hour PP less than 140, 2 hour PP less than 120, average capillary glucose levels to be kept at 100. Okay? HbA1c to be preferably kept at less than 6. So these are the target values. Also please remember, although we have our national criteria, which is Deepti criteria, okay, please remember, through the Deepti criteria, the test is done twice. Do you all know this? One, we will do it at the first antenatal visit, and second, we will do between 24 to 28 weeks. The minimum gap between the two has to be 4 weeks. Okay? The minimum gap between the two tests has to be 4 weeks. Please remember, fasting is not mandatory. The glucose load is 75 grams. You put it in 300 ml of water, take it over 10 minutes. Take the blood sample at 2 hours. If it is more than or equal to 140, it is GDM. Is that understandable? This is the Deepti criteria. This is what you're supposed to know. But when you go for INI-CT, they have been, because before Deepti, we were following IAP-DSG criteria. So when it comes to IAP-DSG criteria, we also do a 75 gram OGTT, but here fasting is mandatory. So we withdraw 3 samples: fasting sample, 1 hour sample, 2 hour sample. What are the cutoffs? 92, 180 and 153. ठीक है, and we say if even one of these values is beyond cutoff, then you will say your patient has GDM, right? So out of these three values, even if one value is beyond the cutoff value, you will say the patient has GDM. Okay, is that clear? So these are the different criteria that you should know. They have been all coming in the exams. All right? Chalo. आगे बढ़ते हैं. Very important again for your NEET PG. So a woman has come for follow-up of ectopic. She has been given methotrexate for 7 days. Now she has abdominal pain, left lower quadrant tenderness, and HCG value has doubled. What is the appropriate step? So how many of you marked it as a repeat methotrexate? Did you mark it as repeat methotrexate? So please understand, repeat methotrexate is never given if the patient has a rising value. Okay? Repeat methotrexate can only be given if the patient has falling value. Okay, there is a fall, but the fall is less than 15%. Then you give repeat methotrexate. Okay? Here the value is rising. She's also having more pain. What do you think has happened? Most likely she is developing ruptured ectopic. So now please understand, if you have given methotrexate and you see a rising value, the management is surgical. Okay? Is that clear to everyone? The management is surgical beta. Okay? Now, in case your patient has ruptured ectopic, what is the treatment of choice? So please never mark medical management. Never mark salpingostomy. Always and always for ruptured ectopic, the treatment has to be a salpingectomy. Okay, it has to be a salpingectomy. Take, so these are very common mistakes. Please don't do them. Also, when it comes to medical management, or rather, I should say, when would you do surgical management? Anybody? So surgical management is done, number one, when the patient is hemodynamically unstable, when the patient has ruptured ectopic, then when the patient has HCG more than 5,000 international units, when the patient has a gestational sac which is bigger than 4 centimeters, when the patient has a gestational sac and cardiac activity is present. Please understand, this is also very, very important. Anytime the MCQ says cardiac activity is present, the treatment of choice is surgery. Medical management is preferably given when cardiac activity is absent. Have I made myself clear? This is very important. They will keep confusing you. Okay? 6, when the family is complete. So if the family is complete, then again we will do a surgical management. 7th, patient wants to go for IVF. Okay, and lastly, obviously the case we did, failed medical management, right? So if the medical management fails, then I have to straight away go for surgical. So please remember, your NEET PG people are fond of asking this. Also, can you tell me, when you give medical management, you all know it is methotrexate. Is it single dose methotrexate or multi-dose? What do we give? So please remember, in ectopic, it is single dose methotrexate. It is not multi-dose. Multi-dose is what you give for GTN or neoplasia. Okay? So single dose methotrexate देना है. 1 milligram per kg IM. Okay? 1 milligram per kg IM. Okay, bacha? Is that clear? So if none of these words are written, then yes, your patient is a patient for medical management. ठीक? Clear? Okay. चलो आगे बढ़ते हैं. So patient is 28 weeks. She has vaginal bleeding and uterine contractions. Fetal heart rate is reactive. She has a twin pregnancy. Okay. Uterine contractions are coming. Membranes have not ruptured. And cervix is 2 to 3 centimeters dilated. Okay. Can you tell me what is the management? So this is simply a case of preterm labor. We have already discussed preterm labor. Now you're going to tell me what you're going to do for her. Do you want to give tocolysis? Yes. Why? Because the POG is less than what? 34 weeks. So tocolytics will be given. Do we want to give steroids? Yes. Why? Because the pregnancy is less than 34. Do you want to give Magsalve? Yes. Because the POG is less than 32 weeks. Do we want to give her antibiotics? No. So please remember, antibiotics are not routinely given for preterm labor. Do we give it for prom? Yes. And for prom. But not for preterm labor. ठीक है बच्चा? बाकी tocolytics we have already covered. Also here what I just want to tell you is that now the guidelines say that steroids can be given up to what POG? 36 plus 6. Okay, so steroids can be given up to 36 plus 6 weeks. Okay, please remember the most common fetal complication of twin pregnancy is what? Prematurity, which is because of preterm labor. So most common fetal complication of twins is prematurity. Okay. Can you tell me which fetal complication is not seen in twin pregnancy? Which one is not seen in twin pregnancy? So सारे fetal complications ना ज़्यादा होते हैं. ठीक है? Except क्या नहीं होता? Macrosomia and post-term. Right? So macrosomia and post-term are not seen in twin pregnancy. ये दोनों MCQs बहुत important है and you should know this. Okay? Okay? Steroid वाला कोई criteria नहीं है बेटा. Steroids can be given any time if you anticipate early delivery. Right? So if you are anticipating delivery before 37 weeks, you can give a steroid cover. Are we supposed to repeat steroids? The answer is no. We don't repeat steroid therapy. ठीक है? एक ही बार देना होता है. All right? Please remember this. No, there is no variable dose methotrexate. People telling you unnecessary things, creating confusions. There is no rule. The recommendation is single dose methotrexate. We are not giving variable dose methotrexate. ठीक है? चलो आगे बढ़ते हैं. Okay. Your patient has come to the emergency department saying that she fainted at work. Okay. Her abdomen is diffusely tender and distended. She complains of shoulder tip pain and abdominal pain. Pulse rate दिया है, blood pressure दिया है. Which of the following is the best diagnostic procedure to perform quickly? Tell me. So what are you dealing with? You are probably again dealing with a case of ruptured ectopic. Who is going to tell me keywords? Why is this ruptured? The abdomen is tender, distended. The vitals are unstable. So we are dealing with ruptured ectopic. है ना? ऐसा क्या करें कि diagnosis बन जाए फटाफट? So culdocentesis. Right? So culdocentesis helps us to quickly form a diagnosis. So please remember this is what you do for ruptured ectopic. Okay. In this patient, is there any role of fast? Suppose the MCQ says what is the management or next step, and instead of caldo there are options like fast, there are options like laparotomy. तो क्या mark करोगे? So please remember, when obvious signs of peritonitis are present, right? What are obvious signs of peritonitis? Guarding, rigidity, rebound tenderness, right? So these are obvious signs of peritonitis. So when obvious signs of peritonitis are present, there is no role of fast. Please don't do this mistake. नहीं, ऐसा नहीं है कि fast is done for trauma. Fast is done for ectopic also, but never required if obvious signs are present. You will do fast only when there are no obvious signs of peritonitis. ये बहुत basic surgical concepts हैं, ठीक है? If obvious signs of peritonitis are present, the management straight away has to be a laparotomy, okay, or laparoscopy, whatever is in the options. Is that clear? Is that clear for everyone? So ये बहुत basic concepts हैं, गलती नहीं करना. INI-CT people ask you this, okay? Now, quickly let's see what I want you to see in culdocentesis. It is this. So please remember, culdocentesis is simply aspiration from the pouch of Douglas, okay, as you can see here. So you aspirate from POD. What do you get? Unclotted blood. So if you get unclotted blood, then this is a marker of intraperitoneal bleed. Can you tell me which fornix will you pierce to reach it? So we go through the posterior vaginal fornix. Okay, so we go through the posterior vaginal fornix to reach there. Please do not confuse culdocentesis with colpotomy. Colpotomy is never done for ectopic. Okay, colpotomy is done to drain a pelvic abscess. So this is how INI-CT people confuse you. So it is done to drain a pelvic abscess. Okay, it is opening up of the pouch of Douglas. You give an incision and you drain the pus. That is colpotomy. Okay, does HSG or hysteroscopy have any role in ectopic? So again, these investigations also have no role in ectopic pregnancy. So no HSG, no hysteroscopy, no colpotomy. ठीक है? Clear everybody? Chalo. Let's go forward now. Okay. So again, a very typical question. And NEET PG people, as I said, are fond of asking all this. So patient is in the second trimester. She is complaining of pain, which is worse with movement and exercise. Okay. There is no fever and application of heating pad helps in the relief of pain. Right? What do you think is the cause? And this is a right-sided pain. So this is a typical description of round ligament pain. Can you tell me why in this patient it is not appendicitis? So no history of fever. Okay. What are the other things which tell you that it will be appendicitis? In appendicitis, your patient will have a very characteristic pain which is called as shifting pain. So earlier it is in the periumbilical area and then it goes to the McBurney's point. So there is shifting pain, there is history of fever there. Hai na? Can you use leukocytosis? No, because leukocytosis is actually physiological, so it can be present in this patient as well. But appendicitis, yes, is a close DD. Appendicitis pain will not be relieved by heating pads. This is a very typical of stretching of the round ligament. So please remember, round ligament pain is classically seen in the second trimester, worsens with movement, okay, relieved by heating pads or resting, right? So this is very important. Also, please remember, round ligament pain, as I said, is because of stretching of the ligament. What is the management of round ligament pain? Conservative. You don't have to do anything. Okay, so just give her heating pads or maybe analgesics and that's done. Appendicitis, please remember, can happen in pregnancy. It is actually the most common surgical complication in pregnancy, but this is more likely to happen in the first trimester. Okay? How do you make a diagnosis? Ultrasound. What would you see in the ultrasound? A non-compressible appendix. है ना? So if I see a non-compressible appendix which is more than 6 mm in diameter, then we will say it is acute appendicitis. What is the management? Management irrespective of POG is going to be appendicectomy. So you have to operate. If you delay, you will actually cause more complications. Okay? So this is important. You should know about round ligament pain and you should also know about appendicitis in pregnancy. Both need PG exam questions. Is that clear to everybody? Chalo, आगे बढ़े. Okay, so this is a patient who is a case of previous cesarean. Okay, and the cesarean was done for fetal distress. Now she wants to know whether she can have a trial of labor or not, right? Were you able to answer this question? Yes, it is a simple one. After a previous cesarean, she can undergo a repeat cesarean provided it is what? Lower segment cesarean section. Yes, so if she has had a lower segment cesarean, then yes, she can. Can she undergo a vaginal delivery after classical cesarean? No. So please remember, contraindications for VBAC, which is also called as TOLAC, trial of labor after cesarean or vaginal birth after cesarean. Can you give me some answers? So one of the very good answers is classical CS. Okay. Second, history of rupture uterus. Third, more than or equal to 3 previous LSCS. Fourth, if my patient has a hysterotomy or a myomectomy scar. Okay, so if she has a hysterotomy or myomectomy scar, if she has CPD in current pregnancy. Okay, so if she has CPD, but please listen to me very carefully. This CPD has to be present in the current pregnancy, not in the previous pregnancy. Okay? Apart from this, breech presentation, macrosomia, okay? Breech presentation, macrosomia as well as post-term pregnancy are going to be contraindications. Okay, so these are important again for NEET PG. NEET PG is quite fond of asking this. Indications for VBAC, even INI-CT is fond of asking. INI-CT will typically ask from the last 3. These are relative contraindications. So breech, macrosomia and post-term. Okay, so these are contraindications for VBAC or TOLAC. Also sometimes we'll ask you a one-liner. Which is the best prognostic marker for VBAC? Can you tell me? So which is the best prognostic marker for successful VBAC? Then it is history of vaginal delivery. Okay, so if your patient has a history of vaginal delivery, then yes, that is considered as the best prognostic marker. But I want to ask you, if there is no history of vaginal delivery, is it a contraindication for VBAC? Not at all. Okay? If there is no history of vaginal delivery, it's not a contraindication. It's just that the chances of success are less. Okay? So please remember this. Yes, I'll give you a break in maybe after this question. Okay? Chalo. We'll do 39 and then I'll give you a break. So your patient is undergoing a elective repeat cesarean at term. And it is a very characteristic question, especially again, NEET PG people are fond of asking this, right? The placenta cannot be removed easily because a clear plane cannot be identified, right? The placenta is removed in pieces and the patient has uterine atony. This is a typical case presentation for PAS. What is PAS? Placenta accreta spectrum, right? So this is a typical case of PAS. This is how they will give you. Who is at high risk? So women who have previous cesarean and who also have placenta previa have the highest risk, right? So previous cesarean plus placenta previa. Also remember, all risk factors of placenta previa are going to be risk factors for PAS, which means multiparity, which means DNCs or uterine scars. They are all going to be risk factors. Now quickly, because NEET PG has previously asked, what is the investigation of choice for PAS? Ultrasound, right? Preferably, we want to combine ultrasound with Doppler. Even if ultrasound is alone given, that remains the investigation of choice, right? So investigation of choice is ultrasound. Please remember, MRI is gold standard, but it is not done in all patients. Okay, it will only be done when ultrasound cannot confirm the diagnosis. Okay? What is the treatment of choice for PAS? Treatment of choice. So, treatment of choice is a classical cesarean plus hysterectomy. Okay, so we will do a classical cesarean and we will do a hysterectomy. That's the treatment. Okay, can you tell me what is the classical histopath finding? The histopath finding is absent neta book membrane. Okay, absent neta book membrane. Okay, and I hope you know that the intervening decidua. So normally there is a decidua between placenta and myometrium. So here the intervening decidua is absent. Okay, bacha? The intervening decidua is going to be absent. Now what I feel is, maybe this time the NEET PG people may ask you the ultrasound findings, right? So important keywords are these: intraplacental lakes, okay, heterogeneous placenta. So intraplacental lakes, heterogeneous placenta, loss of retroplacental clear space. So normally behind the placenta there is a clear space, but that is absent. So loss of retroplacental clear space and thinning of myometrium behind the placenta. अगर सारे नहीं भी याद रहते, पहले दो प्लीज याद कर लो. So intraplacental lakes and heterogeneous placenta. This placenta is often called as moth-eaten placenta. These two are very characteristic. Okay? So at least remember the first two signs. So intraplacental lakes and heterogeneous placenta. Okay, bacha? Clear to everyone? Chalo. Should we take a short break? Yes? So we'll take a 10-minute break. I think that should work for everyone. And then we will start from question number 40. Now, as we keep going forward, you will see more and more topics we've already covered. So I'll go a little faster now, right? Because most topics we are covering up also and the things might have been discussed previously. Classical cesarean, because the placenta is coming into the myometrium. So if you cut in the lower part, you will also cut the placenta because placenta has come into the myometrium. So you cut in the upper part, beta. Okay? So we'll take a 10-minute break and we will start the class at 6:15. Okay? Anji, is everyone back? So hopefully all of you are back. Chalo, shuru kare? All right. Yes, so we are aiming at retrograde revision and that is how revision has to be to make it more and more productive, right? So you also should try that you should do a retrograde revision. Chalo, padhai karte hain. Okay, so you have performed a forceps assisted vaginal delivery and this was done for maternal exhaustion. You had given an episiotomy, and 8 hours after that you're called to see this patient. What is this a case of, Betu? So please remember, whenever you see these keywords, what are the keywords? Instrumental delivery, okay, episiotomy, and then if you see a clinical presentation where the patient has pain, a local swelling, right, and difficulty to void, right? So these are features of what? A vulval hematoma. Yes, absolutely yes. You're very right. So this is a case of vulval hematoma. And please remember, most of the times the hematoma is going to be unilateral on one side. And please also remember that the most common presentation is pain. After that, it is inability to void. And then it is shock. So sometimes, yes, hematomas can also present as shock. Now, normally whenever we talk about vulval, so image is important. NEET PG is again fond of asking these questions. So whenever you talk about vulval hematoma, in general, the management is conservative, right? So where what you ask the patient to do is you give them analgesics, right? So you give them analgesics, okay? You give them ice packs. Okay, so analgesics देते हैं, ice packs देते हैं. Please remember, there is no role of routine antibiotics. Antibiotic नहीं देना है. So this is what we usually do. But look at this patient. If your patient typically says that the pain is worsening or it is unbearable, so a severe or unbearable pain, जिसको हम कहते हैं excruciating pain, right? Apart from that, if you see the hematoma is enlarging or if there is shock, these three are indications for surgical treatment of a hematoma. Okay, so generally again, size alone is usually not a criteria. These are the more important criteria. So severe pain, unbearable pain, an enlarging hematoma, or if my patient is in shock, right? Then yes, we will do a surgical drainage. So what is the treatment? Incision and drainage. Please remember, after IND, you have to definitely obliterate the cavity. Otherwise, the hematoma will form again, right? So obliterate the cavity. So in this case, the answer is going to be incision and drainage. Please remember, if it is a vulval hematoma, which vessels are bleeding? These are actually branches of pudendal artery. Okay. Whereas if it is a vaginal hematoma, then it will usually be branches of uterine artery. Okay. Then it will be branches of uterine artery. All right. Chalo. Let's go to this one. I want to know how many of you have done this one correctly. So your patient is 22 weeks pregnant and we've done a level 2 scan for her. This is the defect that you see. So did you mistake this for anencephaly? So no, this is a very, very probable IBQ. This is a characteristic image of encephalocele. So what you see here is the brain content, okay, herniating. So this is herniation of the brain matter from the skull. So this white intense borders are the skull bones, and then you see there is herniation. Okay, so this is actually a typical example of encephalocele. INI-CT NEET PG. Some level 2 anomalies are very commonly asked. So I want you to see a couple of others as well. For example, what is this? So this you all know. So Mickey Mouse sign, है ना? या फिर as we say it as frog eye sign. These are characteristic signs of anencephaly. Please remember, anencephaly is the only anomaly that can be diagnosed in first trimester. Okay, this is the only anomaly that can be diagnosed in first trimester. Okay, at how many weeks? So it can be diagnosed as early as 10 weeks. But the ideal time for anencephaly is also actually in the second trimester, around 14 weeks. Can you tell me what would be an important associated finding? So an important associated finding will be polyhydramnios. Quickly, I want to know the reason of polyhydramnios, Betu. So the reason is absent swallowing. Please don't answer it as leakage of CSF. It only contributes. It's not the main reason. The main reason is absent swallowing. Okay? I want you to see the other image as well. Now this is a very characteristic image which is showing you actually both the signs, the banana sign as well as the lemon sign. So these are what the INI-CT people are fond of asking. So remember, banana sign is banana shaped cerebellum. Okay. And what is lemon sign? Lemon sign is actually concavity of frontal bones. Now quickly, can you tell me what are these two signs of? Spina bifida. So they are signs of spina bifida. But yes, they can also be seen in Chiari type 2 or Arnold-Chiari syndrome. So these anencephaly or spina bifida, they are all examples of what? Neural tube defects. So now some of the important MCQs. Quickly tell me what is the dose of folic acid given if there is history of neural tube defect. So if there is history of neural tube, then the dose is 4 milligrams. If it is given as prophylaxis of neural tube defects, then the dose is 0.4 milligrams. Okay? If there is history of anti-epileptics, then again the dose is 4 milligrams. And in diabetes, the dose is 0.4 milligrams. Okay? Then the dose is 0.4. What about sickle cell anemia? It is around 5 milligrams per day, right? So ye sare per day hain. So these are the various doses that you need to know as far as FA is concerned. And ideally, when should you start FA? So ideally, FA should be started before conception. Okay, ideally it should be started before conception. Okay, and high dose FA, folic acid, for example, in neural tube or anti-epileptics, when you are giving high dose FA, up till what time? So high dose is given up to 12 weeks. And after 12 weeks, all patients are put on IFA tab. So where the IFA mein kitna folic acid bataya tha? 0.5. Right? So beyond 12 weeks, nobody needs high doses. It is simply reduced to IFA tab. Okay? Is it clear? Okay. Now, very, very important also, please remember sometimes when you go for your INI-CT exams, they ask more depth. So please remember, they may ask you recurrence risk of neural tube defects. So after one neural tube, the recurrence risk is up to 4%. After 2, the recurrence is up to 10%. And they will ask you कि folic acid देने से कितना recurrence कम होता है. So FA will reduce risk by 72%. Right? So folic acid supplementation will reduce risk by 72%, not 100%. ठीक है बच्चा? Clear to everybody? चलो. Let's go forward now. So next question is, your patient has undergone a car accident and by mistake she has undergone X-ray exams and later we got to know she is 10 weeks pregnant. Now what do we do? So please remember, the answer here is C. So what we have to remember is all diagnostic radiation. Yes. So all diagnostic radiation usually will give you exposure which is less than 5 rads. Right? And less than 5 rads, there are no anomalies seen. In fact, no anomalies, no intellectual disabilities, no growth problems, nothing is seen. Right? Beyond 10 rads, it can actually cause fetal death. Okay, fetal death. Beyond 5 rads, as I said, you can see anomalies, you can see growth restriction, you can also see cognitive impairment. ठीक है. So this patient has received less than the damaged causing radiation. So we just do a follow-up and repeat or follow-up with ultrasound in the second trimester. ठीक है, is that clear? So please remember, radioiodine is absolutely contraindicated. Gadolinium is absolutely contraindicated. CT scan is usually not done in pregnancy. And when it comes to ultrasound, it is safe. But please remember, Doppler in early pregnancy should be avoided. Okay, so we should avoid Doppler. You can do Doppler later on, but early pregnancy में Doppler नहीं करना है. So even for cardiac activity, what do? We use ultrasound only. We actually use the M mode of the ultrasound machine to look for cardiac activity. We don't do Doppler study. ठीक है? Is that clear, बच्चा? सुनो, टेराटोजेनेसिस नहीं, कितने गरिमा अगर आपने 3-4 एक्सरे भी ले ली तो भी कुछ नहीं होगा. देयर रेडिएशन एक्सपोजर का डोज इज इन 0.0 समथिंग. ओके, सो इट्स रियली स्मॉल. नाउ प्लीज रिमेंबर, teratogenesis is important with respect to your NEET PG exams. Please go through the topics from your notes. There are certain drugs which are very, very important. So please remember, valproate बिल्कुल नहीं देना है. Okay, it is notorious to cause spina bifida. ठीक है, it can cause other neural tube defects as well, but valproate आपको पता होना चाहिए. Can you tell me what does lithium do very quickly? I can't discuss all, but I want you to know some important ones. Right? So tell me, what about lithium? Lithium will cause Epstein's anomaly. What about diethyl stilbestrol? Clear cell cancer of vagina as well as T-shaped uterus. मोबियस किससे होता है? मोबियस सिंड्रोम, माइजोप्रोस्टॉल. ओके, वॉरफरिन क्या करता है? कॉन्ड्रोडिस्प्लेजिया पंक्टेटा, है ना? सो कॉन्ड्रोडिस्प्लेजिया पंक्टाटा. आइसोट्रेटिनॉइन क्या करता है? आइसोट्रेटिनॉइन माइक्रोटिया एंड एनोटिया. ओके, सो माइक्रोटिया, एनोटिया. INI-CT wale, they have previously asked about fetal alcohol syndrome, right? So remember, fetal alcohol syndrome is a triad. There is growth restriction, there is microcephaly, and there is a characteristic facial features. So that is what is FAS. जल्दी से बताओ, thalidomide क्या करता है? Thalidomide फोकोमीलिया, है ना? फोकोमीलिया. ACE inhibitors हम already कर चुके हैं. ACE inhibitors will cause renal anomalies in the baby. ठीक है? चलो, let's go forward now. So this patient has undergone postpartum hemorrhage. Okay, now listen to the question. So we have already given her oxytocin, we have given her hemabate, she is bleeding. We have started blood transfusion as well. We have done a balloon tamponade, and then her vitals are given. Now, why is the answer uterine artery ligation? Why is the answer not compression sutures? Who is going to tell me that? So the answer is not compression sutures because the patient's vitals are unstable, right? So usually when the systolic blood pressure is below 90, we would consider as unstable and we will proceed on to bilateral uterine artery ligation. So please remember, once you have done a balloon tamponade, okay, then see whether the patient is hemodynamically stable or unstable. If she is stable, then you can do uterine artery embolization or you can do uterine compression sutures, which is called as B-Lynch. If she is unstable, you have to begin with systematic pelvic devascularization. Who is going to tell me what is the order you follow in systematic pelvic devascularizations? What is the first vessel? The first vessel is bilateral uterine arteries. Second, we will ligate the anastomosis with ovarian artery. And what is the third vessel? Anterior division of internal iliac, right? Anterior division of internal iliac. It is a recent NEET PG question. So as I said, more width in NEET. Okay. What would you do if you have done systematic devascularization and the patient is still bleeding? Then you will have to proceed on to hysterectomy. Okay, then you will have to proceed on to hysterectomy. Suppose you have done compression sutures and the patient is still bleeding. Then what do? You have to go on to systematic pelvic devascularization. Is that clear to everyone? So you should know the sequence in which you will do. Also, please remember, I am telling you a very important thing. As per the guidelines of WHO, all patients of PPH, do you know that they should receive Tranexa now? So they should receive injection Tranexa 1 gram within 3 hours. Right? So oxytocin to dena hi dena hai, they will all receive Tranexa as well. Okay? Also, please remember when the question says, you know, most of the times we will give all three. We will give oxytocin also, Miso also, Tranexa also. So once the question says, we have given oxytocin, the patient is bleeding, then you should go on to either carboprost or go on to methergin. Okay? And then you go on to balloon tamponade. So that is the sequence you follow for conservative management. Remember the differentiating feature here, whether I should give carboprost or whether I should give methergin. So remember, preeclampsia is a contraindication for methergin. And carboprost का contraindication है asthma. Asthma के patient में कभी भी carboprost नहीं देना है. ठीक? और अगर कोई आपसे इन जनरल पूछे ड्रग ऑफ चॉइस फॉर पीपीएच, द आंसर रिमेन्स एज ऑक्सीटोसिन. ठीक है, सी द ड्रग ऑफ चॉइस विल रिमेन एज ऑक्सीटोसिन. बेटा वो इन्फ्यूजन का रेट है 1 ग्राम आईवी, इट हैज टू बी गिवन ओवर अ स्पैन ऑफ 20 मिनट्स. बच्चा हम बोल रहे हैं दिस इंजेक्शन हैज टू बी गिवन विद इन 3 आवर्स ऑफ पीपीएच, ऑनसेट ऑफ हैमरेज. ठीक है, बोथ आर डिफरेंट थिंग्स. So जो आप बोल रहे हो वो है how much time you should take to give the infusion. Okay. So please remember this. Misoprostol is usually given as an add-on drug, always with oxytocin. So you will give oxytocin as infusion and misoprostol is put per rectally. Right? So most of the times oxytocin and miso are given together. Okay. One is given IV, the other is put PR. Alright? Chalo. Now a very simple question, but again your exams are fond of asking. Bishop's score includes all except. What is the answer? What is the answer? Right. So as I said, this is an easy one. There's another place where I will show you the Bishop's score and I'll help you in telling you how to remember it. But here, yes, the answer is presenting part. Right? Dilatation होता है, then what else? Cervical position, then cervical effacement. Length of the cervix is, although a component, it is a component of modified Bishop's. Okay. So in modified Bishop's, length of the cervix replaces effacement. So cervical dilatation, cervical position, effacement. What else is included here? What else is included? Station and consistency of cervix. Okay, but presenting part is not included. Station is included. Okay. What is simplified Bishop's, beta? So simplified Bishop's hota hai where you are using only 3 parameters. What are the parameters? We are using cervical dilatation, cervical effacement and station. Okay. Now please remember, if the Bishop's score is more than or equal to 6, you can begin with induction. Okay. So you can start oxytocin for your patient. But if the value is less than or equal to 5, then what do? Then you will have to first do cervical ripening. We have already talked about the drugs. We could use dinoprostone or we could use misoprostol. Which out of the two is preferred? In India, dinoprostone, right? So this is PGE2 while this is PGE1. We have talked about the doses as well. So I'm not going to repeat that, but you should know the doses we use for induction of or cervical ripening. Okay, quickly tell me, what are the mechanical methods of cervical ripening? So when it comes to mechanical methods of ripening, you should know at least two names, right? What are the names? So one is, we could use the bulb of Foley's catheter. The other is laminaria tents, right? Laminaria tents are osmotic dilators. ARM is not used for ripening beta. ARM is used for induction of contractions, but oxytocin is preferred. ARM is not the method of choice. Okay, how many of you know that sweeping of membranes is different from ARM? So sweeping of membranes is also a method to induce contractions. What do you understand here by sweeping? Sweeping में क्या करते हो? You are separating the membranes from the decidua. You are not rupturing them. Okay. This helps in release of prostaglandins. Which prostaglandins are present in the membranes? So membranes have PGE2, not E1. Right. So amniotic membrane typically is a rich source of PGE2. Right, so this is what is called as membrane sweeping or membrane stripping. एक ही बात है, चाहे आप stripping बोल दो या आप membrane sweeping बोल दो, ठीक है? Which prostaglandin is present in decidua? So remember, decidua has prostaglandin F, ठीक है? Membranes have prostaglandin E2 beta. Clear to everyone? चलो, let's go on to the next one. So this is an easy one. I wanted to put it because it has been IBQ previously in the AIMS exams as well. So remember, this is fourth pelvic grip, right? So fourth Leopold, also called as deep pelvic or simply pelvic. Tick. Now here I have put the images because they have been repeatedly coming in the exam. So it's a good idea to know about them. So look at this. Okay, so Leopold 1. What is the other name for Leopold 1? So Leopold 1, please remember, is also called as fundal grip. What is the other name for Leopold 2? It is called as lateral grip. Leopold 3 is also called as Pollux grip. And Leopold 4 is, as I said, also called as deep pelvic or pelvic grip. So it's a good idea to know these images. They have been repeatedly coming in the exam. ठीक है? चलो. No, we don't use the word umbilical. It's not a standard term, betu. ठीक है? चलो. Consider the following statements regarding the non-stress test. ठीक है? Now, reactive NST indicates a healthy fetus. Is it true? Yes. Okay. Reactive NST basically rules out hypoxia. Okay. And when do you say it is reactive? If you see at least 2 accelerations in 20 minutes. That is the usual definition. But if someone asks you what is the upper limit, the upper limit is 40 minutes, which means if you see less than 2 accelerations in 40 minutes, so you have to maximally wait up to 40 minutes, then you say it is non-reactive. Ab meri baat dhyan se suno. When you say non-reactive, this is what is considered as a positive test. When you say it is reactive, okay, So when you say it is reactive, it is considered as a negative test. Negative means no hypoxia. Positive means it may be present. Now I want to ask you, what is high in NST? Is it false positive rate is high or false negative rate is high? Tell me. So please remember, false positive is high. This is why whenever the result is positive, we have to do another test. Right? What is the test? This test is biophysical profile. So when the NST is non-reactive, you have to do a BPP. Okay? Which means, will it have a low false negative? Yes. So false negative is low, false positive is high. Okay? NST is an observation of fetal breathing with fetal movements. No. NST में हम क्या क्या monitor करते हैं? We are only monitoring the fetal heart rate. Right? So we are basically monitoring the fetal heart rate. But yes, can we monitor movements also? Yes. So please remember, NST machine has a probe which can record movements. But can it record fetal breathing? No, it cannot record fetal breathing. Okay? Testing should be started at 20 weeks. No, when should you start monitoring? So please remember, any method of fetal monitoring, whether it is biophysical profile or it is NST, you must begin at 32 weeks. Can you tell me why? Because at less than 32 weeks, the baby is neurologically immature. So half of the tests are coming abnormal because of neurological immaturity, not because of hypoxia. Is that clear? 28, still you have to know, even at 28 weeks, 50% of tests will turn out to be non-reactive. Okay? So the ideal time to start it is actually 32 weeks. The same holds true for BPP. Alright, they are more reliable once you do them after 32 weeks. Okay, bacha? Okay, do you all know that the machine for CTG is same as the machine for NST? Okay, so please remember, there are two probes. So one probe will measure the, so one probe, when you put it on the abdomen, okay, it will pick up the fetal heart rate, and the other probe will pick up uterine contractions. Okay? So when you do it in labor, you call it as CTG. When you do it antenatally, you call it NST. Is that clear? Okay, perfect. Chalo. At 29 weeks of gestational age, the fetus has developed hydrops. All the following are characteristics except. So we have done this in quite a detail. I'm sure you can tell me the answer. The answer is small placenta. Because we will not see small placenta, we will see placentomegaly. Can you tell me the conditions where you see placentomegaly? Jaldi se. So will you see it in syphilis? Yes. Will you see it in parvovirus? Yes, because these conditions are associated with hydrops. So whenever there is a high output, high fetal cardiac output, there will be placentomegaly. Okay? Remember, you can see it in molar pregnancy as well. Okay? Yes. Twin transfusion syndrome is a very important cause of placentomegaly. Okay? So, diabetes, absolutely yes, will again be a cause of placentomegaly. Fetal anemia or fetal high cardiac output conditions, right? Like fetal anemia. Small placenta कहाँ मिलता है बेटा? ये दोनों ही नीट पीजी के PYQs हैं. Big placenta, small placenta. ठीक है? So please remember, small placenta you will see in preeclampsia, you will see in IUGR. Basically जब क्या मिलता है? When there is uteroplacental insufficiency. Right? So when you see uteroplacental insufficiency, that's when you say you will see a small placenta. ठीक? चलो. Now, very, very important conditions. This is an important IBQ. So just follow what I am teaching you and follow the protocol. Whenever you get this question, you have to know, are we seeing the pelvis from top or are we seeing the pelvis from bottom? Jaldi batao, pehle to ye bata do. So please remember, we are seeing the pelvis from bottom. Why? Because only then you will see the sutures. Okay? So we are seeing from bottom. अब सबसे पहले क्या देखना है? You will see where is the triangular fontanel. Okay? Triangular fontanel tells you where is the occiput. So now here you can see the occiput is close to sacrum. Yes. So if it is close to sacrum, the position will be OA. If it is close to symphysis pubis, the position will be OA if it is symphysis pubis. If it is sacrum, then OP, right? So if occiput is towards sacrum, then it is OP. Now, because we are seeing from bottom, our left, so this is on our left side, it becomes patient's right side. Is that clear? So, तीन ही step करने हैं. पहला, see where the triangular fontanel is. Is it towards sacrum or is it towards symphysis pubis? Based on that, answer it is OA or OP. Then you see, is it your left or is it your right? If it is your left, it is patient's right. So the answer is ROP, right? So please remember, ROP is the most common position in occipito-posterior. And what is the pelvis? So the answer is android. So please remember, most common cause of OP is android. But if I ask you most common cause of persistent OP, okay, or direct OP, then the answer will change to anthropoid. So if we use any prefix like persistent or direct, then the answer is anthropoid. बेटा देखो, मैंने बहुत सिंपल चीज बोला है कि आप पेल्विस को नीचे से देख रहे हो, तभी आपको स्यूचर्स दिख रहे हैं. इसीलिए आपका राइट और लेफ्ट पेशेंट के राइट और लेफ्ट से उल्टा है. ठीक. दूसरा चीज आपको आइडेंटिफाई करना है ट्राइंगल शेप्ड फॉन्टेनल, बिकॉज ट्राइंगल शेप्ड इज द पोस्टीरियर फॉन्टेनल. क्योंकि ये पोस्टीरियर फॉन्टेनल है, दिस इज क्लोज टू ऑक्सिपुट. ठीक है. एंड therefore the position of the triangular fontanel tells you the position of the occiput. So now once we see occiput, we have to see, is it close to sacrum or is it close to symphysis pubis? So if the triangular fontanel is close to sacrum, that means the position is OP, occiput is posterior. If triangular fontanel would be close to symphysis pubis, then the occiput becomes anterior. ठीक है. So इस केस में it is OP. एंड इस केस में मेरा क्या है, ये लेफ्ट. तो पेशेंट का क्या होगा, राइट? द ट्राइंगुलर फॉन्टेनल इज ऑन माई लेफ्ट हैंड साइड. सो फॉर द पेशेंट इट विल बी राइट साइड. ठीक है. इज दैट क्लियर नाउ? All right. So these are very, very important things with respect to identification of OP and pelvises. Please remember DTA. Okay, is again most commonly seen with which pelvis? It is seen with android. So most commonly DTA is seen with android pelvis. ठीक है? Is that clear? ठीक. Second, gynecoid pelvis, platypilloid pelvis is associated with face presentation as well as brow presentation. ठीक है? Gynecoid is the normal female pelvis, while android is the typical male pelvis. Remember, in typical male pelvis, the inlet is which shaped? Heart shaped. So if the inlet is heart shaped, it is a male pelvis. ठीक है? Gynecoid में कैसा होता है? Gynecoid में the inlet is almost circular. Okay, it is almost circular. Anthropoid में कैसा होता है बताओ? Anthropoid is antero-posteriorly oval. So AP diameter will be more than transverse diameter. ठीक? What about platyploid? Platyploid is a transverse oval pelvis. Okay? तो इसमें कौन सा diameter बड़ा होगा? Transverse. So transverse diameter will be bigger than AP diameter बच्चे. ठीक है? Also remember a one-liner that platyploid pelvis is called as flat gynecoid. Okay, it is called as a flat gynecoid pelvis. So these are some important questions with respect to the pelvis. अच्छा, कौन सी pelvis की side walls convergent होती हैं बताओ? Male pelvis. ठीक है, male pelvis में side walls are convergent. Android में, ठीक है, और gynecoid में side walls are parallel. And ischial spines किसमें prominent होती हैं? Again android या male pelvis. So ischial spines will be prominent. जबकि female pelvis में ischial spines are blunt. तो कभी कभी क्या करते हैं नीट पीजी, they give you as if you are examining a pelvis and they will describe it and then you have to tell which one it is. So if they are describing it as convergent walls, right, prominent ischial spines, then these are typical examples of android pelvis. ठीक है? चलो आगे बढ़े. Okay. So what is this a case of? This is simply a case of IUGR, right? So please remember, this patient is a smoker, okay, although she has reduced, but ultrasound demonstrates the fetal percentile is less than the 10th percentile, right? So if the estimated birth weight is less than the 10th percentile, or we say abdominal circumference is less than the 10th percentile, then this means we are dealing with what? This means we are dealing with IUGR. When do you say it is severe IUGR? When the percentile is less than the 5th percentile, then it is severe IUGR. Now, as of now, if you see, we have given you the Doppler study of the baby is normal. Amniotic fluid is also normal, right? So please remember, most likely this is a patient of mild IUGR. Now, when the Doppler is normal, initial Doppler and the other things are also normal, then you don't really have to repeat Doppler parameters at all in these patients, right? You will simply follow up with what? Ultrasound for fetal growth and amniotic fluid. What is the frequency? If it is less than 10th percentile, then we will do ultrasound every 4 weeks. If it is less than the 5th percentile, then we do ultrasound every 2 weeks. उससे ज़्यादा जल्दी ultrasound करने में कोई फायदा नहीं है. Okay? In case the Doppler studies are abnormal, then what do? Then you keep doing Doppler every week. Okay? Then you keep doing Doppler every week and NST you will do twice a week. BPP you will do once a week. This is minimum requirement. समझ आ गया बच्चे? So I will repeat. I am saying if the initial Doppler is abnormal, then you have to do Doppler every week. NST is done twice a week and biophysical profile is also done once a week. Ultrasound मैंने आपको बता दिया. What is the frequency? It depends on the percentile. If it is less than 10th percentile, then you do every 4 weekly. But if it is less than 5th percentile, then you do every 2 weeks. ठीक है? Termination कब करना है? It will depend on Doppler findings. So please remember, if SD ratio remains normal, okay, अगर SD ratio normal है, then do termination at 39 weeks. If SD ratio is raised, then you will do termination at 37. If SD ratio is raised and there is oligo, okay, if SD ratio is raised and there is oligo, then you can do termination at and beyond 34 weeks. Okay. Apart from that, for absent end diastolic flow and for reversal, we have already discussed the timings for termination. Okay, bacha, is that clear to everybody? So this is how you should monitor a baby of IUGR and how you should or when you should do the termination. Okay. Now quickly tell me, if there is uteroplacental insufficiency, what kind of IUGR will it do? Symmetrical or asymmetrical? So this will do asymmetrical IUGR. Whereas if the baby has chromosomal abnormality, then what kind of IUGR will it do? Then it will do symmetrical IUGR. Okay, then it will do symmetrical. So when the problem is within the baby itself, it will be early onset and it will be symmetrical. So chromosomal abnormalities will cause early onset IUGR and it tends to be symmetrical. When the cause is in the mother, like nutrition, like UPI, right? So जब maternal causes होते हैं, it will usually cause asymmetrical IUGR. ठीक है बच्चा? So nutritional deficiencies in the mother will also cause asymmetrical IUGR. ठीक है? Is that clear? So perfect. Very good. Happy. Let's go forward now. So this is a patient who has come for a routine prenatal care at 37 weeks and she has an RH negative pregnancy. A bedside ultrasound reveals a frank breech baby. What is the next step? So remember that your exams are actually fond of asking management of breech at term, especially INI-CT, even NEET PG. So when you see a breech baby at term, right? And typically when we say term, we mean here 37 weeks. What are you supposed to do? So I'll give you the algorithm. So the first thing you're supposed to do is do an ultrasound. This is done to look for type of breech, placental localization, amniotic fluid, and look for other contraindications of ECV. So all contraindications of ECV can usually be seen on ultrasound, right? Which I will tell you in a moment. Now, if contraindications to ECV are present, okay, then what is the management? Then the answer is that you will plan a elective cesarean for this pregnancy at 39 weeks. Okay? But if contraindications for ECV are absent, then what is the management we do? So if contraindications for ECV are absent, then what do? Then we will do external cephalic version at 37 weeks. Also, you know, when I do it at 37 weeks, it may be successful, it may not be successful. So if it is not successful or baby reverts, then what do? So if it is not successful or the baby rotates back, then what are we going to do? Then I can do a repeat ECV at 39 weeks. I can repeat the procedure at 39 weeks. Ab agar wahan pe it is not successful, then we'll do a cesarean. Is that clear? Yes? Is the algorithm clear? Perfect. Very good. I'm so happy. Also, please remember, when you talk about external cephalic version, your exams are very, very fond of asking about its contraindications. So, some contraindications are very essential. For example, number 1, multifetal pregnancy is a very important contraindication. Then, footling breech and star grazer breech are very important things. Okay, ruptured membranes is again an important contraindication. Then in case the patient has placenta previa or contracted pelvis, where vaginal delivery anyways is not possible, then there is no point in doing a rotation. Okay? Then if there is fetal distress, remember previous cesarean, preeclampsia and oligohydramnios are also contraindications, right? So previous cesarean, preeclampsia and oligohydramnios. No, RH negative, it is definitely not a contraindication. Who told you that? You will do an ECV and you will give an anti-D prophylaxis. Okay, so RH negative is not a contraindication, Rajay. You will do it. Okay. So these are important contraindications. Also active labor. So please remember, in latent labor, external cephalic version can be done. But in active labor, no. Okay. Also now tell me, what is, when we talk about external cephalic version, what is the ideal time to do it? So please remember, although ECV can be done any time beyond 36 weeks, most commonly we do it at 37 weeks. You should know that always we will do ECV under fetal heart rate monitoring, and we will always give tocolysis 30 minutes before the procedure. Which one do we use here? Do you know? So this is a place where we will typically use terbutaline. Okay, it's a subcutaneous injection and we will give it 30 minutes before the procedure. Okay, so do it under continuous fetal heart rate monitoring. Give tocolysis to improve success rate. Okay. Now, just in case they ask you that while doing ECV, you come across fetal distress. Ab kya karna hai? What is the next step? So the answer is revert the baby to original position. And then take the mother up for cesarean section. So first you will revert the baby, wapas ghumao to original position, and then take her up for CS. Is that clear? Okay. So please remember contraindications. A lot of times you will get these MCQs. Also remember the algorithm for management of breech. Very often asked in INI CT as well as NEET PG exam. Okay? Okay. Let's go on to the next question now. So an important IBQ but an easy one, right? What is this syringe? Do you all know this? So this is a MVA syringe. Please remember, मैंने यहाँ पे bivalve syringe दिखाया है because this is the one which is used these days. But MVA syringe can be univalve as well. More commonly, what we are using now is a bivalve syringe. Okay. So is the volume 60 ml? Yes. Can it be done up to 12 weeks? Yes. What is the pressure? The pressure is not 60, the pressure is 660 millimeters of mercury. And if that's not in the options, you can mark actually 600. Okay. And can it be used in an outpatient setting? Yes, it can be used. Please remember, no electricity is required for this. Okay. So no electricity is required. And it is simply an alternative to suction evacuation. बस ये याद रखो. It is an alternative to suction and evacuation, which means it is a method of which trimester MTP? First trimester MTP. Okay, so it's a method of first trimester MTP. All right. Chalo ji. So a very basic question. I hope you've done this correctly because and let me know if you need to really know these basics as well. So, a patient who has had one previous second trimester MTP, Then she has had one early miscarriage, so that makes it 2. Then she has had a stillbirth, that makes it 3. And now she is pregnant again, which means this is her 4th pregnancy, right? So do you all understand why G4? So remember, in gravida, current pregnancy is counted. But do you count current pregnancy in parity? No. So please remember, parity is number of completed pregnancies beyond period of viability. Okay. Now when we talk about GTPAL formula, TPAL, which is what is given here, this is a universal formula. Okay. So this is a universal formula. What is T here? T here is number of completed term pregnancies, which means completed beyond 37 weeks. Okay, that's what we mean here. The P here is not parity beta. The P here is number of completed preterm deliveries, which means pregnancies that have completed between or ended between 20 to 36 weeks. Please remember, when we say completed, it means delivered. Current pregnancy is not counted, neither in parity, neither in T and P. Right? Now coming to your doubt. Why is P1 here? So please remember, okay, when it comes to TPAL, okay, अच्छा ये तो TPL formula है ही नहीं, ये तो normal formula है GPLA. So why is P1 here? So P is 1 here because only one pregnancy has gone beyond 28 weeks. Okay, so that is why we are counting it as P1. Is stillbirth counted? Yes, stillbirth is counted. So in parity, we are not worried about outcome, right? Whether the baby is alive or dead. As long as the pregnancy is completed, it will be taken. Okay, also remember, what about twins? In twins, term or parity, इसमें क्या लेते हैं? Do we count the number of babies? No. So for all these conditions, twins is not counted as 2, it is counted as 1. Because we are not counting number of babies, we are counting number of pregnancies, right? Why is A2 here? Of course, yes. Okay, A is 2 because she has undergone 2 abortions. One in the second trimester, one in the first trimester. Why is L 0? Please remember, don't do these mistakes. L corresponds to number of currently living children. If the baby is not alive, it is not counted. So it has to be number of currently living. Now answering someone's doubt, is stillbirth counted in GTPL? Of course, yes, beta. It doesn't matter what kind of outcome is there. If the pregnancy is completed, you have to count it. Is that clear? Okay, I hope there are no other doubts. So I have explained both the formulas, GPL and TPAL. ठीक? Good to go everyone? Period of viability तो मैंने शुरू में भी बताया बेटा. इंडिया में period of viability is considered as 28 weeks. ठीक है? 28 weeks. चलो आगे बढ़े. Okay, we have already covered a lot of teratogens, covering a few here maybe. So a lady has been on anti-thyroid drugs. Following delivery, this defect is noted. What is this? So this is aplasia cutis. Okay, so this is aplasia cutis. Typically seen with methimazole. Okay. Right. So please remember, PTU is the drug of choice for hyperthyroidism in first pregnancy. In first trimester. So it is drug of choice for hyperthyroidism in the first trimester. Whereas in the second and third trimester, what is the answer? It is methimazole. Now I want to know two things from you. Number one, if I ask you safest one, then what is the answer? PTU, right? Then the answer is PTU. If I ask you, what? Right, if I ask you, can these drugs cross placenta? So yes, please remember, even PTU, these drugs will cross placenta. So now I want to ask, can they cause fetal hypothyroidism and goiter? The answer is yes. Okay, so they can cause fetal hypothyroidism and goiter. Okay, is that clear to everyone? Those are important things. Also, when we talk about hypothyroidism in pregnancy, what is the most common cause? So please remember, now it is not iodine deficiency, it is Hashimoto's. So I want to know from you, if you have a patient who is a known case of hypothyroidism, right, can you tell me what will you do to the dose of thyroxine that she is taking? So what do you do if she becomes pregnant with the dose? So please remember, the dose will increase 50% when she conceives. Okay, so the demand increases, so you have to provide everything from outside. Okay? With respect to physiological changes, please remember these important points. Thyroid binding globulin increases in pregnancy. Total T3 and total T4 increase in pregnancy, but free T3 and T4 are remaining normal. TSH also remains normal, right? So please remember, TSH is also going to stay normal in pregnancy. Okay? So these are important physiological changes that you should know. Okay? Right. I think the other drugs we have more or less covered in the teratogens, so I'm not going to repeat those. But yes, we're trying to cover the most important things, the ones which are most likely to be asked in the exam as well. Okay? Chalo. Let's look at this. So important and applied MCQ hai. Your patient is 35 weeks pregnant and she is coming to us with decreased fetal movements. You have done an ultrasound which shows an amniotic fluid index of 5. What subsequent evaluation is recommended for this patient, right? Now, you know that patient has decreased fetal movements and the cause is oligo. Now, whenever we talk about oligo, what is the first thing that you have to do? The first thing you have to do is do a per speculum examination. Okay, this is to rule out PROM. Okay, so this is to rule out PROM. Then, especially if you are seeing oligohydramnios in the third trimester, what is the next thing that you should do after per speculum? You should do an umbilical artery Doppler. Who is going to tell me why Doppler? Because oligo का कारण हो सकता है uteroplacental insufficiency, right? So we should also be doing a Doppler. Then, because one of the reasons for oligo in the third trimester is UPI, will there also be an IUGR in this case? Yes. So on the ultrasound, apart from amniotic fluid, you should look for IUGR. You should do an umbilical artery Doppler and you should do a per speculum examination. On the other hand, if I ask you, you see oligo in early second trimester, then what should you do? If you are seeing oligohydramnios in early second trimester, then what should you do? Then definitely do a per speculum examination, and after that you should also be doing a level 2 ultrasound, because if you see it early in pregnancy, then what is the reason? anomalies. Okay. Then the reason is anomalies. Which anomalies will cause a LIGO, bacha? So renal anomalies will cause a LIGO, and if there is a outflow obstruction of the urinary tract. Right? So if there is outflow obstruction, okay, just a minute please. Okay, yes. So renal anomalies, yes, renal agenesis, polycystic kidneys, okay? Outflow obstruction. Okay, if there is outflow obstruction of the urinary tract, then again there will be what? Oligohydramnios. So in level 2, you should look for anomalies. Take, is that understandable? Okay. Which anomalies cause poly? Which anomalies will cause poly? So when it comes to poly, then you have to know wherever the baby cannot swallow. Okay. So whenever the baby cannot swallow, then yes, there's going to be poly. Whenever there is increase in the urine production, then again there will be poly, right? So typical conditions of poly would also include, GIT anomalies as well as neural tube defects. है ना? So GIT anomalies, neural tube defects. Increased urine production कब होता है? When there is a fetal high cardiac output state like fetal anemia. और कब high increased urine production कब होता है? Like Bartter syndrome. है ना? Where the urine production is higher. ठीक है? So these are things that you should think when you get a question on poly or when you get a question on oligo. Now quickly tell me, what is the NST graph showing you? So please remember this association. When you see oligo, the kind of abnormality that you will see, okay? The kind of abnormality that you will see on NST is going to be variable decelerations. What is the reason for variable decelerations? Cord compression. So because of a LIGO, the cord gets compressed and you will see variable decelerations. ठीक है? Yes. Gestational diabetes mellitus में और वो क्या होता है? Right? So diabetes mellitus में भी polyuria होता है. That is why it will also cause or can cause polyhydramnios. Right? Now quickly some of the images that I want to show you here. Okay, so this was just types of breach which you can see they are labeled. These are the pelvises that I have already talked about. So quickly label them with me. So this one is circular, so it has to be gynecoid. Then this one is antero-posteriorly oval, so it will be anthropoid. This one is heart-shaped, C, so this will be android. And transversely oval will be platypeloid. So you can again get them as IBQs, especially in NEET PG. ठीक है? चलो. Variable decelerations हमने देख लिया. What about early? So early decelerations will always occur with the contraction, right? So they start with the contraction and they end with the contraction. Okay, every time they will start with the contraction, they will end with the contraction. So then this is an early deceleration. And what is the cause? Head compression. Also, if you look at the graph, the dip is gradual. Can you all appreciate this? A gradual fall and a gradual pickup. ठीक है, जल्दी जल्दी नहीं होता है. It's a slow fall and a slow pickup. So this is early compression, early deceleration. ठीक है. Now late deceleration. Okay, this is sort of reversed. उल्टा हो गया है ये. आपकी image book में उसमें ठीक है, इसमें उल्टा है. But anyways, what happens is that the contraction will begin at the peak of the, so whenever there is a peak of the contraction, this is when the fetal heart rate begins to dip, right? So FHR begins to dip. It is again a slow fall and a slow pickup. Okay, so it is gradual. Okay, so it is gradual. Please remember, even after the contraction ends, the dip is persisting, right? So the dip is persisting. And because the dip is persisting, we call it as what? Late deceleration. Okay, so we call it as late deceleration. What is the cause? Uteroplacental insufficiency. बेटा देखो, जो डिटेल्स अननेसेसरी है उनको याद करने से कोई फायदा नहीं है. इंपॉर्टेंट बातें याद करो. ग्रेजुअल का सिंपली मतलब ये होता है कि फ्रॉम द स्टार्ट टू मिनिमम वैल्यू, है ना, इट शुड टेक मोर देन 30 seconds. So from start to minimum value, it should take more than 30 seconds. Magar, why do you want to waste your energy learning this up? I can give you as many details as you want, but how does that help you? Okay, so please understand, अगर हम useless बातों को याद करने में टाइम लगाएंगे, उनसे हमारे मार्क्स इंप्रूव नहीं होंगे. ठीक है? So trust me, when I am giving you certain details and when I am avoiding something, it means they are not the most important things. Don't waste your time and energy on those things in revision. ठीक है? काम की बात करेंगे जिससे हमें फायदा मिले. All right? चलो. So these were various types of decelerations and how you will identify them. Okay? Variable में कैसा dip है? वापस आते हैं इस image पे. Is it a gradual fall or is it a quick fall? So if you see here, it is a quick fall and a quick pickup. है ना? It's not gradual, which means it will happen in less than 30 seconds. So from the onset to minimum value, it will take less than 30 seconds. Okay? That makes it quick. And please remember, we say variable because it has no association to a contraction. Right? कभी वो contraction के पहले आ जाएगा, कभी contraction के साथ, कभी contraction के बाद. ठीक? Now please remember, when it comes to variable decelerations, INI-CT people can go to more depth. So, variable is actually the most common deceleration in labor. Did you know that? So, this is the most common deceleration in labor, right? Now, what you have to know is, usually we are not worried about it, but if variable decelerations become severe, which means the heart rate goes below 70 beats per minute and it is lasting for 60 seconds. Or if the decelerations are repetitive. Or if the decelerations are seen with absent beat to beat variability. Then yes, we are worried about it. Right? So then these becomes pathological. And we are worried about these types of variable decelerations. ठीक है? So either they are recurrent or they are severe. By severe we mean the heart rate dips down to very low values and it is persistent for at least 1 minute. These are the details that INI-CET people would want from you. Application and basics is what NEET PG people would want from you. ठीक है? Perfect. What is the normal beat to beat variability? So normal beat to beat variability is 5 to 25 beats per minute. ठीक है? 5 to 25 beats per minute. चलो आगे करें. Okay, a nurse is arranging Magsal for her emergency kit. Following things will help her accept. मतलब कौन सी statement true नहीं है. So नीचे से ही शुरू करते हैं. Does it cause fall in blood pressure? No, not at therapeutic range. So please remember, at therapeutic range, which is how much? 4 to 7 milli-equivalents, right? there is no fall in blood pressure. It is not an anti-hypertensive drug. ठीक है, please याद रखेंगे. It is not anti-hypertensive, which means if your patient has eclampsia, you have to add anti-hypertensive. So Magself को के साथ मुझे अलग से I will have to give anti-hypertensives. Now also here, before I go to the other options, which anti-hypertensive is contraindicated with Magself? कौन सी नहीं देनी? Calcium channel blocker, right? So don't give CCB because together they will cause respiratory paralysis. Okay, so they block the calcium receptors and they will cause respiratory paralysis. ठीक? First sign is loss of patellar reflex. Is it true? Yes. Right, this is true. It can come anywhere between 7 to 10 milliequivalents. ठीक? Please remember, what is the kind of reflexes you see in eclampsia? In eclampsia, there is hyperreflexia. Okay, there is hyperreflexia. With Magself, there is a suppression. Okay. Please remember, at around 12 milliequivalents, it will cause respiratory arrest. At 15 milliequivalents, Magself can do what? Cardiac conduction defects or arrhythmias. And at around 25 milliequivalents, it can cause cardiac arrest. Okay? All right. Magself is used for prevention of eclampsia. Yes, this is why you use it in impending eclampsia. So in impending eclampsia, you use it to prevent seizures, right? What is the loading dose? Now loading dose, बहुत सारे बच्चों को गलत मलत आता है. So I'll quickly, write this for you because it's important. So please remember, when you talk about loading dose, it has an IV component and it has an IM component. And please remember, in India, we are following only and only Pritchard's regime. There is no need to unnecessarily go and learn Zuspan, Sebai and all nonsense things. Don't increase your load. It's not required. Okay? So it is IV dose and IM dose. Now in the IV dose, it has to be 4 grams of 20% solution. Whereas here it has to be 10 grams of 50% Magself. Okay? Now how do you make 4 grams of 20%? Uska detail INICT पूछता है. So remember, you will take 4 vials of Magself, which means 4 grams and 8 ml. So it is a 50% solution. So to make it 20%, you will have to add 12 ml of normal saline. Okay? So add 12 ml of normal saline to make it into a 20% solution. Okay? Is that clear how we make 20%? Okay? Now please remember, the IV dose का maximum rate can be 1 gram per minute. उससे fast नहीं देना है. Ideally, okay, ideally you should know that IV dose should be given preferably over 10 minutes. Okay, so you will preferably give it over 10 minutes. But अगर जल्दी है तो 1 gram per minute. उससे ज़्यादा fast नहीं. IM dose हम क्या करते हैं? We give 5 grams IM in each buttock. Okay, so you have to take 5 vials and you give it 5 grams in one buttock, 5 grams in the other buttock. Okay, so that's how you give the loading dose. Quickly tell me, what will you monitor when you are giving the loading dose? So during loading dose, monitor heart rate. During maintenance dose, monitor patellar reflex. So during maintenance dose, you will monitor patellar reflex, you will monitor respiratory rate and you will monitor urine output. ठीक है? but loading dose पे you have to monitor heart rate. Two last important things that I have to tell you. Please remember, loading dose is given irrespective of renal functions. So there is no need to monitor, first get renal function test done. You can give loading dose even without KFTs. ठीक? Also, please remember, oliguria is not a sign of magnesium toxicity. Okay, it is not a sign. Why are we measuring it? Because अगर मेरे पेशेंट को oliguria है, which can be seen in women with preeclampsia, then oliguria can actually cause toxicity. Why? Because the main route of excretion is urine. ठीक है? So oliguria can cause toxicity, but not vice versa. Is that clear to everybody? So only the maintenance dose needs a change because of altered kidney functions, not the loading dose. ठीक है बच्चा? Is that clear to everybody? चलो. Now quickly tell me, you all know that Magself is used for impending eclampsia, it is used for eclampsia. You know it is used for neuroprotection. Is it used anywhere else? So yes, please remember it is a weak tocolytic agent as well. Okay, so Magself has weak tocolytic action. It's not a very strong tocolytic. See? Okay, a very basic question but an important one. Which of the following is the first stimulus for fetal testes to produce testosterone? What is the answer? It's already written there, right? HCG. A few important things that you should know about HCG apart from this. Please remember it is glycoprotein. Okay? Second point. Remember alpha subunit is identical to alpha of LH, FSH and TSH. Beta subunit is not identical but similar to beta of LH. तो अगर कोई आपसे पूछेगा structurally and functionally HCG is similar to, then what is the answer? LH. Okay, so it is structurally and functionally similar to luteinizing hormone beta. Okay, then very important things that you have to know is what cells secrete. I am sure you all know. Syncytiotrophoblast. Alright. Which hormone maintains corpus luteum? So this maintains corpus luteum of pregnancy. Right. So HCG is the one which is maintaining the corpus luteum of pregnancy. And why is corpus luteum very important? Because in first 2 months of pregnancy, which means up to 8 weeks, it is this corpus luteum that is producing estrogen as well as progesterone. Right? So it is very important that corpus luteum survives. We've already talked about critical titer, lowest value and so on and so forth. ठीक है? So ये याद रखोगे ये वाली चीजें. We have already seen certain other things about HCG. Now the only other thing that I think I might want to tell you is, when do you see maximum levels? So maximum levels are seen at around 10 weeks. They are how much? They are about 100,000 international units. इसके बाद the value will begin to fall. ठीक है? इसके बाद the value begins to fall. Also, when it comes to HCG, in which conditions HCG is higher? कौन से में higher होगा? So multifetal एक बहुत अच्छा आंसर है. Molar pregnancy is a very good answer. Down syndrome is also very good answer. Right? Which are the only two parameters which increase in Downs? HCG and inhibin A. Then conditions where there is placentomegaly, right? For example, hydrops fetalis or erythroblastosis fetalis. So these are important conditions where HCG is higher than expected. ठीक है? Is that clear? चलो. Lower किस में होता है? So lower than expected के अच्छे answers क्या हैं? Ectopic, then abortion, then trisomy 18. So trisomy 21 में high होता है, trisomy 18 में low होता है. Then conditions where the placenta is going to be small, like preeclampsia. ठीक है? So these are conditions where it is going to be lower. All right? Chalo. Okay. So we've covered quite a few things about diabetes. We'll cover these few as well. So your patient has gestational diabetes at 28 weeks. She is at increased risk of all except. So did you all read the except? What is the answer here? IUGR. Because they are more likely to do what? To show macrosomia. IUGR हो सकता है, but it is uncommon. For the same reason, which investigation is not routinely used in diabetics? Because IUGR is uncommon, therefore, Doppler ultrasound is not routinely used in diabetic pregnancy. Theek? Okay. We've already talked about shoulder dystocia, so I'm not going to talk about it again. But sudden IUD का reason होता है macrosomia. So macrosomia is actually a risk factor for sudden intrauterine death. ठीक है? CS के बारे में क्या जानना है? Can you tell me what estimated birth weight in a diabetic pregnancy is an indication for cesarean? So if the weight is more than or equal to 4.5 kgs, okay, then it is an indication for cesarean. Quickly tell me these answers. Which is the most common anomaly in a diabetic pregnancy? So when we ask you most common, the answer is VSD or cardiovascular anomalies. If we ask you most specific anomaly, then what is the answer? So most specific anomaly is caudal regression syndrome. What is the other name for caudal regression? Caudal regression syndrome is also called as sacral agenesis. बार बार एक basic question आपके exam वाले पूछते हैं. Will GDM cause anomalies? The answer is no. So please remember, GDM does not cause anomalies. नहीं बेटा, TGA is only specific within the cardiovascular system. यहाँ हम cardiovascular नहीं पूछ रहे हैं, हम in general पूछ रहे हैं most specific, and therefore the answer is caudal regression. ठीक है? All right, so those are some of the other things that we must know with respect to diabetic pregnancy. Can you tell me which hormone is responsible for insulin resistance in pregnancy? HPL. HPL is also responsible for fetal growth. Can you tell me how? Because HPL causes release of IGF-1, okay? Insulin-like growth factor 1, which is the main reason for fetal growth. Please remember, growth hormone is not involved in fetal growth. Okay? So growth hormone is not involved in fetal growth. It is actually IGF, insulin and insulin-like growth factors. Okay? Chalo. Let's go on to the next one now. A 26-year-old lady on follow-up after evacuation for complete mole at 2 months shows cannonball metastasis. So now, can you tell me cannonball metastasis means what? It means mets to lungs. Which means I want you to tell me two things. Number one, what type of GTN are you dealing with? We are dealing with choriocarcinoma. Second, what stage GTN are you dealing with? Stage 3. Third, even though it is stage 3, is it good prognosis or bad prognosis? It is good prognosis. It is given a score of 0 in the WHO scoring system. Okay? And look at the age. Age is also low risk. Again, a score of 0. Developing within 2 months. So if it happens within 4 months, then also again it is given a score of 0. Which means इस patient का total score कितना आएगा यार? Less than or equal to 6. So if the total score is less than or equal to 6, this means my patient is low risk GTN. Okay, please remember, stage 1 is also considered as low risk GTN. So if your patient is low risk GTN, what is the treatment of choice for her? आप ध्यान से सुनोगे, गलती नहीं करोगे. The choice is single agent. मतलब एक ही ड्रग देना है, कीमो. What is the drug? Methotrexate. But will you give single dose or multi dose? कितने लोगों ने ये गलती करी? Yes, so drug एक ही है, so it is single agent, but it is multi-dose regime. Multi-dose regime is what you give for cancers, right? जिसमें कि आप day 1, day 3, day 5 और day 7 पे methotrexate देते हो, and on days 2, 4 and 6 and 8 आप क्या देते हो? Folinic acid to reduce the side effects. है ना? So it is single agent but multi-dose. ठीक है? Don't confuse this with ectopic. Ectopic में single agent, single dose था. ठीक है? I hope you will not get confused again. Okay. What if your patient is high risk GTN? So who is high risk GTN? If the WHO score is more than or equal to 7 or stage 4. Stage 4 is also considered as high risk. है ना? So now once your patient is high risk, what is the treatment of choice? Yes. The treatment of choice is EMACO, which means multi-agent. Okay, multi-agent chemotherapy. अब एम्स वाले 1 level higher जा सकते हैं. They might ask you, if your patient is methotrexate resistant, तब क्या देना है? Then you will give actinomycin D. And if your patient is EMACO resistant, तो क्या देना है? The regime now changes to EMA-EP, right? EMA-EP. And now can you tell me what is the period of surveillance in GTN? So please remember, period of surveillance for GTN is 12 months. What is the period of surveillance for complete mole? 6 months. For partial mole, only 1 month, right? Please remember the contraceptive of choice remains the same, which is OCP. Which contraceptive to be avoided also remains the same, which is IUD. ठीक है? Chalo, perfect. What is the most important advice? Not to conceive, okay? Because if she conceives, the HCG begins to rise, all right? Okay. Which of the following is not correctly matched to its anesthesia? So this is again a typical NEET PG question. They have been repeatedly asking these questions, right? Heart disease. So please remember, in general for heart disease, the answer is epidural. But in those heart disease where ejection fraction is low, there the answer will change to GA. ठीक है? For example, कौन कौन से हार्ट डिजीज? जैसे कि मार्फन्स विद आयोटिक वाल्व, देन coarctation with aortic root involvement, then aortic dissection, okay? Then if your patient has heart failure, So in these conditions where the ejection fraction is low, there the answer will be GA. Otherwise, in general for heart disease, the answer is epidural. Cord prolapse. Again, yes, the answer is general anesthesia because we don't have time at all, right? Uterine inversion is incorrect. The answer should be general anesthesia. What is the anesthesia in preeclampsia? Again, epidural. Eclampsia, epidural. मगर अगर आपके पेशेंट को रिपीटेड सीजर्स आ रहे हैं लाइक स्टैटस एपिलेप्टिकस, फिर क्या करना है? Then GA. ठीक है? Otherwise the answer remains as epidural. Manual removal of placenta? Yes. General. देखो जहां पे भी you have to put your hand intrauterine, like manual removal, like internal podalic version. Right? So please remember IPV is again going to be general anesthesia because we are going to put our entire hand inside. ठीक? Then the answer will again be general anesthesia. ठीक? Can you tell me which is the most common anesthesia used in CS in general? So here the answer is spinal. Can you also tell me what is the level of block? T4. है ना? The level of block is T4. What type of block are you going to give if it is painless labor or epidural analgesia? ठीक है? So epidural analgesia is what is painless labor. And here the level of block is T10. Okay, so here the level of block is T10. So this covers most of the important things that you need to know with respect to anesthesia in various conditions of obstetrics. ठीक है? चलो. Beta, it is very simple. The general answer in OBS is, spinal for cesarean. Epidural is reserved for certain conditions. And for very few conditions, it is going to be GA. So that is why we will either ask you where the answer is epidural or where the answer is general. Okay? Otherwise, everywhere else, it's simply spinal. Chalo. A lady with central placenta previa presents with one episode of bleeding at 32 weeks. Her BP is given to you. Hemoglobin is given to you. What is the next step? Okay? So remember that this makes her an ideal candidate for expectant management or for conservative management. What is the name of conservative management? What is the name? It is called as Johnson's and McAfee's regime. Okay, so it is called as Johnson's and McAfee's regime. ठीक? बेटा epidural analgesia सबको इसलिए नहीं देते because number one, our patients are not affording. Number two, we don't have the doctor-patient ratio that we need to monitor these patients who are being given epidural. ठीक है? So either you start working in corporate big hospitals where richer patients are coming to you and they are more affording, then yes, you will see epidural analgesia quite often. ठीक? Okay. Now please remember some doubts. When I say conservative management, what are the requirements for this? So number one, please remember the patient has to be hemodynamically stable. That's the first thing. Second, POG should be less than 37 weeks. Third, there should be no active bleeding. There should be no fetal distress. Right? So stable patient, stable baby, no active bleeding, no fetal distress, and the woman should not be in active labor. So these are the requirements for conservative management. Now doubts. I've seen some students keep asking me, ma'am, can we do this in conservative? Can we do that? So what are you going to do here? Tell me. You will do fetal monitoring. You will do maternal monitoring. What else will you do? Who is going to tell me? So please remember, if POG is less than 37, what else will you do? You can also give steroids for lung maturation. If POG is less than 32 weeks, you can also give Magsulf. This is for neurodevelopment. If the patient is less than 34 weeks and she has mild contractions, what can you do? You can give tocolysis. Which one will you give here? Nifedipine. भाई concepts तो वही रहते हैं ना, जैसे हमने पहले पढ़ा. You can give tocolytics provided the POG is less than 34 weeks and provided she is having some contractions. Otherwise, why will you give it? ठीक है? Should I put a cerclage? No. There is no role of cerclage. Okay, so there is no role of cerclage in the conservative management. ठीक? I hope this makes things clear. Is it okay now? What are the keywords in which in a clinical question you will get to know that the patient has placenta previa? What are the keywords, Betu? So remember the keywords are painless bleeding. ठीक है? Second, fundal height is equal to POG. Sometimes it may even be less, but it will not be more. Third, there are episodes of warning hemorrhages. Warning hemorrhage का मतलब होता है small bouts of bleeding, not massive bleeding, small bleeding, right? So warning hemorrhages is very characteristic to placenta previa. Then on PA examination, the uterus should be relaxed and it should be non-tender, right? Very often you will get malpresentations, right? So please remember, placenta previa has high association, okay, with malpresentations. Which malpresentation? The single most important one is transverse lie. Yes. So bleeding is the common thing which you come across in abruption also, previa also. So when we say it is painless, it is also said to be causeless and it will be fresh bleeding. It's not altered bleeding. So these things help to differentiate it from a case of abruption. So most of the times the exam, especially NEET PG, is asking clinical vignettes on placenta previa, on abruption, on rupture uterus, right? And they're all DDs of each other. Vasa previa, labor, ठीक है? Chalo. Which is the last parameter to become abnormal in biophysical profile? What is the answer? It is fetal tone. पहले तो मुझे components बता दो. What are the components? So, fetal breathing movements, then apart from that, gross body movements, right? Then fetal tone. What else is considered? Amniotic fluid. Now this is where some bachas get confused. Do we need to measure the amniotic fluid index for this? No. Okay. So in biophysical profile, I don't need the index. We are only seeing if I am able to see a single pocket of 2 centimeters, then it is considered as a score of +2. So no, we don't need amniotic fluid index. ठीक है, मेरी बात समझो. We don't need to count the entire amniotic fluid. Even if I see one pocket of at least 2 centimeters, okay, then this means amniotic fluid criteria is +2. How many breathing movements you need? One movement which is lasting for 30 seconds. How many gross body movements do you need? 3 gross body movements, right? What do you need in fetal tone? In fetal tone, we need one movement of flexion, extension and back to flexion. Okay? So this is what we need, and the NST needs to be reactive. Okay? NST needs to be reactive. So please remember, this is what you need for BPP. Okay? If the BPP score is 8 by 10 or 10 by 10, okay, then this is considered as normal, no distress. 6 by 10 with oligo is considered as borderline. Okay, or we say equivocal. Anything less than or equal to 4 by 10 indicates hypoxia. Needs emergency cesarean. Okay, quickly tell me one question. Is biophysical profile reliable across all ages? Is biophysical profile reliable across all ages? The answer is no. I told you, all the parameters here are dependent on baby's neurological maturation. So if the baby is preterm, some of the parameters will be abnormal because of prematurity, not because of hypoxia. Okay? So please remember, it is not reliable across all ages. It will become more reliable beyond 32 weeks. Exactly. Very good. So good concepts, clearing, application. That's what I want. That will reduce the mugging up part. Okay. Quickly tell me what is modified BPP, बच्चा? अच्छा, पहले BPP का दूसरा नाम क्या होता है? So biophysical profile is also called as Manning score. ठीक है? It is also called as Manning score. What is modified BPP? Modified BPP has been a named MCQ twice. है ना? So modified BPP consists of NST plus amniotic fluid assessment. Right? Here you need to do a complete assessment. So here we will use amniotic fluid index. Is this clear? I hope there is no confusion now. Right? And if modified BPP is abnormal, you will have to do a complete BPP. Okay? You will have to do a complete biophysical profile. Okay? Is that clear? Okay. So now we are left with about 15 MCQs. Do you want a short break? Yes? We'll probably finish by anywhere around 9 or 9:15. But if you want a 5-10 minute break, we can do that. We can definitely do it. सबको चाहिए तो मुझे बताओ. Then I can take a short break. See, it's very difficult if half of you say no, half of you say yes. So, okay, I think, Arey Baba, it's very difficult if I ask you. Acha, stop typing. Alright, we'll take a 5 to 7 minute break. ठीक है, 8 बजे, 8-7 we will restart. So that I keep both sides happy. ठीक है, 8-7 I will restart. Chalo. Hanji, is everyone back? Gigi, I am back. What about all of you? Are you back? Okay. So let's go on to question number 62. And most of it we have already discussed. So you should be able to give me an answer. All the following are used for cervical ripening except. So what is the answer? The answer is PGF2 alpha. ये NEET PG का one of the favorite MCQs है. So please remember, PGF2 alpha is not used for induction of labor at term. I already told you where is it used. It is used for postpartum hemorrhage, right? So management of PPH. Can we use PGF2 alpha for abortions? Yes, we can use it for second trimester abortions. Now, with respect to induction of labor, एक और MCQ है which NEET PG people are fond of asking, and that is contraindications. So अब मेरी बात ध्यान से सुनो, खाली रट्टा नहीं लगाना है, right? All the conditions where vaginal delivery cannot happen, anyways will become contraindications. So can you give me some good answers where induction of labor is not done? So very, very important conditions like classical cesarean, okay? Conditions like patient who has a history of rupture uterus. Conditions like transverse lie where there is no mechanism of labor. Then conditions like placenta previa, contracted pelvis. नहीं, CPD नहीं है बेटा आंसर. CPD में तो trial of labor is the best thing. Contracted pelvis is the answer. ठीक है? So contracted pelvis. Then yes, a patient who is a known case of cancer cervix. Okay? Then cord prolapse. Right? Vasa previa. PAS. है ना, जो चीजें हम पहले कर ही चुके हैं. Right? PAS. Yes, category 3, category 4, fetal heart rate. Or actually just category 3, fetal heart rate. Do you know what comes in category 3 fetal heart rate? So this is actually either if the baby shows sinusoidal heart rate or the baby shows absent beat to beat variability, ठीक है, with late decelerations or with bradycardia or with variable decelerations, right? So if there is absent beat to beat variability with these things, then they're called as category 3 FHR. Then yes, active genital herpes, okay, active genital herpes. So these will become all contraindications of induction of labor. नहीं, twin में कर सकते हैं. Please remember, twin में as long as the first baby is vertex, ठीक है? So if the first twin is vertex, vaginal delivery is possible, beta. Okay? Only if the first twin is non-vertex, then you do a cesarean. ठीक है? Yes, Garima, you can do everything in CPD, you know, provided it is not a previous cesarean. If you're just talking about normal CPD in a non-scarred uterus, you have to do a trial of labor. ठीक है? Yes, PAS is placenta accreta spectrum बच्चे. ठीक है? So these are important contraindications and NEET PG is repeatedly asking questions on this. So it's better to know this, and the logic is very simple. Wherever you can't do vaginal delivery, you will not do induction. Now with respect to INICT, so please remember INICT ना आपको actually Bishop score calculate करने को कहता है. Twice it has come. And I know for बच्चास it becomes difficult. तो मैं क्या चाहती हूँ, आप लोग ये simple rule follow करो. Remember the conditions which are getting a score 1. Why? Because they are all mid conditions. Like cervix will be mid position, effacement will be 50%, station will be -2, consistency will be medium, right? And dilatation बस एक अलग से याद करना पड़ेगा, which is 1 to 2 centimeters. तो आप मेरी बात ध्यान दो. Remember all the parameters which are getting a score of 1, and they are actually mid वाले criterias. So if you remember this, believe me, it will be very easy for you to calculate the score if they give it again. ठीक है? So remember this. Remember 1 wale, and then you will be able to reach the answer even if you're not exactly able to calculate it. So ye kar lo, it will become much easier for you. Calculation is only required for INICT. NEET PG will usually not ask you calculation. Also, please remember, out of all these criterias, the most important criteria for induction of labor is cervical dilatation. And the least important one is actually position of the cervix. So most important is dilatation and least important is position. ठीक है? We have already discussed what is modified Bishops, what is simplified Bishops. Those are the other cues that you should know. Chalo, let's move forward now. All are true about peripartum cardiomyopathy except, again, NEET PG. As I said, NEET PG wale width, मैं बार-बार force कर रही हूँ, width. They are asking more topics than INICET. ठीक है? So now, Is it development of heart failure? Yes. So that is actually the presentation. Sudden onset of breathlessness. Right? So these patients develop sudden onset of breathlessness. Please remember, the patient should not be a known case of heart disease. So patient is not a known case of heart disease. Okay? Criteria kya hai? How do we make a diagnosis? The patient has to develop heart failure in peripartum period, which means which period? From 36 weeks to 5th month postpartum. Right? So from 36 weeks to the 5th month postpartum is when she develops heart failure, not 28 to 32 weeks. And most commonly she will develop it in the first week postpartum. So most common heart failure will happen in the first week postpartum. Okay, bache, is that clear? Okay. How do you confirm the diagnosis? By doing a echocardiography. So on echo, the single most important diagnostic criteria is ejection fraction. So if it is less than 45%, we say that yes, this is heart failure. If it meets the other criteria, which means no underlying heart disease, the correct time, then you will say it is peripartum cardiomyopathy. Okay, can you tell me which hormone is implicated in peripartum cardiomyopathy? So when we talk about which hormone, then here the answer is not HCG. Okay? Here the answer is prolactin. Also, please remember the risk factors. So the risk factors are multipara, women with preeclampsia, women with advanced maternal age. Okay, so these are important risk factors, right? So women with preeclampsia, women with multifetal pregnancy, women with advanced maternal age. They are at risk of developing peripartum cardiomyopathy. Okay, treatment kya karta hai? Treatment is simple treatment of heart failure, but you should add bromocriptine. So we have seen that these patients respond well if you add bromocriptine, right? So this is what you should know about peripartum cardiomyopathy. Is that clear? So remember, not a known case of heart disease and the correct time period. All right? Chalo. Ventouse is again something that the NEET PG people are fond of asking. They are repeatedly asking, to important hai bacha. Okay? More than forceps. So in which is it contraindicated? So please remember, it should definitely not be given if the pregnancy is preterm, and it is absolutely contraindicated at less than 34 weeks. So less than 34 weeks is an absolute contraindication. Okay? Second important thing, what are the other contraindications for vacuum? So please remember, face presentation, okay? Then after coming head of breech, okay? In these conditions also you cannot put vacuum. Then apart from this, please remember, in general, presence of CPD, presence of contracted pelvis, okay, are contraindications for any instrumental delivery, not just for vacuum. They are contraindications for all types of instrumental delivery. Then HIV positive women. Again, instruments should not be used. Then if the baby is a known case of osteogenesis imperfecta, or if the baby has known coagulopathy, okay, then these are in general contraindications for instrumental delivery. Okay, so ye cheezein aapko yaad rakhna hai. Then please remember, when we say vacuum, you should know, is it more easier to apply? Definitely yes. Okay, so vacuum is more easier to apply, and this is exactly why it is more commonly used. Not because it is better, it is easier to apply. Okay? Also remember, the pressure generated is around 600 millimeters of mercury or 0.8 kgs per centimeter square. Uterine inertia में तो करना है ना बेटा. How will you bring out the baby, right? So if the uterus is not contracting, very well, then you will have to do instrumental delivery in the second stage. So it's not a contraindication. Okay. This is probably a reason why you would have to do instrumental delivery. Okay. Please remember, अरे भाई वो तो anyways contraindications for instrumental delivery हो गया ना. Please remember, for instrumental deliveries, the station has to be more than 0, right? So one of the requirements is head should be engaged. Okay. Vacuum can be applied even at 0 station. Okay. So for example, in DTA with normal pelvis, you can apply vacuum. So I'll come to that part. So vacuum is easier, it is more commonly used. Pressure. Then what are the advantages? That is what I was about to tell you. When it comes to advantages, first, it can be applied at and beyond 6. I am not saying that is an absolute requirement. Okay. Ideal for vacuum is also full dilatation. But yes, beyond 6 we can apply if required. Okay. Second, it can be applied to even non-rotated head. Okay. So it can be applied to even a non-rotated head. So yes, in case your patient has DTA and normal pelvis. Okay. The pelvis is not abnormal. If your patient has deep transverse arrest and the pelvis is normal, then yes, you can apply vacuum. ठीक है. तीसरा important चीज, जैसे कि हमने बोला, when it comes to vacuum, it can be applied even when the station is higher, right? So when the station is 0, even then vacuum can be applied, but forceps cannot be applied, right? So then forceps cannot be applied. Okay, is that clear? Okay. Heart disease, beta, heart disease may you have to cut down the second stage of labor. But yes, in general we say in heart disease, forceps is preferred over vacuum. It doesn't mean vacuum is contraindicated. Okay? Vacuum is not contraindicated in heart disease. It is an indication to put an instrument. Alright? Chalo. When it comes to vacuum, there is one more thing that you should know, and that should be correct application. Okay, let's look at this. So this is a vacuum cup. You have to know where exactly are you going to put it. Okay? So now there is a point on the sagittal suture of the baby's head which is called as flexion point. So this flexion point is where? It is on the sagittal suture. अब मुझे ये बताओ कहाँ लगाना है is the question, right? So this is a point on the sagittal suture, but where? So this point lies 3 centimeters anterior to the posterior fontanelle. You remember I told you how to identify it? We said posterior fontanelle is triangular. So it is 3 centimeters anterior to the posterior fontanelle, or you can say it is 6 centimeters posterior to anterior fontanelle. Right? So this is the exact position of the flexion point. Do you know why it is called as flexion point? Because if you apply the cup here and then you pull, it maintains head inflection. And when you maintain head inflection, smaller diameters are going to come out, the injury will be less. Ab mujhe batao, do you think in real life we measure these things? No. So just by looking at the image, forget about all these measurements. Can you tell me, just by looking at the image, how do you know about correct application? कौन बताएगा? So correct application, image देख के कैसे पता लगेगी? If the vacuum cup is correctly applied, it will touch the margin of which fontanelle? Posterior fontanelle. So in the correct application, okay, the margin of the cup touches posterior fontanelle. Is that clear? And then you know that it is a correct application. Okay, is that clear? Yes. Not the anterior, the posterior one. Okay, perfect. Also, INI-CT वाले यहाँ पे क्या पूछेंगे? INI-CT वाले पूछेंगे, when you talk about instrumental delivery, they will ask you which fetal injuries, okay, are more common with forceps. Okay, so can you tell me what will you answer if they ask you for forceps? So if they ask you for forceps, the answer should be brachial plexus injury. The answer should be facial nerve palsy. These are very good answers for forceps. Okay, apart from that, yes, it can cause injury to the cornea of the eye. And it can also cause lacerations of the skin and the scalp, right? That can also happen. But if we ask you injuries which are more characteristic to vacuum, okay? So fetal injuries characteristic to vacuum, then what is the answer? Then the answer is number 1. Good answers are sixth nerve palsy, okay, injury to the retina, shoulder dystocia, and cephalhematoma. So these are good answers for vacuum. Also, can you tell me maternal injuries किससे होती हैं? Forceps से ज़्यादा होती हैं या vacuum से ज़्यादा होती हैं? So maternal injuries are more with forceps, है ना? So maternal injuries are more with forceps. ठीक? चलो. Let's go on to the next question. Again, something that some specific drugs, the NEET PG people are very fond of asking. So side effects of oxytocin are all except, what is the answer? Hypertension, right? It actually causes what? It causes hypotension. Especially if you give IV bolus. This is exactly why you should not give it IV bolus. Because if you give it IV bolus, वो क्या करता है? Severe hypotension. This hypotension can cause tachycardia, it can even cause arrhythmias, it can even cause an MI, it can also cause a cardiac arrest. Okay? So if at all you want to give oxytocin IV, the correct method will be IV infusion. Okay? Second question. Can you tell me what dose are you giving for prophylaxis in AMTSL? So please remember, in AMTSL again, the drug of choice is oxytocin. What is the dose? 10 international units. It can be given IM, it can be given IV infusion. Okay? Next, I want to ask you, if you give oxytocin IV infusion, okay, if you are giving IV infusion and you give it in dextrose, okay, so if you give it in dextrose, can you tell me which complication will you see? So if you give large doses of oxytocin as IV infusion in dextrose solution for long duration, right? Then what complication will you see? Very good. Excellent. Rupeshwar, yes, you will see water intoxication. So because it has ADH-like action. Okay? Some important other words about oxytocin should be, please remember it has a TF of 3 minutes. Range is 3 to 5 minutes, but the single best answer is 3 minutes. Also, please remember that it is released from which place? Hypothalamus. Okay? It is released from the hypothalamus, the paraventricular nucleus, whereas if we ask you stored, then it is posterior pituitary. And rather than released, I should say actually made where, right? So oxytocin is synthesized will be a better answer because release में तो आप confuse हो जाओगे. Release तो posterior pituitary से भी होगा. So synthesize is a more specific way of saying it. So synthesized in the paraventricular nucleus. Okay, remember the release from the posterior pituitary is pulsatile. Do you know what is the reason for after pains? Who's going to tell me the reason for after pains? So after pains are pains after delivery, but what is the reason? So again, this is because of release of oxytocin. So whenever the baby suckles, the suckling causes release of oxytocin, which causes contractions and pain. And it is also called as the milk ejection hormone. These are all NEET PG PYQs. So NEET PG is asking all these things about oxytocin. So you better be careful and you know them, hai na? So it is also called as the milk ejection hormone. Okay. How does oxytocin act? Do you all know this? So please remember it acts by two ways. ठीक है? Oxytocin एक तो क्या करता है? It will increase the intracellular calcium. दूसरा, it causes increased release of PGF2 alpha from the decidua. So main mechanism is increasing intracellular calcium, but yes, it also causes release of PGF2 alpha. ठीक है बच्चा? चलो. So what is this image? Can you tell me? So a lot of you confuse this image with shoulder dystocia. Beta, this is not shoulder dystocia. This is actually something which is called as neglected shoulder presentation, not shoulder dystocia. So which means this is seen in actually transverse lie. Okay, so this is actually seen with transverse lie. And when you say neglected shoulder, this means the baby the patient has gone into obstructed labor. And once she goes into obstructed labor, the baby may be alive, it may be dead as well. So when you talk about fetal heart rate, there may be severe distress or there may be absent fetal heart rate. How can I look at the image and say it is obstructed labor? So look at the upper segment of the uterus. And now what has happened to the upper segment? Upper segment is tonically contracted. And what happens to the lower segment? Lower segment is stretched out and thinned out. And there is this arrow that we have shown here, right? So what is this? There is a depression or a ring between the two. What is it called as? This is what is the Bandel's ring. So Bandel's ring is seen with obstructed labor. Hai na? So just by looking at the image, we know that there is obstruction. So now what is the answer? So there are very few places where even in the or even with absent FHR, the management is going to be cesarean. Okay? So cesarean is the treatment of choice or management of choice even with absent FHR. Okay? Can you tell me, if I reverse the question and ask you, out of these all four choices, which one cannot be done? So which cannot be done? तो अगर मैं पूछूं which cannot be done, तो answer है craniotomy. Please remember, craniotomy is done where? It is only done in vertex presentations. Okay? You cannot do a craniotomy in transverse lie. Can we do decapitation and evisceration? Yes, they are theoretical answers. They're not treatment of choice. We don't do destructive procedures. But decapitation and evisceration can be done. Okay? Right? So they can be theoretically done, but not craniotomy. ठीक? हाँ जी, craniotomy का मतलब होता है cranium में incision देके skull को खोलना, brain को release करना. Decapitation होता है सर को काटना from the neck. Right? So they are very different things. ठीक है? Okay. Some of the important one-liners with respect to transverse lie. पहला चीज. Please remember, when they ask you management of transverse lie at term, the answer is just like cesarean section, just like breech, which means you first do an ultrasound. Okay. If there are contraindications for ECD, then you will do cesarean at 39. If there are no contraindications to ECV, then you will do external cephalic version. So management is just like breech. ठीक है? दूसरा, if they ask you one-liners like most common cause of transverse lie, then what is the answer? So remember this. In general, most common cause of transverse lie is prematurity. But if they ask you most common cause of transverse lie at term, right? So if they ask you at term, then the answer will change to placenta previa. Okay, is that clear to everybody? Okay. Also, please remember, among all malpresentations, transverse lie has highest risk of cord prolapse. आप लोग क्या करते हो? आप लोग फुटलिंग ब्रीच आंसर करके आते हो. फुटलिंग ब्रीच हैज हाई रिस्क बट विद इन ब्रीच. इन जनरल ओवरऑल रिस्क इज हाईएस्ट विद ट्रांसवर्स लाई. ठीक है, चलो. दिस वी हैव ऑलरेडी डन. आई हैव टोल्ड यू हाउ टू कैलकुलेट. सो अगर डायलिटेशन 50% है, ठीक है, तो इसका स्कोर कितना होगा बताओ, मैं तुम्हें करके दिखाऊंगी. सो इफ द डायलिटेशन इज 50%, स्कोर क्या होगा? 1. ठीक है, 40 to 50% was 1. Then, sorry, dilatation is, 50% effaced. मैंने मार्क गलत करा. So it means इसका स्कोर कितना हो गया? 1. Dilatation is 2 centimeter. तो वो भी मैंने बोला था 1 to 2 centimeter is given a score of 1. ठीक है. मीडियम कंसिस्टेंसी, उसको भी स्कोर कितना देंगे? 1. ठीक. मिड पोजिशन, उसको भी कितना देंगे? Another 1. Yes, so can you see how simple it becomes? So already we have reached a score of 4, right? And vertex is at -3. So what was given a score of 1? What vertex was given a score of -1? Do you remember? Tell me. So if the station is -2, yes, do you remember? Then we were giving a score of 1. So if it is -3, the score is 0. ठीक है? Very good. So इसलिए आंसर क्या होगा? 4. ठीक है? So now you understand what logic I said? कि 1 वाले remember कर लो, वो सारे mid वाले हैं. ठीक है? उसके में तुम्हें सिर्फ एक और याद करना पड़ेगा कि 1 to 2 सेंटीमीटर्स को भी 1 देते हैं और -2 स्टेशन को भी 1 देते हैं. ठीक है? वो दोनों सेम है. 2 है ना, 2 सेंटीमीटर -2. सो नाउ डू यू थिंक इट इज डूएबल? बिकॉज अदरवाइज आई नो आप लोग बहुत डरते हो इस कैलकुलेशन से, एंड आई अंडरस्टैंड, बट नाउ डू यू सी हाउ डूएबल इट बिकम्स. सो बाकी तीनों में मिड है, स्कोर 1. डायलिटेशन ऑफ 2 सेंटीमीटर, स्कोर 1. स्टेशन ऑफ -2, स्कोर 1. वो दोनों 2 हैं. ठीक है, चलो. Right, so this one again we have already done. I'm not going to do in detail. I've discussed all the doses and everything. So misoprostol discussed in detail. Oxytocin is the answer here, but I hope you know the answer. What is the reason? The reason is IV bolus. We will not give IV bolus. We have to give IV infusion. ठीक है? Carbetocin we have already done. This is correct. Methergin का डोज आना चाहिए 0.2 milligrams IM. ठीक है? Quickly tell me what are contraindications for methergin. So please remember, patients who have hypertension like preeclampsia or eclampsia, you will never give methergin. इसके अलावा women with heart disease, women with peripheral vascular disease. So these are very good answers for contraindications of methergin, right? Heart disease is one question where they keep on repeating. इसके अलावा बाकी सब जो है वो useless हैं. They don't help you in exams. Like it is contraindicated after delivery of first twin. Please remember, you can give it in the second twin when the second twin is out, but not after the first twin. And it is relatively contraindicated in Rh negative. सो लास्ट वाले दो याद नहीं भी हुए, दैट इज ओके, बट प्री एक्लैम्सिया, पेरिफेरल वैस्कुलर डिजीज, हार्ट डिजीज आपको याद रहना चाहिए. ठीक है. व्हाट इज द इंपॉर्टेंट साइड इफेक्ट ऑफ माइजोप्रोस्टॉल, जिसपे हम एमसीक्यू पूछते हैं. सो रिमेंबर, माइजोप्रोस्टॉल कॉजेज हाइपोटेंशन and misoprostol will cause hyperthermia. Hyperthermia with miso is important. It causes fever with chills. हम एग्जाम में पूछते हैं. ठीक है. कार्बेटोसिन मैं आपको बता चुकी हूं, इट इज एन ऑक्सीटोसिन एनालॉग, बट फर्क क्या है, इट इज एन ऑक्टापेप्टाइड. ओके. Normal oxytocin is a nonapeptide. This is actually an octapeptide and it has a longer half-life of 40 minutes. Can you tell me an oxytocin receptor antag? Anybody? Oxytocin receptor antag, because वो डाल के वो confuse करते हैं. This becomes atosiban, which is actually used as a tocolytic. ठीक है. So atosiban is an oxytocin receptor antag and it is a tocolytic. ठीक है. Okay. We have done most of these signs, so you will quickly help me with this. Which one is not correct? Ectopic pregnancy. Now I have already told you the signs of ectopic pregnancy. I am not repeating it, Betu. ठीक है. The answer here is intradecidual sign. It is a marker of intrauterine pregnancy. ठीक है. We have talked about honeycomb, we have talked about twin peak, we have talked about double bleb, double decidual, we have talked about all. एक double रह गया. One double. What is double bubble? ये किस में मिलता है? So double bubble is seen with duodenal atresia. It has a strong association with what? Batao? It has a high association with trisomy 21 or Down syndrome. So please remember, if on level 2, okay, so if on level 2 ultrasound, which is your anomaly scan, if you see duodenal atresia, and we are asking you what should you do next, what should be the answer? The answer should be karyotyping. Okay, so it has a high association with Down syndrome. All right. Chalo. Okay. Some very basic questions about implantation. Again, NEET PG as well as INICT दोनों पूछते हैं. So uterine receptivity is limited to day 20 to 24 of the cycle. Yes. This, when you say cycle, we mean here the menstrual cycle. And therefore, this day 20 to day 24 is called as implantation window. Okay. What is the correct sequence for implantation? Apposition, adhesion, invasion. This is also correct. What is required for apposition? Selectance. What is required for adhesion? Integrins. What is required for invasion? Matrix metalloproteinase. Okay. What is wrong with option D? Morula does not begin implantation. Implantation happens in what stage? Blastocyst. Okay. Blastocyst. And most important marker for receptivity is integrins. Yes. So out of selectins, integrins and matrix metalloproteinase, it has to be integrins. Okay. Okay. Quickly answer this. The conceptus enters uterine cavity on which day? On day 4, right? So it enters on day 4 post fertilization. The range is day 3 to 4. In what form does it enter? Morula, which is the 16 cell stage. Okay. On what day does implantation begin? और ना नीट पीजी वाले बार बार एक ना एक ऐसे बहुत ही सिंपल सा एमसीक्यू जरूर देते हैं, because it really sort of makes the paper a little more doable and less confusing. है ना? So please remember, implantation, when we ask you when does it begin, it begins on day 6. When does it end or complete? It is completed by day 10. ठीक है? When is blastocyst formed? So blastocyst is formed on day 5. ठीक है? When is zona pellucida lost? Which is also called as day 5. So zona pellucida lost को हम क्या कहते हैं? Zona hatching. Okay? So we also call it as zona hatching. So this happens again on day 5. Then some very basic questions like, what is the site of fertilization? I'm sure you will not do any of this wrong, but I'm just putting it at one place for you. So the site of fertilization is ampulla. What is the site of implantation? So implantation is not fundus. Implantation is upper posterior wall. Okay. What is implantation? Again, another thing. Yes, upper posterior wall, and it is eccentric. Never in the center. It's more towards one side. Okay. And yes, lastly, what is implantation bleeding called as? So bleeding at the time of implantation is called as Hartmann's sign. Okay, so Hartmann's sign. Take. Chalo. Which of the following finding is normal in pregnancy? So we've done some of these already. So free T3 increase hota hai? No. Okay, this is false. Increase in respiratory rate? No. This also shows no change. Increase in TLC? This is definitely true. It can go up to 15,000. Increase in hemoglobin? Fall. There is a decrease. There is hemodilution. Okay. Some of the other ones which I know that either NEET PG or INI-CT has asked, सारे तो मैं यहाँ नहीं cover कर सकती, but I will definitely ask you a few. For example, can you tell me what happens to the depth of respiration? So please remember, depth of respiration increases. Okay. What happens to GFR? Increases by 50%. Okay, I'm asking you the ones which have been PYQs, right? So I'm trying to stress on the PYQs. Okay, what happens to vital capacity? No change. What happens to reserve and residual volume? Decrease. Okay? Reserve and residual volume decrease. What happens to, let's say, okay. Cardiac output, you all know increases, but I want to know about cardiac output. Please remember, maximum cardiac output is seen when it is seen at or in immediate postpartum. Okay. The second highest is in the second stage of labor. And then the answer is 32 weeks. Please remember, cardiac output actually decreases a little at term. This is what the AIMS people had asked previously. Okay, so cardiac output decreases slightly at term. Also, please remember, जो हमने cardiac output का order लिखा है, this is also the order for highest risk of heart failure. Right? So, if in the exams they ask you highest risk of heart failure, the order remains the same. Okay. What happens to peripheral vascular resistance? Okay, as I said, trying to cover the ones which are PYQs. Okay. What happens to peripheral vascular resistance? Decreases. Okay. What happens to ESR? Increase. What is the reason for ESR increase? Increase in fibrinogen. Okay, I'm only covering the PYQs here, right? The ones which have been asked in INI-CT or NEET PG over last 5 years, right? So ESR is this. Which clotting factor decreases? So please remember factors 11 and 13 decrease. Okay, factors 11 and 13 decrease. Take. Okay. Can you see hydroureter in pregnancy? Yes, hydroureter is physiological and it is more common on the right side as compared to left side. Whenever they ask you reason for any physiological change, the single best answer is progesterone. Okay? Combination, yes, E and P together become better answers, but जब एक आंसर मार्क करना होगा, the answer is progesterone. Okay? So the cause of hydroureter is also progesterone. Okay? What happens to LH, FSH in pregnancy? They are suppressed. Very low levels are seen with respect to LH and FSH. Thyroid we have already covered. When do you see highest levels of prolactin? So highest levels of prolactin are seen in the third trimester, not during lactation. So please remember, after delivery, prolactin levels decrease by 50%. Okay, they actually decrease by 50%. See? So these are some of the most important ones that have been recent PYQs with respect to physiological changes. See? But एक बार do go through the chapter of physiological changes. It is really important for exams, right? Limited है उतना ही करो. Okay, which of the following describes contracted pelvis? So ये आप सबके लिए you have to know all the above are criteria. So intertuberous less than 8, interspinous also less than 8, and obstetric conjugate less than 10 centimeters. Suppose they ask you with respect to diagonal conjugate, then the criteria will become less than 11.5. So if they ask you with respect to DC, then it is 11.5. Remember, DC is the only AP diameter of inlet that can be measured. अरे menstrual cycle hormones gynae में करेंगे अनुराधा, आज obs है बाबू. Okay, so AP diameter of inlet that can be measured is diagonal conjugate. अनुराधा देखो पता है ना, we have a separate T&D paper for gynae. And similarly in gynae also we'll start at 12 o'clock in the afternoon and I'll give you my whole day dedicated to you. Okay? Chalo. Okay, so this is important with respect to contracted pelvis. We've talked about other things about the pelvis already. I am trying to cover the things that I know that NEET PG people are fond of asking. Okay? Chalo. Which is true about perinatal infections? Rubella can be prevented by giving rubella vaccine in pregnancy. Is it true? No. Okay, not true. This is false. So please remember MMR, varicella. Okay, so MMR, varicella, HPV vaccines. बार बार NEET PG पूछता है. Are contraindicated in pregnancy. Okay, they are contraindicated. Doubt. Can you tell me if my patient has received rubella vaccine, for how long pregnancy should be avoided? Can you tell me? For how long the pregnancy should be avoided? Pregnancy to be avoided for 1 month. Okay, it's not 3 months. It is only 1 month, bacha. Okay? Okay. Also with respect to rubella, can you tell me in what POG will you see congenital rubella syndrome? If the mother gets infected in the early pregnancy or if she gets infected in the 3rd trimester. So if the mother gets infected at less than 16 weeks, only then she will have congenital rubella syndrome. If ever NEET PG people give you a newborn baby with cataract और कुछ पढ़ना ही मत, आंसर करना रुबेला, ठीक है? A newborn baby, cataract, and they are asking you which infection did the mother have? Answer should be rubella. Okay. What is the triad? Cataract, SNHL, and PDA. Patent ductus arteriosus. It can also cause pulmonary stenosis. But please remember, if they ask you when is transmission of rubella highest, तो फिर क्या आंसर करोगे? Transmission of rubella is highest beyond 36 weeks. Okay, so beyond 36 weeks. Is that clear? Transmission is more in the third trimester, but the severity is more in the first part of the pregnancy. ठीक है? चलो. Important points. Is breastfeeding contraindicated in HIV? No. So please remember, as far as our national guidelines are concerned, NACO guidelines, okay, we are supposed to address exclusive breastfeeding for a span of 6 months. Okay. In case NEET PG asks you contraindication for breastfeeding, what is the single best answer? Galactosemia. Okay, the single best answer is actually galactosemia. The other good answers are active herpes lesions on the breast and a case of untreated pulmonary tuberculosis. Right? So if the patient is a case of untreated pulmonary tuberculosis, these are like good answers, non-controversial. Infections are not contraindication. So not HIV, not any other infection, hepatitis B, whatever they might want to ask, CMV, they are not contraindications. Okay? Does CMV cause macrosomia? Okay, first, pehle option number C. Transmission of HIV is more in vaginal delivery. That's true. Okay, so this is a true statement. But despite this, what is recommended as per the NACO guidelines in HIV positive? Vaginal delivery is indicated. And NACO guidelines say cesarean is reserved for obstetric indications. See? Please understand, we have our national guidelines. This is what we have to follow. America wale, they follow viral load. Right? So, ek bari INICT ne pucha tha, what viral load is an indication for cesarean? So, if my patient has more than 1000 copies per ml, then yes, we say CS. But this is an American guideline, not an Indian guideline. We are not deciding mode of delivery by viral load. Okay, we are simply saying it is vaginal and cesarean will be reserved for obstetric indications. Now, coming to HIV and drug, I am sure you all know it is TLD and it has to be lifelong. It has to be started as early as possible. And given lifelong. Now please remember, chahe patient labor mein aaye, third trimester mein aaye, jab bhi aaye, whenever she comes, you're supposed to give her TLD. Is that clear? Right? Then please remember, invasive fetal monitoring should not be done in HIV. ARM should be avoided in HIV. Can you do oxytocin augmentation? Yes, actually you should accelerate the process of labor. So oxytocin augmentation can be done. So no invasive monitoring, no instrumental delivery. We have already talked about this. Okay? So these are other important things. Now coming to the controversy, and I am so sorry that it is a controversy, but I can't really do anything about it. As far as NACO guidelines are concerned, NACO guidelines very clearly say avoid delayed clamping. Okay, so they clearly say avoid delayed clamping. The problem is WHO says you should do delayed clamping in HIV. That's where the controversy is. But as I have said, we have to follow national guidelines wherever there are national guidelines. So NACO clearly writes अपनी guidelines में, avoid delayed clamping, do clamping when cord stops pulsating. अब ये बेवकूफी क्यों है? Because cord stops pulsating usually around 3 minutes, which automatically becomes delayed. But anyways, I can't really help it. These are exact terminologies used in the NACO guidelines, so we'll have to stick to it. So the answer will be avoid delayed clamping. ठीक है? Unless the MCQ says as per WHO, जो NEET कभी नहीं करता है, usually वो कौन करता है? INICT. So अगर WHO के हिसाब से पूछेंगे, then yes, it is delayed clamping. ठीक है? Is that clear? Also, HIV में somebody is asking me, why is transmission more in vaginal delivery? Because maximum transmission happens in the second stage of labor, beta. Right? So if the viral load is high, transmission will also be very high. Right? So please remember, maximum transmission of HIV will happen in second stage. So our goal should be to give this drug therapy and reduce the viral load, so transmission reduces. ठीक है? Is that clear? चलो. CMV causes macrosomia? No. So please remember, CMV के लिए हम क्या use करते हैं? Microcephaly. And what kind of calcifications? Periventricular. Okay? Periventricular calcification. Toxo क्या करता है बेटा? Hydrocephalus and generalized calcifications. Intraventricular, periventricular नहीं करता, वो generalized करता है. So you should know the difference between CMV and toxo. So one is periventricular, the other is generalized. ठीक है? ओके. इन्फेक्शन में INICT एक और पूछता है, वो varicella पूछता है. सो मे बी यू शुड नो दिस. सो प्लीज रिमेंबर, varicella का risk of congenital varicella syndrome can happen anywhere between 8 to 20 weeks, but maximum risk is between 13 to 20 weeks. Okay? And varicella क्या produce करता है? Skin scarring and limb defects. ठीक है? So skin scarring and limb defects is varicella. Also, AIMS has once asked about neonatal varicella syndrome. So this is different from congenital varicella. ठीक है? Congenital अलग है, neonatal अलग है. Neonatal होता है when the mother acquires infection 5 days before delivery to 2 days after delivery. एक बार AIMS में they have also asked about Zika. So with Zika you should know there is microcephaly caused by which mosquito? Aedes. So transmitted by Aedes, and it first infects Hofbauer cells in the placenta. Do you know what are Hofbauer cells? They are fetal macrophages. Okay, so Hofbauer cells are fetal macrophages. So INICT usually has asked about varicella, Zika, right? NEET PG, more likely rubella, right? So these are the kind of things that you should remember. Chalo. Okay. Heart disease in pregnancy, we've covered quite a few things. So let's look at the other ones. Cesarean delivery is preferred. It is false. What is preferred? Vaginal delivery. Okay? We say CS, again here also is reserved for obstetric indications. Okay? Then, warfarin is given for mechanical valves between 12 to 36 weeks. This is true. What do you do at less than 12 weeks? So less than 12 you will give low molecular weight heparin. At 12 you do a switch over from low molecular weight heparin to warfarin. ठीक है? Then 12 to 36 weeks she continues on warfarin. What do you do at 36? At 36 you again do a switch over from warfarin to LMW. Okay, so from warfarin to low molecular weight heparin at 36 weeks, which you will give till the onset of labor. So at onset of labor, you are supposed to stop anticoagulation. Right? When would you restart? You will restart anticoagulation at 6 hours after vaginal delivery and after 24 hours of CS. So cesarean के बाद we will restart at after 24 hours and vaginal delivery में we will restart after 6 hours. So this is with respect to anticoagulation in pregnancy, which is very frequently asked. Now please remember, although मैंने ऐसा लिखवाया less than 12 weeks LMW, but कभी-कभी exam will be more specific. So in case they are giving you the dose of warfarin, the answer changes. So please remember, if warfarin dose is less than 5 milligrams per day, less than or equal to, then can I continue warfarin in first trimester? Yes. So in case they have specially mentioned the dose, then they are asking you with respect to this. So if the dose is less than 5 milligrams per day, then we can actually continue warfarin in first trimester. ठीक? Also with respect to warfarin, suppose आपको change करना था at 36 weeks from warfarin to heparin, but patient goes into labor. So she is on warfarin and she goes into labor. Then you should know that this is an indication for cesarean, right? You cannot do a vaginal delivery while she is on warfarin, because all this warfarin is going to the baby and it will cause intracranial hemorrhage, right? So warfarin in labor, you're going to do a cesarean. Okay? Do we do invasive monitoring for all patients? No, it is hardly ever required. So invasive pulmonary catheterization is not required routinely. Is heart failure an indication to expedite delivery? No. So please remember, suppose they say your patient has mitral stenosis. I'm going to write it here. So suppose your patient has mitral stenosis and she goes into heart failure at 36 weeks. Okay. Then tell me, what will you do? So nothing. You have to answer it as admit and manage heart failure. Please don't answer it as induction, cesarean, whatever. No, no ARM, no induction, no cesarean. You have to simply manage heart failure, stabilize the patient. There is no need to deliver her or expedite the delivery. Okay? Is that clear? Okay. So these are some of the important things with respect to heart disease. Beta 6 to 12 में maximum teratogenicity होता है, right? You will change as soon as she comes to you and her UPT is positive. ठीक है? Okay. Now please remember, apart from warfarin in labor, what are the other indications for CS? So one I have told you is warfarin and she goes in labor. So she is on warfarin, she goes in labor. Apart from that, please remember, if your patient has refractory heart failure, which means patient is not responding to treatment, then yes, you have to do emergency cesareans. Okay, so in these conditions, you need to do an emergency cesarean. All the conditions where ejection fraction is low, right? जैसे मैंने पहले लिखवाया था, क्या लिखवाया था? Ejection fraction is low in conditions like coarctation, but खाली coarctation नहीं, coarctation with aortic valve, या मार्फन्स विद आयोटिक रूट, या फिर aortic stenosis which is severe not mild, है ना, या फिर aortic dissection. In all these conditions ejection fraction is low, so again we prefer to do a cesarean section in these conditions. So remember, normally we say we will do vaginal delivery in heart disease, but some specific conditions need cesarean, right? So either they are emergencies like warfarin and labor, or refractory heart failure, or they are conditions with low ejection fraction. ठीक है, कोई भी condition जिसमें अगर EF low है तो yes, we will prefer to do what? Cesarean and not do a vaginal delivery because they become high risk. Okay, question number 75 we have actually discussed quite a lot. It is simply about the steps of suction evacuation. It's an easy one, but it is a recent PYQ. So just to tell you that they are asking you basics, so you must know it, right? Otherwise, we've talked a lot about suction evacuation, so I'm not going to talk more. But were you all able to mark the correct answer in this one? So yes, the first thing you do is empty the bladder. Then you should do a PV exam to look for the size of the uterus, direction of the uterus. Dilate the cervix. What should you do before dilatation? Paracervical block. वो था नहीं पेपर में इसलिए मैंने नहीं डाला, but इससे पहले you have to give a paracervical block. Then you dilate, then you introduce the cannula, then you do suction. अच्छा मुझे बस यहाँ पे ये बता दो, what are indicators of that the suction evacuation is complete? Okay, procedure is complete. What are the indications? So number one, there will be reduction in the bleeding. Okay, so bleeding will reduce. ठीक है, what else will happen? You will see air bubbles. Yes, Dr. Sumay, these are a group of super bright bachas. They have been so interactive and बहुत अच्छे से पढ़कर आए हैं. And must say, I am very proud of each one of you sitting there and answering so well. I am very proud of each one of you. ठीक है? Right. So you will see air bubbles in the cannula and you will get a gripping sensation on the cannula. Okay. So we will also see a gripping sensation on the cannula. Feel. Right. Why? Because the uterus is contracting. तो ऐसा लगता है कि वो cannula को पकड़ रहा है. That's called as gripping. ठीक है, so these are markers that the procedure is complete. You turn off the machine and you remove the instruments. ठीक है, so these are very important. ठीक है, so now there is just one more image that I want you to see and then I think I can let you go because मैंने आज बहुत तंग कर दिया आप सबको खूब सारा पढ़ा कर, right? Okay, there is this one image and I feel कि बच्चे बड़े confused हैं इसलिए I thought I will actually give it in the class itself. Now please remember, this was a recent NEET PG question, therefore I wanted to clear it out. So when you talk about planes of pelvis, okay, right, when you talk about planes of pelvis, there are 4 planes, okay. There is a plane of inlet. So inlet is very simple, okay? It goes from upper border of symphysis pubis to the sacral promontory, okay? So from symphysis pubis upper border to sacral promontory, okay? This is very simple. Then plane of greatest pelvic dimensions is also very simple. ठीक है, सो प्लेन ऑफ ग्रेटेस्ट पेल्विक डायमेंशंस अगर आपसे पूछेंगे कि कहां से जाता है, सो यू हैव टू से इनर बॉर्डर ऑफ सिम्फाइसिस प्यूबिस, इनर सरफेस रादर, ओके, इनर सरफेस ऑफ सिम्फाइसिस प्यूबिस, ठीक है, एंड वेयर डज इट गो पोस्टीरियरली? इट गोज टू इंटरवर्टिब्रल डिस्क स्पेस बिटवीन व्हाट एंड व्हाट? बिटवीन S2 एंड S3, ठीक है, तो ये भी बहुत आसान है. फिर आता है प्लेन ऑफ लीस्ट पेल्विक डायमेंशंस. Now plane of least pelvic dimensions passes from lower border of symphysis pubis. Okay, where does it go, bacha batao? So lower border of symphysis pubis, and then it goes to the ischial spines, and then where does it go posteriorly? Posteriorly it will go to lower border of S5 vertebra. Okay, so lower border of S5 vertebra. ठीक है, लास्ट सेक्रल वर्टिब्रा. ठीक है, परफेक्ट, ये भी आप सबको आता है. व्हाट आई वांट यू टू नो इज प्लेन ऑफ लीस्ट पेल्विक डायमेंशंस कॉरेस्पॉन्ड्स टू, ये एमसीक्यू आएगा. ठीक है, इट कॉरेस्पॉन्ड्स टू ऑब्स्टेट्रिक आउटलेट. ओके, एंड इट ऑल्सो कॉरेस्पॉन्ड्स टू प्लेन ऑफ मिड पेल्विस. ठीक है, so it corresponds to the obstetric outlet and it also corresponds to the plane of mid pelvis. ठीक है बेटू, clear? What is the last plane? The last plane is plane of anatomical outlet. Okay, so plane, this is the fourth one. So fourth is the plane of anatomical outlet. ये कहां से जाता है? Lower border of symphysis pubis, then ischial tuberosity, right? So lower border of symphysis pubis, then it goes to ischial tuberosity. Posteriorly कहाँ जाता है बेटा? हाँ, अभी नहीं करोगे, मैं सिखाऊंगी ना, नहीं करोगे गलती. Posteriorly जाता है tip of coccyx. नाउ अब मेरी बात ध्यान से सुनोगे सारे बच्चे, ये लास्ट बात है. ठीक है, फिर हम जाएंगे एंड आई लेट यू गो. नाउ अगर आप ये 4 प्लेन्स याद कर लो, उसके बाद मुश्किल नहीं है. इसमें भी 2 तो बहुत ऑब्वियस ही है, इनलेट वाला और आउटलेट वाला. आउटलेट का प्लीज टिप याद कर लो. एनाटॉमिकल आउटलेट का पीछे है टिप ऑफ कॉक्सिक्स. अब मेरी बात सुनो. इफ आई आस्क यू व्हाट इज द स्पेस, ओके, इफ आई आस्क यू, डायग्राम देखो, and if I ask you what is this area between plane of least pelvic dimensions and anatomical outlet, can you tell me? The answer is obstetric outlet. ठीक है, so this 3-dimensional space. ठीक, so ध्यान से सुनो मैं क्या कह रही हूं. मैं कह रही हूं space between plane of least pelvic dimensions and anatomical outlet. इस 3-डायमेंशनल स्पेस को क्या कहते हैं? दिस इज ऑब्स्टेट्रिक आउटलेट. मतलब ऑब्स्टेट्रिक आउटलेट का रूफ, ओके, रूफ है प्लेन ऑफ लीस्ट डायमेंशंस और फ्लोर है एनाटॉमिकल आउटलेट. क्लियर? इतना क्लियर हो गया? थम्स अप दे दो अगर क्लियर हो गया तो. इसी तरह से अब मैं अगर पूछूं व्हाट इज द स्पेस बिटवीन प्लेन ऑफ लीस्ट पेल्विक डायमेंशंस एंड ग्रेटेस्ट पेल्विक डायमेंशंस, अभी क्या आंसर होगा? अब आंसर हो जाएगा मिड पेल्विस. मतलब मिड पेल्विस का रूफ है ग्रेटेस्ट पेल्विक डायमेंशंस और फ्लोर है लीस्ट पेल्विक डायमेंशंस. ठीक है, सो दिस 3D स्पेस इज एक्चुअली कॉल्ड एज मिड पेल्विस. इसका मतलब, ओके, इसका मतलब ऑब्स्टेट्रिक आउटलेट में पीछे क्या है? पोस्टीरियरली बॉडी ऑफ कॉक्सिक्स. टिप नहीं है बेटा. टिप किस में थी? टिप थी एनाटॉमिकल आउटलेट. ऑब्स्टेट्रिक आउटलेट में क्या है? बॉडी ऑफ कॉक्सिक्स. कैन यू टेल मी मिड पेल्विस में पोस्टीरियरली क्या है? क्या होगा? वर्टिब्रास विच आर 3rd, 4th and 5th sacral vertebras, right? So 3rd, 4th and 5th sacral vertebras. Is that clear? So आपके नीट पीजी में एमसीक्यू आया था, ये जो येलो एरिया है इसको अगर मैं डॉट 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 बना दूं, ये क्वेश्चन आया था. क्वेश्चन था दिस मार्क्ड एरिया कॉरेस्पॉन्ड्स टू व्हाट, राइट? दिस मार्क्ड एरिया कॉरेस्पॉन्ड्स टू व्हाट? तो व्हाट इज द आंसर? द आंसर इज मिड पेल्विस. दिस वॉज द क्वेश्चन, राइट. सो ये मार्क्ड एरिया आया था और आपसे पूछा था बताओ ये क्या है, तो आंसर क्या है, मिड पेल्विस. इज इट क्लियर टू एवरीवन? ठीक है. सो एनाटॉमिकल आउटलेट में पीछे है टिप ऑफ कॉक्सिक्स, ऑब्स्टेट्रिक आउटलेट में है बॉडी ऑफ कॉक्सिक्स. ठीक है. सो आपने क्या करना है, आपने सिर्फ पहले 4 प्लेन्स कर लेने हैं, उसके बाद एवरीथिंग इज वेरी सिंपल, राइट. लेकिन कंफ्यूज नहीं होंगे. अगर एमसीक्यू है प्लेन ऑफ मिड पेल्विस corresponds to what, then it corresponds to plane of least pelvic dimensions. ठीक है. चलो, इसी के साथ हमारी तपस्या एंड होती है. सो इट वॉज अ लॉन्ग डे, बट आई थॉट आई शुड गिव whatever best I can to all of you, right? So it was an absolute pleasure, and I can say this from the bottom of my heart that you people have done exceedingly well. You have proved to be great. आपने बहुत अच्छे से पढ़ाई की है. You were very active, you were interactive, you were not tired. I mean हो गए, but मुझे नहीं बताया. So I think this is absolutely amazing. So I'm going to clap for each one of you for putting in the kind of efforts that you are putting. And I'm going to thank you with folded hands to, make me a part of your journey. I know what that means for you. आपके लिए वो बात बहुत important है. Believe me, मेरे लिए भी important है. And that is why I tried my best from whatever I could in the time. I've also taken extra time so that I can give you my best, right? So, lots of love, lots of good wishes, lots of blessings to each one of you. I hope, have you all joined my Telegram channel? Do you know that I have a Telegram channel? Yes? So do you know that I have a Telegram channel? Okay, so I'm going to just write my Telegram channel, and all of you can join and you can keep asking as many questions. And on my Telegram channel, I run a quiz every single day. Sometimes 5 questions, sometimes 10 questions. And then I also put audio explanations to that. So you can all join the Telegram channel, right? And I'm just going to write it. So you can actually search me with this name. Okay, so OBGYN, Obs-N Gynae with Dr. Deepti Behel. Okay, so just search me with this name, Obs-N Gynae with Dr. Deepti Behel, and join the channel. I will put the link also if you want, okay, in the chat. ठीक है, ताकि in case you want to use, then use it. Now coming to some things that I want to say to all of you. See, what happens is motivation will stay for some time, and then you have these down phases. So what actually helps you to bounce back in life is not motivation. What helps you to bounce back in life is your consistency. Okay? मैंने एक बार ये Instagram में भी बोला था कि सक्सेस के लिए what are the 2 most important things. So the first important thing is truthfulness. Okay, which means जब भी आप पढ़ाई कर रहे हो, you are truthful to your efforts. You are not just there because you have to be there, but you are truthfully trying to do the best you can. So if you are truthful about your efforts, about what you want in life, believe me, only good things are going to happen. The outcome is going to be good. The second important thing is trust. Trust in what? Trust in yourself. Trust that you have immense capabilities. You are very, very talented. Trust that you have some great things about yourself which will make you unique and special. Right? So tell yourself that no doubt that there are going to be some days when you are not your best, or maybe you are in your down phase, but have that trust that you can bounce back, and whatever you need is inside you, right? As they say, there is no secret really, right? It has to come from within. So remember these 2 things, और जब भी पढ़ाई करने बैठो ये 2 चीजों को हमेशा याद करो कि मैं अपने एफर्ट्स के प्रति ट्रूथफुल हूं और मैं अपनी एबिलिटीज के प्रति भी ट्रस्टफुल हूं. So I trust my abilities and I'm truthful to my efforts. Believe me, these are the only two things which will carry you forward in life, not just in examination, even otherwise. Right? So ये सब करो. कोई बात नहीं, रिविजन ऐसा लगता है कब करेंगे, तो प्लीज रिमेंबर दैट जब भी रिविजन करनी हो, प्लीज यूज योर टीएनडी पेपर. अपना टीएनडी पेपर लो, स्टार्ट फ्रॉम द टॉपिक दैट इज कवर्ड फर्स्ट, गो बैक एंड रिवाइज दैट फ्रॉम द नोट्स. ठीक है, don't start revision from the first page of notes to last page. Start from these topics, go retrograde to your notes and then do your revision. और इससे क्या होगा ना, इवन अगर आपको नहीं भी समझ में आ रहा है कि आपको मन कर रहा है सर्जरी रिवाइज करनी है, राइट, बट समझ नहीं आ रहा कैसे करो, तो इट्स वेरी सिंपल, जस्ट पिक अप योर टीएनडी पेपर, उसका कोई भी एक दो टॉपिक्स ले लो और उसको रिवाइज करो. व्हाट आई विल सजेस्ट इज that when you talk about revisions, you should do that every day for 30 minutes. Every day at night spend 30 minutes to revise something old. कुछ पुरानी चीज रिवाइज करो, और वो कैसे होगी? by using these papers in a retrograde manner. ठीक है, so don't worry about it. Also don't worry, in the telegram group I will also post a link which takes you to the chat group. तो मैंने क्या करा है, एक चैनल रखा है, एक चैट ग्रुप रखा है. चैनल में सिर्फ मैं ही अपने क्वेश्चंस डालती हूँ, सो दैट यू नो इट्स नॉट एडल्ट्रेटेड, कोई उसमें आलतू फालतू की चीजें ना हो, इट इज जस्ट हाई यील्ड रिविजन. ठीक है, एंड देन यू कैन ज्वाइन द चैट ग्रुप विच इज ओपन फॉर यू टू आस्क योर क्वेरीज, योर डाउट्स, एवरीथिंग, इवन इफ यू वांट टू आस्क एनी हेल्प फ्रॉम मी और यू वांट टू टेल एनीथिंग टू मी, राइट. सो आई विल डू दैट. हाँ जी, आज घर जाके सारे अपने पेपर को एनालाइज करेंगे. You will write in a plain sheet of paper what are the topics that you have done wrong and be very specific. हर पेपर के बाद आपको ये करना है, चाहे वो TND हो, चाहे वो GT हो, चाहे वो SWT हो. Start making a wrong diary, identify topics that you are doing wrong and try and revise those topics in a retrograde manner before you give the next GT. Okay, that's how the number of correct questions will increase. ठीक है, so it will happen. बिल्कुल, INI-CT के लिए अभी 3 महीने हैं एंड इट इज अ गुड इनफ टाइम. यू हैव टू डू अ कंसोलिडेटेड रिविजन. INI-CT PYQ का बाप करेंगे, INI-CT TND या ये वाला TND रिवाइज करेंगे रेट्रोग्रेड. ठीक है, और एंड में हम एक रिविजन कोर्स करेंगे, शायद एक नया एम्स कैप्सूल एंड मे बी समथिंग इन द DVT. बट अगर हम अलग से करेंगे एम्स कैप्सूल, दैट्स इट. सो दीज आर ओनली 3 थिंग्स दैट यू नीड. ओके, INI PYQ का बाप, योर TND पेपर, and a revision course that we will do towards the end, let's say a month before the exam. ठीक? So take care everyone. I think I should let you go now. It's been a long day for you, but thank you once again. Lots of love, lots of good wishes. Bye-bye. Yes, the PDF will be uploaded. Don't worry about it. ठीक है?